Yes, the only.
So good morning. I think we will start the second session of this meeting. And so the session will talk about pathogenesis of long COVID. And before to start, I want to inform you that Brent Appelman is still in the air and will be late, and his presentation is postponed until probably the end of the session. So let's start with the presentation of Roger Paredes, who is one of the organizers of this very interesting meeting. So Roger is worked before on HIV, as many other scientists work or researchers working on long COVID, and direct the AIDS Center in Barcelona, and so he will tell you today about long pathogenesis and asking what have we learned so far on long COVID. So, Roger.
So thank you very much. Thank you everyone for being here. Although I am an organizer, I'm actually surprised of the quality actually that we were able to of presenters and everyone. And I think it's very important that we start looking a little bit more deeper and scientifically on these very interesting but also very difficult topic. So I'm also very glad to co-chair this session with Dr. Morgan Bomsel. Okay, so these are my disclaimers here. So I will do a very quick overview of what we have learned. This will be a top-level review because there will be, I think it will be much more interesting than my talk, the talks that will come right afterwards. So very briefly, so the first thing that we have learned is that long COVID is a multisystemic post-viral disease that is affecting many organs in the body, almost every organ in the body, and going from the heart, lungs, immune system, neurological system, blood vessels, etc. And this is already, so this is a real disease. And the first thing we learned from this early study in 2022 is that long COVID is not going away. There's politicians and also people who make decisions on healthcare systems are wishing that this would go away, that this is something that would happen just for a while, but that's not true. And in this very interesting and very good work, it's already showing how many symptoms, but also the impact of all these symptoms actually improves, maybe initially, but then it goes up again. Showing that, well, personal activities, professional activities, social activities, morale, family, relationship with caregivers is getting worse over the time, and this is not living. So we have to do something. For the first thing that we focused a lot is in showing there is actual real organ damage, and I will not go into details. It's only 10 minutes, but I will just show you a few examples. So first is that in this review, in this paper from the Veterans Affairs group in the US, you can see how there's the risks of incident composite cardiovascular, but also neurological, gastrointestinal outcomes are increased. They are also, they come with a lot of disability. And yes, they are more likely to be seen in severely affected patients, but less and less, we're seeing less and less of those patients, luckily, thanks to vaccines. But if you, instead, we're seeing a lot of patients having a relatively mild disease. And of course, there is also an increased risk of all these outcomes in patients with mild disease. And that explains why in our clinics we are seeing mostly people with low, with a relatively mild acute disease. So the maths actually match. One example from our unit, we evaluated a number of patients, so up to 27% of our patients had chest pain, anginal chest pain. And when you test, when you actually do MRIs and you do adenosine MRIs, what you do see is that at least half of them have, and numbers were small, there are only 10, but the cohort is now much larger, and more or less we keep the same numbers. Half of them actually have subendocardial ischemia with normal coronary arteries. These are young women without other cardiovascular risk factors. The coronary arteries are normal, and still you see myocardial ischemia. Of course, you can find also myocarditis, because we all know that SARS-CoV-2 causes myocarditis. And yes, in a number of patients, you also have normal findings. But so it is the burden of subendocardial ischemia is pretty high. Of course, then another aspect that it's an objective measurement is the inappropriate sinus tachycardia. In this case, we evaluated in our long COVID unit led by Lourdes Mateo and others here. We found that inappropriate sinus tachycardia was present in about 20% of prospective long COVID subjects. And here you can see clear evidence. So this is not just something that patients are making up. Then we recently published a paper led by Gemma Llados, who's also here, showing that also the vagus nerve, for example, is affected. There's vagus nerve dysfunction in many different aspects. You can do ultrasounds in the neck ultrasounds in the vagus nerve. We're not saying that this is the only reason. We're not saying that this is the only factor. And of course, this paper is a cherry-picking exercise. So we pre-selected patients that were enriched in the possibility of having the vagus nerve altered. But we do see a number of structural but also functional changes affecting the vagus nerve, but also the phrenic nerves, for example. So one interesting aspect here is that when you look at patients with dyspnea and normal X-rays, for example, what you see is reductions in the maximum inspiratory and expiratory pressure. That is clearly a suggestion that the phrenic nerve and maybe other nerves are also affected. And we could go on, and I think that's not the point of this talk. So first, then, the first message is there's organ damage. This is a real disease, and I think that we need to highlight that, because many of our colleagues don't understand why we work in long COVID. And just because it's difficult, we should not stop there. And then in terms of mechanisms, and also will be a top-level review, this is a classical summary by Hannah Davis. So on one hand, we have immune dysregulation. We've seen that yesterday. We'll see more about this, possibly related with persistent viral replication to some extent and reactivation of reservoirs. Yesterday, there was a very nice paper from France showing that the macrophages, at least in early phases of COVID, can become at least one source of potential reservoirs. Also, another reservoir could be the gut, also the fat. So we're now everyone in the process of digging deeper and finding, looking at the different tissues and seeing what happens there. Autoimmunity is also very important, and immune priming, and we'll see that afterwards. And I think we are very lucky to have Dr. Teresia Pretorius here that will tell us more about blood clotting and endothelial abnormalities. Their group has also done amazing studies here. Finally, dysfunctional neurological signaling. So as I said before, the vagus nerve, phrenic nerve, and also central nervous system alterations. This paper is very, very nice by Zollner, also from 2022, showing that during acute COVID, actually SARS-CoV-2 uses AC2 receptors. AC2 are all over the place, and it's actually not the lungs, necessarily the cells in the lungs that are the ones with higher expression. Enterocytes can become infected very early and relatively easily. So it seems that at least in several patients, SARS-CoV-2 can remain in the gut, and in post-acute COVID-19. And this is data from 7 months after acute infection, but now there's data looking beyond that. You can detect antigen persistence. There's still a lot of discussion whether that's a live virus or not. It's a virus that's replicating or not, but at least the antigen is there. And in this paper, the presence of the antigen was clearly associated with fatigue, memory issues, loss of smell, and so on and so forth. As I said, systemic endotheliopathy. I will not go into details on the mechanisms, but what is really worrying also is this idea that into suspective angiogenesis. So actually, because of chronic ischemia and in small vasa, the vasa can then grow and then can become create obstructions that might be very difficult to solve over time. And here you have an electron microscopy of let's say a normal alveoli on the left and one on the right with endosuspective endotheliopathy. So endotheliopathy is very important. Of course, all the effects on the CNS, going from neuroinflammation, neuronal and glial dysregulation, dysfunction of neural circuits, cognitive impairment, but also the direct effect of even the SARS-CoV-2 MPRO is something that is very, very, very important. Autoimmunity is there. SARS-CoV-2 infection triggers autoimmunity. The issue with autoimmunity is that autoimmune antibodies actually target many different antigens around the world, around the body. So it will become a little bit difficult from my point of view now to turn this into an actionable test, but I think that we can discuss that later on. In this paper by the Yale's group, actually, when they did a tour de force looking at many different aspects, and I'm sorry the slides were moved here. What I wanted to show is that actually low cortisolemia levels are also affected, and actually they were one of the highest predictors of long COVID. So, and two more things that have come up. Mitochondrial dysfunction. Dr. Appelman will be telling us more at the end of this session. The mitochondria is actually altered by SARS-CoV-2 infection, and most recently we have this paper from Penn showing how serotonin reduction could actually be one of the mechanisms linking the different aspects that we've seen before, going from interferon responses to the vagus nerve. And finally, of course, it's always the microbiota. So the microbiota is altered very early during the SARS-CoV-2 disease. We know that these changes remain over time, and also they are able to cluster patients in, and more will have to be done in terms of the microbiota. So in conclusions, there's a simultaneous multifaceted pathogenic mechanisms, including viral persistence, immune dysregulation, autoimmunity, endocrine parameters, endotheliopathy, gut dysbiosis, and vagus nerve dysfunction. Let me finish by thanking the group led by Lourdes Mateo and also Marta Massanella, and also our collaborators in both with patients, the COVID persistent, and also Oxford. Thanks a lot.
So thank you, Roger, for this very clear review of all the symptoms and mechanisms of long COVID. We may take one or two questions in the room, if there are. There is a question online from Roy V, not sure. Is there a difference between LGE with cardiac MRI on post-COVID patient and patient with other diseases?
So what we've seen, I mean, in what the group by Lourdes Mateo has seen actually is that so subendocardial ischemia is present in young. I mean, not every patient develops heart pain, but those with chest pain, there's a group of them that have anginal chest pain. And what we've seen is that those patients are usually enriched in terms of myocardial ischemia. And they are young, like 40-year-old women mostly, without really other cardiovascular risk factors. And in that sense, they are different from the general population. And coronary arteries are always normal. So I think that anginal chest pain has to be taken very seriously. Adenosine stress MRIs cause pain. So this is not a good strategy to follow patients because they don't want to get a second one. But yesterday it was being discussed, for example, treatments like ibravadine or others are also very, very important. And what we find is that sometimes we start just putting those treatments without including patients in randomized clinical trials. And what I think we need to do is to really think about whatever we do in long COVID, do it in a randomized clinical trial scenario.
Okay, thank you very much. I think we have to move on to the next presentation. So Rezia Pretorius will tell you about long COVID and vascular dysfunction. Rezia is professor at Stellenbosch University in South Africa, and she worked on early inflammation biomarker and look at coagulation defect in long COVID, what I think she will speak about now. So Rezia.
Hello everyone, I'm delighted to be here and thank you for the organizers for inviting me to present this presentation. Which one is it? This one. These are my disclosures and interests and funding as well as IP. Then just a few of my collaborators. There are many, many more all over the globe, but this is just my close collaborators, Professor Douglas Cowell, Amy Proel from Polybio, many, many more, and also my team of research collaborators and students and workers in Stellenbosch University. Then just briefly my research focus. Over the few past years, I have been looking at inflammatory molecules that may cause pathological blood clotting, including those coming from both viruses and bacteria. And we have been interested in the effects of circulating inflammatory molecules on platelets, on red blood cells, as well as the clotting protein fibrinogen, which is the main clotting protein. We are also interested in development of novel methods to study clotting pathologies, and these include imaging flow cytometry, proteomics, and also fluorescent microscopy. Over the years, we've published many publications looking at these inflammatory molecules and their effect on the blood system and cells in the circulation. Then came along COVID. So just a brief background for those of you that might not perhaps know the circulating inflammatory molecule interactions with platelets. So platelets are very well known that they have numerous receptors on their membranes that can interact with each other, the platelets themselves with each other. They can interact with all of these inflammatory molecules via these receptors. They also play an important role in interaction with the endothelial layers, especially when there are damaged endothelial cells. So platelets are known to form complexes, not only with themselves, but also with other cells of the immune system in circulation. Pathological clotting, as I mentioned, is also one of the things that we study. Of importance is how proteins that are of inflammatory nature might interact directly with the protein fibrinogen. So if you look at the protein fibrinogen, it's usually supposed to be in a soluble form when you are healthy, and it changes into fibrin when there is a clotting necessity. However, in circulation and in the presence of inflammatory molecules like the spike protein, these molecules can directly bind to the fibrinogen molecule and change the structure. And as early as 2016 already, myself and my collaborator Douglas Kell showed that this changes due to binding of inflammatory molecules might cause the protein to change its structure into an amyloid shape. So we're not talking here about amyloid that we know in the brain of Alzheimer's and Parkinson's. It's an amyloid protein change in the blood, in the fibrinogen itself, and we have marked this with various fluorescent markers that bind specifically only to amyloid, and one of the markers that we use is theoflavin T, a well-known marker to identify amyloid protein. So just to return to COVID and long COVID, so we need to look at acute COVID to understand the clotting pathologies and the thrombotic endotheliitis that will result in long COVID. So if we look at what happens in acute COVID and then also translated to long COVID, there are numerous activation processes happening, particularly looking at the platelets as well then as fibrinogen, where there are these activation processes that activate and damage the endothelial layers. We know that from acute phase, but we also know that is happening in long COVID. So early on in the pandemic, we took blood samples when it was when everyone was in lockdown, and we studied and looked at the platelets, and to our surprise, we found numerous platelet hyperactivation and damage in acute COVID. Here you could see structural changes in platelets with the yellow arrows, where the platelets looked as if they've just exploded, and also interactions with red blood cells. And then we also found microclots. We did in that stage 2020, did not name it microclots. We only did that when we started looking at long COVID. And here you can see with the blue arrows where these microclots are just packed onto red blood cells and also glue together the red blood cells. So you could just imagine that in acute COVID, these samples looked very much sticky, and our reports from our clinical collaborators globally also mentioned the sticky blood in acute COVID. Then I mentioned previously we looked at studying the amyloid's nature of fibrinogen. So we also then obviously took the chance to look at this in our acute COVID samples. Here's just an example of healthy plasma, type 2 diabetes, and then of COVID plasma. So we simply added theoflavin T, our marker for amyloid, to platelet-poor plasma. We exposed it when it was freshly drawn from the patient. We exposed it, waited for 30 minutes, and put it into a fluorescent microscope. And here you can see even healthy plasma people who are healthy do have small abnormal areas in their fibrinogen. We see that in every single healthy individual. However, it's the size and the nature of these clots that might differ. Type 2 diabetes, we know they have inflammatory nature, and we also know many people suffering from type 2 diabetes have got a higher propensity to clot and form clots. We know deep vein thrombosis is very well known in this disease. To my surprise, in acute COVID, I could not believe what I was seeing in front of my eyes. The amount of these amyloid structures in the platelet-poor plasma were significant. It just lit up like Christmas trees. And then from that moment, we knew that there was something that we need to look into further. We also looked at the platelets, and just to just make sure that we are all on the same page, these platelets are exposed to two markers, CD62P, which is the pinkness signal, that's for P-selectin, a well-known platelet marker, and then PAC1, which is a glycoprotein marker that actually indicates that it is platelets that we are looking at. These platelets were also significantly hyperactivated. You could see a typical healthy platelet in a healthy individual, and from B to F, you could see the platelets from acute COVID. Because we were working with a fluorescent microscopy method, we decided that we need somehow to assist clinicians, not perhaps looking at research in such detail, to understand what we are looking at, because obviously we know microscopy is not the ideal type of method to try to look at quantifying damage. So we developed a platelet grading system where we said that one is when you have a healthy individual with little spreading, and in a healthy individual there should not be any clumping, so no clumping. And then 2, 3, and 4 is progressively the platelet damage that one would expect. Perhaps 2 you would find for the spreading in a healthy individual, 3 perhaps in a typical diabetes individual or someone with rheumatoid arthritis, and then 4 would be where we would find significant platelet hyperactivation in COVID. We also developed a microclot grading system based on the same type of criteria, where 1 and perhaps 2 might be in a healthy individual. 2, the grading system for 2 is perhaps someone that's older, perhaps a little bit more inflammation, and then 3, 4, and 5 were the huge microclots that we typically would see in a COVID population. So then we turned our attention, as most of us did, to long COVID. So very early on in the end of 2020, beginning of 2021, we had our first long COVID reports in South Africa. And we also looked at their platelets. There you can also see platelets still very much hyperactivated in long COVID patients that were at that stage. There wasn't even in South Africa a proper belief that there was something like long COVID. People weren't even recognized that it could happen. This is just an extremely badly activated micrograph of platelets in long COVID from someone who suffered from this disease for 3 years, still having significant platelet hyperactivation. We also used our scanning electron microscope analysis methods again to closely look at how platelets would look like. Here you could see on the left a healthy platelet, and on the right just massive platelet clumping together, breaking up, and absolutely not looking very healthy at all. And then once again, also in long COVID, we did again, as with acute COVID, found significant microclot formation. Here you could see how the red blood cells are just packed with clotting protein. And one can imagine that those red blood cells would not be able to fulfill their duties as they should by delivering oxygen to the organ systems. And one can just think that they can also clog these little red blood cell clump themselves, can clog up the finer capillaries, because they will definitely not be able to flow significantly well through the blood vessels. This is just a close-up of the red blood cell of a long COVID patient with the microclots just packed onto the membrane. And once again, if one look at this scanning electron microscope view of a red blood cell, one can imagine that the red blood cells would not be able to function properly when they are so severely impaired with microclots covering their periphery. Microclots in whole blood, we also looked at that once again in long COVID, and here you could see these clots it was simply just whole blood, a drop placed on a glass slide and prepared for scanning electron microscopy, nothing added. So this is straight from the patient, minutes after the patient had given the blood sample. So the questions that we sometimes get is, these microclots, are they also present in other diseases, and why haven't we seen them? Yes, they are. We have been showing that microclots are present in lupus samples, in obviously acute COVID, in rheumatoid arthritis, also in conditions like Alzheimer's and Parkinson's, in all diseases where there are clotting pathologies or coagulation pathologies noted, and all of these are well known for that. We also looked at the spike protein. In 2021, we added spike protein, the S1 part of the spike protein, to healthy blood, and we could induce, just by adding the spike protein itself, the S part, to whole blood and to platelet-poor plasma, we could induce significant platelet hyperactivation as well as induce microclot formation. So we do now, from that publication, we hypothesize that spike protein can actually have direct protein-protein interactions with fibrinogen plasma proteins as well as with the receptors on platelets. And here's just some other work from that publication where you could see how the platelets were just significantly clumped together, hyperactivated, binding to red blood cells was seen. And we also did a microfluidics analysis where we compared healthy plasma at the top, you could see it on the right, a COVID example where the clots flow through, and then the top sample exposed to spike protein at the bottom, we could induce significant microclot formation. With a team of US collaborators, we also looked at Omicron and compared that to the beta and the alpha, the older, more virulent variants, and we did recognize that in Omicron, the clotting pathologies were not as significant as we saw with the earlier variants. Interestingly, the platelets in Omicron samples were still significantly hyperactivated, and we could not see the difference between Omicron and the more virulent variants. And this is just an example of just some of our unpublished work that wasn't included in the paper, where we looked at the platelets from Omicron patients. Now, we also turned our attention to proteomics. So proteomics, we used MS, mass spectrometry, and we followed the usual processes where one would digest the sample, the protein sample, with a single trypsin digestion step. Unfortunately, we could not digest all the plasma clots in the acute phase as well as the long COVID samples. We could not digest our protein with a single trypsin digestion step. We had then developed a second trypsin digestion step, and only then did we successfully digest the clots. And we looked at, after the first digestion step, we looked at the microclots, and we still saw that in acute COVID and in long COVID, we did not digest the clots. However, we also compared it to healthy and to type 2 diabetes. We indeed could digest the plasma with a single trypsin digestion step with in the controls in the diabetes, but not in the acute and the long COVID. The second step, we could digest everything, and then when we did our proteomics analysis, we were surprised to find, or perhaps not so surprised, I think, we found numerous inflammatory molecules, von Willebrand factor, C-reactive protein, some of the complements, plasminogen, fibrinogen, obviously, because we're looking at the clots, but also a molecule called alpha-2 antiplasmin. That immediately drew our attention. And if you look at the clotting cascade here, which I'm not going to go into detail, but just focusing on where alpha-2 antiplasmin have got a function, it actually blocks clot breakdown. So now we had a reason why we see the clots in circulation that are not breaking down. In 2022, we did a further analysis, proteomics analysis, with a much larger sample. This is also what we again found. All the molecules in the first experiment were there. What we also now found was numerous antibodies entrapped inside the microclots. We published it, and we're not a immunological group, and we did send it to some of our collaborators, and we still do not know exactly what all the immune antibodies that we have been finding in the clots, what they actually mean. So it would be great to study that further. So now the question arose, is there another way that we could try to give clinicians some assistance, pathology labs, how to identify these microclots in circulation? And luckily there were. We found a place for flow cytometry, in specific imaging flow cytometry. So in the beginning of the year, we received a crowd-funded and supported by Polybio as well as Balvi Foundation. We received our imaging flow cytometer, and we developed a method to look at microclots in a cell-free method in cytometry, with flow cytometry. We know that flow cytometry is usually used for looking at cells, and we removed the cells, we used platelet-poor plasma, and we could indeed find significant differences between our controls and our long COVID. We used our marker for it, theoflavin T, and we are in the process of looking at other markers, endothelial markers, other amyloid markers, and also biofilm markers in using flow cytometry to better quantify and classify the microclots. And here you can see some data from our recently published paper on our method. Now, we also looked at other possibilities, automated systems for microscopy. We are busy with a meta-systems automated analysis for platelets, which turned out to be quite difficult because these clumps are quite huge. The platelet clumps are quite huge, but we could find a method. We developed a method. We're still working with meta-systems also to try to see how we can further work on the Z-stack and to get all of the information. And we're also busy looking at the meta-systems automated microscopy system for microclots. However, the flow cytometry, I think, is a much better method because many pathology labs have got that. So let's quickly look at the bigger picture in the last few slides of microclot presence. What do we know? We do know that they are widespread in all chronic inflammatory diseases. We have found them ourselves in Alzheimer's, Parkinson's, rheumatoid arthritis, and many more. We do know that they can be stained with fluorogenic dyes, such as theoflavin T and also the amitractor dyes. And we do know that they are resistant to the normal process of fibrinolysis. And ourselves have found alpha-2 antiplasmin as possibly one of the mechanisms that prevent clot breakdown. And we do know that we can actually induce them in vitro by adding spike protein to healthy blood. And we do know that we can also induce other kinds of microclots by adding bacterial lipopolysaccharides, LPSs, lipoteichoic acids, even estrogen and other inflammatory molecules. If we add that to whole blood, we can induce other forms of these microclots. And interestingly, and that's why I say other forms of microclots, interestingly, we believe that these microclots can exhibit considerable structural and even spectral heterogeneity, reflecting the molecules that were bound to them in the first place. So a variety of possible changes might happen due to the polymerization process. So microclots and endothelial damage, we think point to heterogeneous and complex disease pathology. It is not simply a size or numbers of the microclots present in healthy and long COVID or any other disease, but it's also their content, their activity, and the biochemical characteristics that we must look at. And we cannot forget the activated, hyperactivated platelets. Ultimately, we believe that these two pathologies drive thrombotic endotheliitis in long COVID. The next steps in my last slide, we are still continuing research with all interested collaborators all over the world, so I extend an open door to you here. If you want to join us in finding answers, please do. We have got commercial endeavors because we do believe that the imaging flow cytometry and microscopy need to get to the patient where it's needed the most. We are determining ranges of microclot presence. We are doing a third proteomics analysis to identify more markers, and hopefully there will be some clinical trials looking at anticoagulation in the US as well as the UK, and then we are busy with numerous grant applications. And then I just want to, before I end off, just remind you, perhaps you have seen it, there's a wonderful piece of research out from Scottish collaborators that show that they followed 1.1 million COVID patients over a few period of months, years, and they determined that the only thing that prevented these patients from going into long COVID after they had acute COVID was the usage of anticoagulants. So we do believe there's a place for anticoagulants to treat at least the endothelial pathology in long COVID. Thank you.
Thank you, Rezia. Are there some questions? Yeah.
Thanks. That was really a terrific talk. I have two quick questions. One, both related to spike protein. So you showed that spike protein can be associated with fibrin and change its structure. So do you think spike protein continues to be present and is causing the persistence of the abnormal coding of erythrocytes? And the related question is there some connection here with the thrombosis that's seen with vaccination, which has really been limited to the adenovirus-associated vaccines, even though all vaccines are based on spike?
Yeah, that's a wonderful question. Thank you. So yes, we have published a paper with a lot of collaborators in Nature Immunology where we discuss viral persistence. And we do believe that viral persistence might be one of the reasons why we see these persistent microclots forming and that they are still present in the circulation 3 years or more after the initial acute infection. We also are thinking of the fact that there might be spike persistence, but that we haven't really looked into great detail, but there are some collaborators that think that spike persistence might be something driving it. So definitely viral persistence we need to look at, and we probably need to look at antivirals for treatment in individuals with viral persistence. And then your last question on the fact that we see vaccine injury and spike. Yes, I do believe that vaccine injury is very crucial for looking at coagulation. We are actually currently busy with a study in South Africa where we are looking at the effects of vaccination and vaccine injury. We did a very small pilot study where we looked at individuals who had the vaccine. We looked at, in South Africa, we have got Pfizer, and we also have Johnson & Johnson. We looked at a combination of individuals, healthy individuals, before and after their vaccination. We noted that their coagulation profiles went up for about 2 weeks. They had microclots in circulation, they had platelet hyperactivation, and then after 2 weeks it tapered down and their coagulation returned to health. So I do think there's a place to study coagulation with regards to the vaccines, and not only a variety of vaccines. We need to look at all vaccines, not only one or two.
So, thank you. We are all looking for biomarkers. Do you think that grading in microclots you described could stratify the long COVID patient? And do you have did you look at a correlation between this various size of various grading of microclots and some specific, more or less specific, or different specific symptoms that Roger just clearly described before?
That's a very interesting question. We do think that microclots, as well as platelet hyperactivation, should be considered as two of the main diagnostic criteria, not the only, because obviously there are many more. We do know that there are immune dysregulation and viral persistence in all of the other things that we are going to talk about today as well and hear about today. So we definitely don't think microclots at the beginning or the end of why we get long COVID. We think it's a whole process of various things happening, and we do think that a grading system needs to be developed to look at if there are certain some of the symptoms, that certain symptoms show up as higher reason for microclots. What we have been looking at, and we looked at probably just over 1,000 patients from our clinical collaborators, where we looked at the patient's symptoms as well as the presence of microclots and platelet hyperactivation. At this stage, we cannot see that different symptoms have lower or higher microclot presence. But that's, we need to look at it more carefully using our flow cytometry with many more numbers. So that is definitely a good idea to look at.
Okay, so thank you. I think we have to move on to...
So then there's maybe a question there, number 2. We have time for another question? No, we have to.
So I'm sorry. The organizer just told us that we should stop question. I'm sorry. You will have time to discuss just in the break, I guess. Do you present, Lisa?
Yes, so I'm really glad to present Dr. Lisa Chakrabarti from Institut Pasteur, and she will tell us about SARS-CoV-2 adaptive immune responses in long COVID. Super interesting topic. Thank you. Merci.
Good morning. So it's a pleasure to be here. I thank the organizers for the opportunity to present our studies on T-cell responses in long COVID. These studies were done in the frame of the Persicot study at Institut Pasteur and in close collaboration with the team of Dominique Salmon-Serron at Hôpital Hôtel Dieu in Paris. I have no conflict to declare. We have seen this slide already, so I won't go into the different possible mechanisms. But what I wanted to emphasize is that all of these mechanisms, it's quite striking that they may either imply an insufficient immune response that would enable viral persistence, this dysbiosis, and the reactivation of herpes viruses. I will try to use a pointer, please. Could I have a pointer? No, I think I was told to point here. It's not really pointing. Yes, it does. Okay, but I just... Okay, so either, it's not super easy, either an inefficient immune response with viral persistence or reactivation, or an excessive immune response that would drive low-grade chronic inflammation and the associated clotting abnormality we just heard about, or neuroinflammation. So there is no consensus. What is clear is that in acute COVID, the timely appearance of adaptive T-cell responses is important. Here, in a classical mild COVID infection, you can see the rise of the viral load, and then the induction of the innate response is the purple curve, followed by the appearance of specific T cells and B cells, which will help drive down not only the virus, but the innate inflammation. Now, if the induction of specific T cells is delayed or absent, then the virus goes on unabated and the inflammation persists too. And importantly, the group of Shane Crotty, Antonio Bertoletti, and Malameni have shown that delayed induction of T cells in the acute stage is associated with severe COVID. Now, in long COVID, it's less clear. There have been several groups pointing to an excessive immune response in long COVID. For instance, Files et al. Have found the persistence of a high frequency of specific CD4 T cells directed to SARS-CoV-2. Cheon et al. Have reported that the presence of resident CD8 T cells in lung tissue is inversely correlated with lung function. But these two studies were mainly done in hospitalized patients. Also, the group of Nina Babel has reported the presence of highly differentiated TEMRA CD8 T cells in long COVID. Recently, the group of Akiko Iwasaki has reported the presence of higher antibody not only to the spike, but also to herpes viruses in long COVID. Also, they found signs of aberrant T-cell engagement, for instance, increased cytokine secretion upon PMA ionomycin stimulation. In addition, the group of Nadia Rohn has reported signs of CD8 T-cell exhaustion, but also the presence of CD4 T-cells, specific CD4 T-cells, which are poised to migrate into tissues because they express certain chemokine receptors, such as CCR6. And again, they have found increased antibody to the spike in long COVID. On the other hand, at least 2 groups have reported that low antibodies to the spike early on in the acute stage is associated to a higher risk of long COVID later on. These are the groups of Clara Lehmann in Germany and Marmasia in Spain. In addition, Hu et al. Have shown that people with low IgG to the spike have an increased risk of showing reactivation of the virus in the following 2 months. The group of Pierre Corbeau has detected CD8 T cells with lower perforin content in the acute stage, and this was associated with a higher risk of long COVID. And last, it has been shown that when the virus breaches the epithelial barrier and goes into the circulation, this is also associated with a higher risk of long COVID. So there is no consensus between signs of excessive or insufficient adaptive immune responses. So we felt this deserved further investigation, and to do so, we launched the Persicot study. So it was based on the recruitment of 51 patients at Hôtel Dieu by Dominique Salmon. And these patients had either documented SARS-CoV-2 infection or at least 3 symptoms of COVID in the acute stage. They were infected for at least 3 months, but actually the median time to onset of symptoms was rather close to 1 year. So these were long-term, long COVID. And they were not hospitalized. They were compared to a group of individuals with resolved COVID who had documented infection and no reinfection, and to a group of healthy donors who had no signs of COVID. And importantly, all these volunteers were sampled before they were vaccinated so that we could study their adaptive responses to the infection and not to the vaccine. It's important to point out that among the 51 long COVID patients studied, 23 were seronegative. They had no antibody to the spike. We chose to study these patients because they represented up to 1/3 of the patients in Dominique Salmon's cohort, and also because they have not frequently been included in physiopathological or clinical studies, because often their infection is not documented. For instance, most of the patients we studied were recruited in 2020 when PCR was not widely available, and they have no antibodies. So they have no laboratory test often to document their infection, and these patients often have trouble to access medical care. But when we look at their spectrum of symptoms, as shown here, the seronegative long COVID patients, or LC- group in orange, their spectrum of symptoms was quite similar to that seen in seropositive long COVID patients, as can be seen here. They even tended to have a few more symptoms. And an interesting difference was that, if I can point here, they tended to have more fever and chills than the seropositive patients. And possibly that could point to viral persistence, induction of interferon, but this remains to be demonstrated. So we chose to study these patients too. And initially, they were defined as seropositive or seronegative based on an ELISA done at the hospital for the spike proteins. But we chose to retest their antibodies with a more sensitive assay called the S-Flow, developed by the team of Olivier Schwartz. This assay consists in incubating HEC293 T cells that express a high level of the spike with the patient sera, and then with a secondary antibody. And then the cells are harvested and analyzed by flow cytometry. So the percentage of IgG positive cells is very well correlated to the amount of spike-specific antibodies. And it's a little more sensitive, and also it reveals the antibodies that bind to the native form of the spike. Using this assay, we could find very few antibodies in the group of healthy donors, a high level of IgG specific to the spike in the group of seropositive long COVID patients, LC+, as high as that found in the group of recovered individuals. And as expected, the responses were low in the group LC- of seronegative long COVID patients, but with this more sensitive assay, we found a few individuals with actually detectable antibodies. And the pattern was the same when we analyzed IgA. Equivalent responses in the LC- and RE groups, and a few responses in the LC- group. So what was interesting was that the distribution of IgG was not continuous. We had mostly patients with low response or high responses. So that's why we call them divergent responses. And we asked whether this was the same for antibodies to other proteins of SARS-CoV-2. So we measured by Luminex the antibody responses to the nucleocapsid here and to the matrix and envelope here, and they were correlated to the antibody to the spike in the x-axis. And you see an overall very good correlation between the antibodies to these different viral proteins. So the patients who were seronegative for the spike, they were also seronegative for the nucleocapsid, the matrix, and the envelope. So we really had these divergent responses. We also looked at their antibody responses to common cold coronaviruses, and we found basically no major differences between the patient groups. There was a trend for higher responses to the OC43 spike in the long COVID patients and the recovered patients as compared to the healthy individuals, but we think this may be due to the cross-reactivity of antibodies specific to the SARS-CoV-2 spike, which also bind a little to the OC43 spike. Then we looked at their T-cell responses, and to do so, we used the most sensitive assay we had available, which is to generate primary CD4 T-cell lines. So to do so, we take the PBMC of patients, we stimulate them with mini pools of long peptides, and then we grow these cells for 2 weeks in the presence of IL-2, and at the end of these 2 weeks, we re-stimulate them with individual peptides. And we measured cytokine production by intracellular cytokine staining. You have here TNF-alpha measured in the y-axis and interferon gamma in the x-axis. On the top line, you can see examples without peptide re-stimulation. We see little cytokine production. On the bottom line, you see that the healthy donor on the left does not make much cytokines, neither TNF nor interferon gamma. The long COVID patients in the middle, the seropositive long COVID patients, has a strong cytokine response with double positive cells that make both TNF and gamma. And the seronegative long COVID patients has a low but significant response. And this is interesting because these patients had undocumented infection. So we think by using these sensitive T-cell assays, maybe we could help document their infection. And that may be useful in terms of diagnosis, because often these patients have more difficulty accessing medical care. So these are the results shown for the 3 matrix peptides we studied. You can see one peptide gave few responses, one peptide, and the 2 other matrix peptides were quite immunodominant, with responses in over 90% of seropositive long COVID patients, even though these patients were not selected for a particular HLA-DR. I think I need a little water. So sorry. And then, so you can see that responses were equivalent between the LC plus group and the RE group. Thank you very much. Even with a trend for higher responses in the LC plus groups. And as expected, the responses were low in the HD groups, and they were low also in the LC minus group, with a few individuals that may show some responses. But one has to be careful because there were also a few responses in the HD groups due to cross-reactivity with common cold coronaviruses. Now, if we look at the interferon gamma production, the overall pattern is the same, but this cytokine is interesting because it's cleaner in terms of background in the healthy donor group. So we can say with more confidence that the few responses we detect in the seronegative long COVID patients are actual responses. So we do confirm that we have a few responses in the seronegative long COVID patient groups. And when we sum the responses analyzed for the 9 peptides tested, then we can see that indeed we have equivalent responses in the LC plus and RE groups, and we have detectable response in a subset of the seronegative long COVID patients. So we do confirm these divergent responses in the 2 long COVID groups with either strong or low responses to the viral proteins. If we look at correlations, roughly, I would say we had an overall correlation between antibodies and CD4 responses, as shown by the red color in that rectangle. But if we look into more details, we could see that when we compare the responses to the immunodominant M141 matrix peptide in the X-axis and the antibody to the spike in the Y-axis, we had these overall correlations. But if we look at the pink symbols, the seronegative long COVID patients, you see a few patients with T-cell response and no antibodies, and a couple of patients with some antibodies but no T-cell responses. So their responses are less correlated. To look at more in details at this group of seronegative long COVID patients, okay, we could find in the second column, I listed all the patients in yellow that had responses to at least 2 peptides in terms of CD4 responses. The third column is IgG to the spike, and the fourth is IgA to the spike. And you can see that patients who have CD4 responses, they are not necessarily those that have antibodies. Again, this notion of discordant T-cell and antibody responses. But if one considers the 3 criterion together, in this last column, we can see that 52% of the seronegative long COVID patients have signs, immunological signs of a previous SARS-CoV-2 infection. And if we add the criteria of a positive PCR or that of anosmia agesia, which is very indicative of a previous SARS-CoV-2 infection, then we can say that 82% of the seronegative long COVID patients have signs of a previous SARS-CoV-2 infection, and hence that they should be studied. To conclude, we found a similar spectrum of symptoms in seronegative and seropositive long COVID patients. The seropositive long COVID patients show antibody and CD4 responses as high, if not higher, as those of recovered individuals. Seronegative long COVID patients show low antibody and CD4 responses. However, the use of sensitive assays enables to detect immunological signs of a previous infection in half of these patients. And they show a poor coordination of the humoral and the cellular adaptive immune responses to SARS-CoV-2. So we conclude that we have divergent immune responses that define two types of long COVID with either strong or low adaptive immune responses to SARS-CoV-2, which may point to at least two distinct etiologies underlying long COVID. I have not much time to speculate about these etiologies, so I will just briefly say that for the seronegative long COVID patients, clearly they have suboptimal adaptive responses, and this may enable possibly viral persistence and localized tissue damage. And also, since this will contribute to maintain an innate response, this would also drive inflammatory damage. For the seropositive long COVID patients, maybe it's just an excessive immune responses that contribute to inflammatory damage, but we cannot rule out that maybe they have a high response that is inefficient. For instance, with low avidity of antibodies or low TCR avidity, and that maybe also they cannot really contain the virus efficiently, and that then we are back to the same scenario as for the seronegative patients. I will stop here by acknowledging the people involved in this work, in particular Jérôme Kervévan, who did all the T-cell assays, postdoctoral fellow in my group, Isabelle Staropoli in the group of Olivier Schwartz, who did the antibody measurements, of course the clinical team of Dominique Salmon-Serron at Hôtel Dieu Hospital, Faroudi Boufassa, who is the methodologist of the study, and also our other collaborators in the teams of Hélène Perret, Michael White, Milena Hassan, and I thank all the volunteers who participated to the study. Thank you for your attention.
Any questions? Thank you very much for the wonderful presentation.
Yes, I may have a question. Do you see a difference in inflammatory marker in a long COVID patient with and without antibodies, as you mentioned it?
Yes, this is a very relevant question. These studies are actually ongoing. We are testing their plasma, their sera actually by Luminex and MSD assays. So we don't know yet.
Okay.
But I just wanted to make the point that we should also study these patients. So we will see.
Okay. So, and another question, your group of acute COVID were all positive for antibodies. So I don't know if it was samples taken during the acute phase or later on, because in your hand at least, maybe 10%, 15% of individual with acute COVID, but when viremia is not present anymore, were seronegative, and that was also a very striking issue for us.
Okay, so I'm glad to hear that you also find some seronegative patients. I should point out that the control group were patients who were not identified during acute COVID, but after they had recovered. We could not exactly match them to the long COVID patients in terms of duration of infection. Unfortunately, because we had to collect these samples very rapidly before they got vaccinated. So we do not have exact matching between the patients.
I think there are no more questions. So thank you very much.
So I think we will go on with Serena Spudish, who is a professor at Yale University, and she's an expert in neuropathogenesis in HIV for another person working before COVID on HIV. And she will now tell us about neuropathogenesis in long COVID. So Serena.
Thank you very much. It's a pleasure to see everyone and to meet some people for the first time and meet some people I've only known on Zoom for a couple of years. So I'm going to be talking to you, switching gears a little bit, focusing on the brain. We've heard about the brain being one of the organ systems that seems to be affected in many, many people with long COVID. And in some cases, it's the primary effect, and in others, it's within a constellation. And I'm going to really focus on pathogenesis. We're going to be hearing a more clinically oriented talk tomorrow. And then also I'm going to point out that I'm going to be talking about a study that includes many results, but some of the key results will actually be presented by my colleague, Lindsay McAlpine, later this afternoon in the abstract session. So in my mind, one of the key ways that we can learn about the pathogenesis of long COVID is to first identify what we know about acute COVID. And many of you may already know a lot of the details about how acute COVID affects the brain. But I'm going to do a review of that because I think that's the anchor of thinking about what processes might be in play in long COVID. So I'm going to talk about acute COVID first, and then neurologic long COVID, and then end with some questions about remaining directions and research questions. So in terms of neuropathogenesis of long COVID, well, as I think with all of the systemic aspects of acute COVID, we really began to learn about pathogenesis simply by seeing clinical patients. And I'm a clinical neurologist with Dr. McAlpine very, very early in the pandemic. We formed a consult service that was specifically looking at patients who were hospitalized with COVID who had neurological symptoms, not necessarily as their primary, but as part of their presentation. And we not only tried to treat these patients, but we did also try to learn from these patients. And one of the things that we did is we indexed the types of conditions that we saw in those first months of the pandemic in northeastern United States. And you can see here the sort of constellation of different types of symptoms that we saw in the first 100 patients on whom we consulted. And this is a mix of different kinds of things. And as a neurologist, having experience with treating a variety of different kinds of neurologic syndromes, many of these syndromes actually seem to be immune-mediated diseases. So things we would typically see as either acute inflammatory conditions or as things that could be autoimmune. We also saw a large percentage here, 26%, of people with acute stroke in the setting of COVID-19. And again, you've heard about that already, and we had a great talk about vascular pathogenesis. But this was something that was interesting and actually, in some ways, seemed to be a sort of different type of manifestation than the encephalitis and some of the other conditions that we saw. So this is consistent with reports from all over the world. Some of the best clinical studies of neurologic acute COVID came from the UK, where there were, because of their unified hospital system and their records, they were able to collect cases from throughout the country from many, many hospitals. And they did a number of sort of UK-wide surveillance studies. This was the result of one of their first studies that they published, which had 267 hospitalized patients who then were reported as having neurologic conditions. And they did the same thing that we did in terms of, as you can see at the bottom, the types of categories of conditions that they were seeing. Again, reminding everyone that this is a heterogeneous condition. There's not one neurologic acute COVID. The other thing they did that was really interesting is they actually categorized these different presentations based on the timing of the onset of symptoms, where 0 on this y-axis, is the onset of respiratory symptoms. And they found two different patterns, primarily. One was a pattern where actually symptoms either predated the onset of COVID-19, and that was typically cerebrovascular symptoms. People with stroke sometimes came in with stroke as their presenting symptom. And the other were people who had symptom onset about 14 days after the respiratory symptoms, suggesting again that that might have a different type of pathophysiology that was more of an autoimmune response. And we saw that for central inflammatory, psychiatric, and peripheral neuropathy conditions, which again, as a neurologist, we think of as being immune-mediated conditions. So this gave us some hints immediately that there were probably different kinds of pathogenesis happening. And so I'm going to show you now clinical studies that were conducted during acute COVID. Several caveats here. All of these clinical studies were done in hospitalized patients, and most of the studies that included things like CSF collection, cerebrospinal fluid collection, were done solely on people who had neurologic symptoms. So we don't have information about acute COVID-19 in the brain in people who had mild symptoms and weren't hospitalized. We also don't have information about people who didn't have any neurologic symptoms for the most part. Again, we were only able to do clinical lumbar punctures in people who had indications because of all the restrictions at the time. So this is a nice study out of Harvard that looked at 27 patients who had neurologic symptoms and had an indication for a spinal tap. This study was interested in looking for the presence of viral RNA and was also interested in looking for patterns of inflammation. Again, because many of these conditions seem to be immune-mediated, and also because we knew inflammation was such a critical part of acute systemic COVID-19. In this case, they found no evidence of RNA, SARS-CoV-2 RNA, by either PCR or metagenomic sequencing, but they did find evidence of CSF inflammation based on protein-based inflammatory markers in many of the people with COVID-19. So the acute COVID is the red on the far right in each of these graphs. And you can see that compared to controls, who were people, this was pre-pandemic controls who had no COVID, many of these markers had a high amount of inflammation and were elevated. And in some cases, they were elevated even more than West Nile virus or even HIV. So that was a very interesting hallmark finding, and this was also consistent with several other CSF studies at the time, which were smaller. And again, my colleague at Yale, Shelley Farhadian, also conducted a study based on some of the consult patients that Dr. Malkalpan and I had seen, where those patients had lumbar punctures for clinical reasons. She again found patterns of CSF cytokines that were different than people who had not had COVID, pre-pandemic controls, as well as different patterns that were seen in the plasma. And so a picture started to emerge a little bit that in these people with neurologic COVID, in the acute phase, there seemed to be almost a compartmentalized immune response that was different between the blood. She also found that there was no elevation in clinical measures, such as a white blood cell count or protein or CSF albumin ratio, which are markers of blood-brain barrier breakdown. But she did detect an increase in the frequency of B cells in the cerebrospinal fluid compared to controls. And when she investigated that further, she found that there was detectable SARS-CoV-2 antibodies in all of the samples that we looked at. And we also found that some of these SARS-CoV-2 antibodies were cross-reactive to recognizing brain tissue. So again, suggesting that at least in these people with these kind of acute neurologic manifestations during acute COVID, direct autoimmunity to the brain was a potential pathogenic mechanism. So inflammation, generalized inflammation, but also some targeted inflammation with antibodies and autoimmunity. So other studies have looked at autopsy tissue in acute COVID. Again, there's a lot of caveats with autopsy tissue. These were all people who were hospitalized, who had severe COVID, who died from COVID. And also, based on things like hypoxia, there can be changes in the brain at death. But a couple of studies have looked extensively for evidence of SARS-CoV-2 virus in the brain and found this in some limited numbers of samples. In this figure, the bottom section that shows the green and the purple shows the detection of SARS-CoV-2 RNA or protein in small numbers of these 43 samples that were evaluated from 43 patients. However, what you can see on this slide is that among all these 43 patients, there's a high degree of macrophage and microglial activation, as well as T-cell invasion, which is on another slide, which suggests that there's a lot of inflammation in the brain, a lot of macrophage activation. Again, with the caveats, this is consistent with the cerebrospinal fluid data. The other thing that I mentioned already was that we saw a high degree of strokes in our consult patients, and this was widely reported globally as a major complication of acute COVID-19. And again, with Dr. McAlpine and others have done studies that indicated that the strokes were not only related to increased thrombosis and clotting, but actually that there seemed to be endothelial activation and immune activation in the vessels that in people who had strokes with COVID-19 as compared to people who had strokes who did not have COVID-19. So again, that the mechanisms included this endotheliitis. And microvascular injury was also seen in autopsy studies that showed leakage of fibrinogen from blood vessels and showed other kind of injury to microvascular changes in the brain in people who died from long COVID. This study did not find any evidence of virus. Finally, there's a lot of evidence, and we saw some already from NFL, from one of the talks, I think last night, that there is evidence of acute neuronal injury during acute COVID-19. So again, people who had symptoms during acute COVID, who had spinal taps, had elevations in neurofilament light chain, which is a neuronal injury marker, in the spinal fluid, and also actually leaking into the blood. And this study shows also that over days since the onset of COVID-19, the NFL is actually rising. We often see this, we see the same thing in acute HIV, that actually with more exposure to inflammation, you have some increasing damage to your neurons. So this sets the stage for wondering what is driving this. And we see inflammation. We have shown that you can detect antibodies, but nobody has shown really consistently that you can detect RNA. However, this nice study from the Swedish group, which we collaborate with, and they do fantastic work, did find detection of SARS-CoV-2 nucleocapsid antigen in people with acute COVID-19, whether they were symptomatic or not, compared to controls. And they found really almost no evidence of spike antigen. So antigen seems to be detectable in the central nervous system without clear evidence of replicating virus, and maybe is one of the drivers of neuroinflammation. So this is a schematic. I'm not going to go through this from a review paper that we wrote pretty early in the stages of trying to understand long COVID, which is basically mentioning all these different mechanisms and suggesting that there is neuronal injury, but the mechanisms really directly causing that are unknown, and that there may also be some unknown host factors for susceptibility for these conditions. And I think that's something that needs to be further studied. So really what we're supposed to be talking about is neurologic long COVID. I will say there's much less evidence and there's much less data on this topic, partly because we heard last night that there's been sort of a diminishing interest in really studying this as an urgent question. And it's difficult to set up really large multi-site neurologic studies that do really in-depth work. I'm going to show you basically some hypotheses for pathogenesis, and I'm going to show you some data from a study that we have at Yale and mention some of the other studies that have come out. So again, putative mechanisms for nervous system post-acute sequelae of COVID-19, essentially the same things you've been hearing across all the organ systems, and which you heard about earlier in Dr. Paredes' talk. So is it generalized inflammation with trafficking of immune cells, cytokines, antibodies into the brain, and activation of microglia? That's something that we know is happening in acute COVID. Is that prolonged and persistent or even emerging in long COVID? We know there's antibody production, including anti-SARS-CoV-2 antibodies. We've now shown that actually in long COVID, but we don't know as much about whether autoantibodies are persisting. Vascular dysfunction, again, this is something that we can see in acute COVID. How much of that is at play? I think this has been under-recognized in most studies of neurologic long COVID, and it's something that we're really interested in. And then, of course, persistence of virus, and this has been something that's been a driver of thinking about the work and also the approaches to treatment. And then the other question is there ongoing neuronal injury in people who have long COVID, or are we seeing the result of something that happened and now a legacy effect in people who are affected? So this is an introduction to our long COVID study. Again, it's directed by Dr. McAlpine, Dr. Farhadian, and myself. And we're really using a panoply of different tools to try to study the brain in humans with long COVID. I'll say that this slide is exactly the same slide as the type of work that we do for our HIV studies. We've been using these kinds of tools for years. We have a great infrastructure for studying patients with slightly invasive procedures such as PET scans and lumbar punctures. We've been able to do this study only because we've been collaborating with an amazing group of people. Many of you will recognize some of these faces from the HIV world because some of the people that we knew from HIV research were very interested in these same questions. We're trying to look at sort of these different mechanisms, both by looking at blood and cerebrospinal fluid, but also by looking at some really novel MRI brain methods, and of course, neuropsychiatric batteries, which are a cornerstone here. This is the study design. We actually have 3 groups. One is a group with NeuroPask. Another is a group that are pre-pandemic community volunteers. These are samples from healthy controls that we had actually collected for comparison studies for our HIV studies. And then we also are collecting contemporaneous community volunteers who did have COVID but without PASC. For the data that I'm going to show you, we actually are only comparing the first 2 groups, long COVID and pre-pandemic controls. And this is because we really wanted to, first of all, look for any signal that was different in long COVID. And then if it was different in long COVID, we wanted to then compare in a next group of studies whether or not it was different in PASC or no PASC. This is the timeline for our study right now. We're doing 2-year follow-up, looking at a baseline within the first year after COVID. And this is a quick, only some of the demographic information for our first set of participants. The age is similar between the PASC and controls. The gender is not similar. And you can see that the days from COVID symptom onset is almost a year. So again, these markers and these that we're looking at are in people who are almost a year out from their acute COVID. They also 80% convalesced at home, so they had mild COVID. Primary symptoms for our studies, because they're focused on neuro, is cognitive impairment. So I think that really what I'm going to show you are some preliminary results. We still have not completed our study, but we do have baseline results in enough people that I think we have some interesting findings. So number one, when we look at people with acute encephalitis or even with ongoing inflammation in the brain, when they have autoimmune diseases, even when they have treated HIV, we tend to see markers that are abnormal even in clinical tests. So things like the number of white blood cells in the spinal fluid, things like the protein or albumin ratio can be abnormal in those conditions. In these people who have long COVID, significant symptoms identified through Dr. McAlpine's long COVID clinic, we're not seeing any clinical abnormalities. And this is one of the things that's very frustrating for patients, frustrating for clinicians. We'd like to be able to say, yeah, you have inflammation, you have blood-brain barrier breakdown, but we're not seeing any of that. Now, this is not a slide where I'm expecting you to look at these results carefully. We just published this paper so you can look carefully at these results. But this is something where we took all of the plasma samples that we had and in 37 participants and all of the CSF samples that we had. These are all people with NeuroPask symptoms, compared them to never COVID controls, and looking at a 15-plex cytokine set of assays, a cytokine panel, and also neopterin, which is an ELISA test. When corrected for multiple comparisons, we see absolutely no difference between the CSF in healthy controls and long COVID patients or in the blood. This is a surprising finding and a little disappointing, I think, for us, but it's consistent with other work that's recently been published, including from our Swedish colleagues just in JID this year. Similarly, we're not finding evidence of neuronal injury by several other kind of more novel markers of microglial activation. We are not seeing neuronal injury based on the neurofilament light chain, which is also an axonal injury marker that I showed you before. The only thing that we are seeing potentially is an elevation in astrocyte activation. Again, these studies we're completing and we're getting more samples to completely verify this. We published it we presented it at CROI last year, but we haven't published it. And then really, I think one of the major questions is there persistence of virus? Looking at spinal fluid is not the same thing as looking at the brain. We have not found any evidence of a virus by PCR, and we also have not found now any evidence of SARS-CoV-2 nucleocapsid antigen. After in NeuroPask participants, we found a little bit in people with acute COVID-19. So again, no evidence just based on looking at spinal fluid antigen of persistence of virus. So I'm going to end quickly on remaining questions and research directions. We're really interested in these questions of what are the underlying mechanisms. I'm going to show this slide, but hopefully people can look at it later if we're sharing slides on the web. We are interested in collaborating, and we have a lot of studies in progress looking at antibodies, looking at autoimmunity. We're planning PET studies, and we also have some novel immune exhaustion markers and other things we're doing with flow cytometry. But we do have precious samples, and we're interested in collaborating. And I think the remaining questions really are, is this injury accrued during acute infection? I would argue probably not, because many of these people had no neurosymptoms at the time of infection. Are there ongoing immune perturbations? Is there ongoing vascular inflammation? Is there persistence of low-level viral antigen? And I think that these are really the big questions. Will there be long-term consequences of this? We know that people who had COVID-19 did have an effect in their brain. So not only people with long COVID, but all of us who got COVID, will there be any consequences? Can neurodegenerative diseases or autoimmune diseases in the brain potentially be triggered by COVID? Is there an increased risk of Alzheimer's disease? And this has been a big question that's gotten a lot of attention. And I'll finally end by saying something that I'm really interested in, and we actually have a study ongoing about this question, is I've been caring for people with HIV my whole career, trying to protect their brains. And we know that second hit can be a problem, and so I think that there's a major question, too, whether people living with HIV will be further have injury or have further problems from getting COVID. So thanks for your attention, and I hope this was useful for people to get a picture. Thanking all of my colleagues, and in particular, our study participants. These people are often tired, they're having a lot of symptoms. It's difficult for them to come into studies, and they're coming in and volunteering for lumbar punctures, for repeat visits, and this is the kind of work that we can only do hand in hand with the participants. Thanks.
So thank you very much. Thanks a lot, Serena, for a wonderful talk. One question over there. We are not seeing any update in the questions from the audience in the online, right? Do you see?
Yeah, you nicely showed that there is viral persistence anywhere in the nerve system, including the cerebrospinal fluid. But my question is on subgenomic RNA. There was a paper in Nature last year, I think that the first author was Sidney Stein, indicating that the subgenomic RNA in autopsies indicates that the virus is not only there, but it's actually replicating. But this was only in autopsies. Do you find this in live people?
So it's a great question. That's not something that we've looked at. That's why I really wanted to make the caveat that looking at antigen and CSF is only one measure. We are not able to look at brain tissue, but we are really interested in using other methods. We have cell pellets as well as supernatant. So we're really interested in looking at other methods. And actually, I was really interested, we do single-cell RNA-seq on CSF. So I was really interested in the talk yesterday where there was detection of viral transcripts. So I think this is something that we need to try to figure out how to do in live patients. Because again, autopsy patients who died with severe acute COVID may be different than most of our patients who have long COVID. But it's a great question.
So maybe we can take a few questions from the online people. One question is, does this, I'm not sure what, explain the increasing number of cerebellum stroke in young population?
Does this explain the increased number of cerebellar strokes in the young population? Well, so many of the major strokes that we're seeing in people with COVID-19 at the beginning of the pandemic were major thrombotic strokes. So somebody had a big clot in their heart, they also had clots in other places, and then they got clots to the brain. So some of those cerebellar strokes in young people were really directly related to acute COVID. What we don't know is whether long COVID is really going to be associated with a high degree of strokes. You'll hear from Dr. McAlpine later, who sees these patients clinically and also has studied them. But I am not aware that in our long COVID neuro clinic, we're seeing a lot of people with acute stroke later. So I think the stroke is related to early. But again, will microvascular injury eventually lead to more long-term microvascular disease that precipitates stroke? We don't know.
Okay, thank you.
Giovanni.
Giovanni Guaraldi. And so, Serena, it seems that really virology and immunology in the brain do not help us to identify the severity. Nevertheless, we've got cognitive function tests that most of the time are reliable in order to tell us something. Nevertheless, recently in the HIV field, we met in Naples, we were somehow asking ourselves, are these tests sufficient in order to identify the true impact with regard of the quality of life, the functioning, all this. So what is the position you think is cognitive assessment in routine screening of people with long COVID?
Well, that's a multiple-part question. I mean, I want to comment one thing. I did not mean to imply that virology and immunology are not going to be helpful here. What I wanted to show you were some preliminary results based on small panels. Our cytokine panel was 15 markers, right? I think we are doing single-cell RNA-seq. We're doing other things to look at the immunology of the brain and the nervous system, and I think other people are doing the same thing. So I think there may be things that are revealing. So far, we've just used a sort of simple set of tools and a small number of people. I do think that there's a major place for cognitive testing in terms of identifying specific areas of impairment that people are having. Again, in our studies where people have a lot of symptoms, we're finding, and again, you're going to hear about this from Dr. McAlpine, we are finding specific patterns of cognitive impairment. I will say cognitive assessment, where we send people for formal neuropsychological testing, is very often fairly normal in these patients. And that's, again, a frustrating thing for these patients. And it's frustrating because it doesn't necessarily help them with a diagnosis or credibility, validation. And it's also hard because then we don't know what to treat, right? Whether or not routine screening for these people, or certainly including cognitive testing in research studies, I think that has to be honed to the things that are identified in we have a super comprehensive battery that was designed to study different types of specific problems that people complain of in long COVID. If in that battery we can identify 5 tests that really discriminate, then I think that could be used for screening. But what we found is doing something like a MOCA test, which is a one-page, is not going to be helpful at all. And in fact, it devalues the experience of the patient. So we don't tend to find that really useful. I think that a little bit more work needs to be done to identify the specific domains that people have trouble in, and then we can use those for screening and potentially to guide diagnosis and therapy.
And Serena, one quick question. Do you think that what's the role of functional imaging there?
You're going to hear a little bit more about that this afternoon. Yeah. But that's one of the things that we are doing, and actually we're expanding in our studies. I think, again, for those who don't know, we do MRI scans, we look at pictures, but there are many, many other things you can do with MRIs, including looking at how parts of the brain talk to each other, how blood flow is in the brain. And these are some of the things that we've found, and for example, in HIV, pick up things that you can't see on simply the pictures. And so I think really that is the next step in terms of some of the more subtle changes.
Okay, thank you. I think we're out of time. Thank you very much.
I'll talk to you later. You guys.
Oh, no, there's another question? Okay, so we will continue with a talk by, I think it's also a very important talk by Guillem Díaz de Melo from Institut Pasteur, which is about the hamster model for studying neurological manifestations of long COVID. Thank you very much. We're looking forward to your talk.
Thank you for the organizers for the invitation, and I'm very glad to be here to talk about the hamsters and how this small animal can teach us a lot of COVID and long COVID. So I have nothing to disclose. Back in the beginning of the pandemic, in 2020, we started to study the mechanism of anosmia in human patients, and we detect that people having presenting a lot of olfaction have olfactory sensory neurons infected in the olfactory mucosa. You can see here this yellow cell. And we try to transpose this feature in the hamster model by infecting them. And we discovered that the infection promoted a complete destruction of the olfactory mucosa in the hamsters, with the infection of olfactory sensory neurons and also infection of fibers going from the nasal cavity to the olfactory bulb. And looking deeper in the olfactory mucosa, we detect that there was a massive deciliation in the olfactory mucosa. And in this area, the cilia, they are part of the olfactory sensory neurons. So we focus then to try to prove that the SARS-CoV-2 could infect the neurons and then reach the brain using the hamsters. We started to work with the U1, the ancestral virus, but then Gamma, Delta, Omicron, BA1 arrived, and we have these 4 viruses in the hamsters. And what is interesting to see is that the animals presented the same clinical differences manifested by people. So the U1 was the most severe virus, and then Gamma, Delta, and Omicron being the less severe. And in this graph, we put the olfactory performance of the animals. We tested the animals to see if the infection would cause a loss of olfaction. And here, the U1, so it caused lots of, 62% of animals loss of olfaction. Gamma, there was no anosmia, but we can talk about hyposmia. You can see the performance is delayed, but they find the food. This test is based on the buried food finding test. We hide food in the bedding, and then we measure the time that the animals take to find the food, as having only the olfaction as output. And here you can see also the lung weight. So all the animals presented signs of pneumonia. There was exudation, there was inflammation and hemorrhages. But we were more interested in the brain. So we could take the brain tissue of the animals, and we found that the olfactory bulbs were infected. All viruses were detected in the olfactory bulbs, regardless of the presence or not of olfaction loss. The virus was in the olfactory bulb of these animals. And the olfactory bulbs, there was also inflammation and antiviral response in this tissue. But we could isolate the virus in the olfactory bulbs, but then we'd like to see the infected cells in the brain. So we went to the Paris Brain Institute and we performed a light sheet imaging in the head of the animals. You can see the orange cells are infected cells in the nasal cavity. And you can see there is virus everywhere. And going to the olfactory bulbs, you can also see some infected cells. It's more rare. We can also see infected fibers. And the virus is there. It's the viral load is low, but we could prove that the virus reached the central nervous system via the olfactory bulbs. And later, we want to prove again that the virus could indeed reach the brain via the olfactory bulbs, and reconstruct recombinant viruses expressing nanoluciferase. Nanoluciferase is an enzyme that produces light. And then we infected the animals with U1 nanoluciferase and delta nanoluciferase. And again, regardless the absence, the difference of the clinical manifestations, we could clearly see here the olfactory bulbs showing light, emitting light, and this is indicative that the virus is there and the virus is replicative. We published these results recently, and the message of this paper was all the variants can invade the brain via the olfactory bulbs, regardless the difference of the clinical manifestations. And you also put a message, but I won't talk here, but the virus can infect the neurons and can move inside the axons. And the virus can move in the anterograde and the retrograde directions inside the axon. So, coming back to the long COVID, at the our first study, we stopped to study the hamster at day 13, so 2 weeks, and we detect that the acute phase was around 5 days post-infection. You can see there was body weight loss, the clinical score, and the olfactory depth was finished by day 13. But later on, we thought that day 14 perhaps was not enough, was not long enough to see the long-term effects for long COVID. So we came back with the U1, Delta, Omicron, BA.1, and we infected the animals and keep them during 80 days. It's very long for a lab experiment, and you can see here we have the acute phase for all the animals, and then around day 15, day 30, and day 80, we tested these animals for different outputs. We were interested in the anxiety, depression, and memory loss. And what is interesting with this model is the somatic symptom disorder free. They don't think they are sick. So they help us to be objective in the output. So the first test was the anxiety, the test for anxiety, and it's a test to measure conflict. So we put the animals in a new arena with food inside in the middle, and we measure. So the animal wants to eat, but it's an anxiogenious environment. So we will measure the time that the animal go there and take the food, and you can see. We can see in these graphs that we have for U1 and Delta in Omicron infected animals, we have this tendency to pass more time before going there and taking the food. So it's indicative of anxiety-like behavior for these animals. The second was for depression, and for depression we measure anhedonia, so it's the ability of the animals to feel pleasure. And how we measure that? We spray the animal with sucrose, it's very viscous solution, and then we measure how long they spend grooming themselves as an index of self-care. And this output was more easy to see in female. In female, you can see that the U1 infected females have all the time below the mock-infected animals. And Delta and Omicron, it was like these relapsing symptoms. We have depression-like behavior at day 13. At day 30, the animals they seemed healthy, but at day 80, they were presenting again a depressive-like behavior. And the last test was for memory, how we measure memory in animals. So we put the animals with two objects. They will recognize these two objects. And then in a second session, we change one of the objects, and we measure how long they will explore the new one. Because they know that the old one is a non-object, so they keep and pass more time exploring the new object. And you can see that all infected animals passed less time exploring the new object. So there was an issue with the memory of these animals. It's difficult to say that one animal is depressed or anxious, but we can correlate and compare with the non-infected animals, and you can see that they're always at any time point for all the virus, there was at least one or two animals expressing this behavior related to anxiety, depression, or memory. And then I decided to put this painting to make like a cultural interlude so we can think about this. And it's a painting from Goya. It's just there in the Museo del Prado. And it's very interesting because this painting calls the dog. But if you don't know there's the dog there, we don't know what to look for. So I think it's very nice to put it in the long COVID. We need to know who, where, and how look for the viruses. So we start to look for the virus in the brain, and we're focused on the brainstem. So the brainstem I put here in blue, we have the medulla oblongata, the pons, the midbrain, the encephalon. And we looked in the brainstem because at the acute phase with our nonluciferase virus, we saw that the olfactory bulbs were infected, but sometimes we had the brainstem infected in the nonluciferase test. And doing PCR, the viral RNA is present in the brainstem as early as 4 hours post-infection in the brain of the hamsters, and it's always positive at day 1, day 2, day 4 in the acute phase, including with subgenomic RNA replication. And then in the late phases, we don't see subgenomic RNA, but probably because the detection limit is low, but we can have we could isolate infectious viral particles from the brainstem at day 80 from the animals presenting behavioral changes. We also took the brainstem of the animals and performed bulk RNA-seq. For those who are not so familiar with the technique, so we take the brain and we sequence all the messenger RNAs in the tissue, and then we will find the genes that are up or down regulated and try to find common pathways with these genes. And if you see these terms here, there are some terms that are interesting, like Parkinson's disease, Alzheimer's disease. I'm not saying that these animals had Parkinson or Alzheimer, but the genes were related with this disease. And if you go to the gene ontology terms, to see what biological processes were dysregulated, we can see mitochondria, cytochrome, proteasome. And those who work with neurodegenerative disease know these terms, I think, very well, better than myself. And going for the down-regulated pathways, the list is even bigger. So I'll focalize just in few ones. I have here downregulation in the glutamatergic synapse, in the cholinergic synapse, in dopaminergic synapse. I think all of you have listened to the glutamatergic, cholinergic, and these neurotransmitters. And other important points are proliferation and differentiation. And we are in the brainstem of adult animals. So what these two terms are, why are they there? So focusing on these two specific terms, we can see that we have a downregulation of neuroprecursor cells in the adult brain of these animals. And for the differentiation, we have a diminution of neuron differentiation and diminution of neurogenesis. Again, this is adult brain, but the stem cell, neurostem cells in the adult brain is a recent field, but we know now that the neurons must be somehow renewed, and the neurogenesis is important in the adult brain, and the infection in the acute phase may have this late consequence in the brain. And just to sum up all of this information with the RNA-seq, there's lots of information we need to focalize in one or another. I took these two images to try to find common pathways with pathological aging. And again, the hamster, they are not old, and they don't have any neurodegenerative disease. But if we go one by one, we have lots of proteostasis in the brain of the animals. The mitochondria are not working very well. The stem cells are exhausted, and I want to focus on that because the neurogenesis is very impacted in the brainstem of the animals. And the communication between cells are quite dysregulated, especially for neurons. The communication is related to neurotransmission. And again, in age-related neurodegenerative disorders, we have diminution of the glutamatergic system, the cholinergic system, and the dopaminergic system. And all of this data we are still validating, and we want to validate what we find in the hamster brain. We want to validate in human cells to make the bridge between the animal model and human model. And here you have human neurons differentiated from stem cells, co-cultured with viral permissible cells. So what you see in green is infected cells, what you see in orange is neurons, and in blue is the nuclei. And doing this kind of culture, we can see infected neurons, and we can validate what we see in the RNA-seq from the hamster brain, including the diminution of neurogenesis in a dish. And the take-home message that I wanted to say here is that I hope I convinced you that SARS-CoV-2 is neuroinvasive, and SARS-CoV-2 persists in the brainstem at least day 80. And I put a diagram before, so 80 days in a hamster lifespan is not 80 days at the human lifespan. We need also to consider time in the species. And the SARS-CoV-2 induces a long-term neuropsychiatric and cognitive sequela in the hamster model. And finally, the long-term SARS-CoV infection may reduce neurogenesis, which I think is an important point, and one point that I'm going deeper to try to understand. The long-term infection may impact brain connectivity, especially if some specific neurotransmitters like glutamate, dopamine, and acetylcholine. And finally, it may mimic neurodegenerative disorders. And this is one point, at least for the neuro part of long COVID, that we need to focalize to try to understand how this virus is inducing symptoms and manifestations related to neurodegenerative disease in non-old brains. And to finalize, I'd like to thank the founders, all the collaborators, and you for listening to me. Thank you.
So thank you very much. An amazing talk. Are there any questions? So it is striking that, I mean, what you showed was that Omicron is not more benign than previous variants in this sense. Is that true? I mean, it's like, what do you think about that?
Yeah, what we detect is that the clinical disease and the neuroinvasive potential of the variants are two different entities. Mm-hmm. So there's the clinical disease is responsible for one point, and then all the SARS-CoV-2, regardless of that clinical manifestations, have this neurotropic potential. Why? We don't know yet, but there's this common feature.
And do you think, what is the route to reach the brainstem? Do you think it comes from inhaled, or is it systemic, or what do you think?
Yeah, the strongest hypothesis is that there, by connection from the olfactory bulb, there's directed connection with the brainstem. So it's 4 hours, it's very rapidly to reach the brainstem, but we need to remember that the brainstem have 10 of the 12 cranial nerve pairs are going to the brainstem, the vagus nerve or others. And is it possible? Yes, we don't know, but it's possible that also other cranial nerves are carrying the virus.
And you said, and this is the last one, that there's anterograde and retrograde also traveling within the neurons.
Yes, because I'm a specialist in rabies virus. That's a retrograde, makes the retrograde transport. And for the olfactory mucosa, it's anterograde transport. So that's why we analyze both directions, and it can be transported by both directions.
Does any preference, do you think? No.
No, it will depend on the protein, the carrier protein. For the retrograde, it should be dynein. But the anterograde is more complicated. We don't know yet which protein, and it can do both.
Thank you.
This is number 2 over there.
Hi, nice talk. I was wondering, you really clearly show neuroinvasion in the hamster brain. We actually have brains of non-human primates infected with the virus, and we don't find any. Do you think that could be also related to the anatomy of the nasal area and the olfactory bulb touching it? Or do you think it's species-specific, or do you think we don't look in a correct way?
I think it may be like the problem of the size of the brain, because even in the hamster brain, which is small, if you look by regular imaging, immunohistochemistry is very difficult, and we don't see infected cells. That's why we did this whole brain imaging to try to focalize on the infection. And even in that case, just few cells. So the virus is there. It's very difficult to find them. I think the virus is also in the human brain and also in the primate's brain. The problem is to know where. And in my hypothesis, it's very small niches, and it's like the dog of Goya. We need to pick their exact position. I think it's only that problematic.
So you suggest we keep on looking further and with different methods.
Yes, it's what we do. We are trying again to find the virus in like a regular immunohistochemical staining.
Number one.
So it's a related question. So now that you localize where the infection focuses in the brain stem, for example, with luciferase activity, can you go there and look in more detail what kind of RNA, viral RNA, is accumulated in that region?
We need to do that in the late infection. We have the polymerase RNA, you have the E gene, but you don't have the subgenomic. But again, I think it's because the detection limit of the techniques that we have, it's not easy to detect. We have the lower detector of the technique is very high, so we don't find it. But it's not because the RNA is not there. It's just the problem. The problem, I think, is with the technique. We tried digital PCR. We tried everything that we had at Institut Pasteur, and it's very tricky. That's why I need to take the whole brain, make a big homogenate, and then try to isolate by regular virus isolation. It was the easiest way to isolate the virus.
Yeah, the problem is if you take the whole brain, you're going to dilute your sample. But now that you really can focus on a certain region, it may be easier. But it's interesting that you say that you see polymerase RNA, but no subgenomic RNAs, while the subgenomic RNAs always are, much higher levels because they amplify themselves.
Yeah. And what we want now is do special transcriptomic exactly to find specifically the anatomic area where the virus is.
Okay, so thank you very much. I think we're running out of time. Wonderful presentation. Now we're very honored to have Brent Appelman. He just arrived. Brent is a PhD student and long COVID physician at the Center of Experimental and Molecular Medicine at Amsterdam University Medical Centers. Thank you. Thank you for arriving also on time.
Thank KLM for that.
And please go ahead.
20 minutes ago.
Yes.
Getting it close. Thanks for the introduction and apologies for being late today. Today I will be talking about, in the session, pathogenesis about long COVID, and I will be talking about mitochondrial function that's decreased in long COVID patients and myopathy. And I will discuss two studies of the Amsterdam UMC, where I'm a physician, to show you a little bit about the data we have in our center and what we're doing. No conflict of interest. We do receive funding from the Patient-Led Research Collaborative. And the story, like many stories that we're all doing here, started with COVID-19, the acute infection itself. So this story was published, I think it was in 2022, where they had a young female admitted on the ICU, intubated, and they took a skeletal muscle biopsy. Some of my colleagues did this. And what they saw in this young female that shouldn't have any muscle defects, that they saw focal necrosis in the skeletal muscle of the vastus lateralis. They saw regeneration, they saw mitochondrial complex abnormalities. And that got us thinking, if these things are present in acute SARS-CoV-2, maybe they're present in long COVID as well. So today I will discuss two studies that derive from this, actually. So first study I'll be talking about is skeletal muscle pathophysiology that we examined during post-exertional malaise. And the second one is prolonged IDO2 presence with mitochondrial function in immune cells. First study I was talking about, the muscle plastic study is a collaboration between the Amsterdam UMC and the movement sciences. We study post-exertional malaise and look at muscle abnormalities. So we're in the last stages of submission, so it's they accepted it, but it's still not online, so please do not spread the pictures yet. Hopefully this month it will come online. And before I start talking about this, I think it's always a good idea to, formalize what we're talking about. So before I was talking about acute COVID-19 and intubated patients. When I'm talking about long COVID, I'm not talking about post-hospitalization syndromes or patients. I'm not talking about the deconditioning, the malnutritions these patients have. As we all know, if you're intubated, you can be lying in bed for a month or so. And what you see then in the muscle is completely different what we see in long COVID in young patients. I'm also not talking about aging patients where sarcopenia, clinical frailty plays a role. Now I'm really talking about the young patients, mostly female, as we know, that often have a very mild infection, not admitted to the hospital, and that also have post-exertional malaise. And post-exertional malaise is it's a very frequent symptom actually among long COVID patients. According to this article, around 70% of all patients with long COVID have it. But it's a really bad symptom. If you have seen a patient where you induce post-exertional malaise, you know what I'm talking about. You can set their rehabilitation process back for like 3-4 weeks even, and sometimes even permanently. So it's not only physical, of course, that's something we have to keep in mind. It's also cognitive and emotional that can induce post-exertional malaise. Reading a book, socializing with friends, driving, going to a doctor's appointment, going to a study visit, all these things can induce post-exertional malaise. And we, in the study, did it a little different because we wanted to make sure that we had post-exertional malaise, so we did a bike test. A maximum bike test takes around 15 minutes. It gets heavier and heavier per minute that you cycle, and it's made to fail. So at a certain stage, everybody fails. If you're healthy or not, you fail. Only long COVID will fail probably at a lower level. We examined skeletal muscle tissue 1 week before and 1 day after this bike test to see longitudinally what is changing in these patients. We also took blood from these time points so we can really create an in-depth profile of what is going on in these patients. And for this study, we included 21 healthy controls and 25 long COVID patients, all of relatively young age, around 40 years old, healthy, even split between males and females, normal BMIs, no comorbidities, with a severe reduction in working hours for the long COVID patients. They cannot really work anymore. They're so severely affected by the long COVID. We'll start with the most obvious results, and this is the results of the CPAT itself. So this is the bike test. You expect these patients, of course, to perform badly at these tests, and that's what you see actually in these results. So we have the VO2, measure how you can use oxygen. We have the peak power output, so the maximum wattage you can reach on the bike, and the gas exchange threshold. They're all lower in long COVID. In red, you see here long COVID, and they're all diminished in long COVID, which really shows that there's also some deconditioning going on and that they cannot function properly, which is logical. If you have seen in long COVID patients, that's what you would guess. What's not logical is this picture I'm going to show you. And this is the main finding of the paper, I think, and this is focal necrosis. So we examined focal necrosis 1 week before and 1 day after. I show you here the baseline and the 1 day after the post-exertional malaise. In red, the long COVID patients, in the white, healthy controls. At baseline, you see that only 8% of long COVID patients show focal necrosis in the muscle tissue. None of the healthy controls, which you would expect. But after the induction of post-exertional malaise, something happens. Around 40% of all long COVID patients show focal necrosis in the muscle tissue. And these are the defects you see in this picture. And they're scattered throughout the tissue. It's not only a small part. Multiple sections are actually full with focal necrosis. And the thing is with this, that in your mind, it can also really explain some of the symptoms these patients have. The muscle aches, the tremors, that they tell you they cannot walk anymore, to their muscle pain. It really explains what they're having. The good thing is that there is some regeneration going on in these muscles. So the long COVID muscles show that they're able to regenerate. Only the extent of the damage is enormous. So that's also, again, a positive side. They show to be repairing, which is, in my mind, still positive. So we have focal necrosis, a lot of infiltration of macrophages as well, a lot of immune cells, of course, that are coming in. Why is this happening? This is only, of course, the tip of the iceberg we're looking at. We tested 3 different theories that I'm going to show you today. The first thing I will talk about is mitochondrial respiration. So we examined mitochondria from the skeletal muscles. Again, in red, long COVID, baseline 1 day after post-exertional malaise. And what you see in the respiration is that the mitochondria are not producing energy as the healthy controls, both before and after exercise. If you further look a little bit deeper and you look at the metabolites within the TCA cycle, for example, you see that all metabolites within the TCA cycle are downregulated and lower as in compared to controls. It looks like the entire mitochondria of these patients in the skeletal muscle are just not functioning properly. And that's both before and after exercise, and getting worse after exercise. Another thing which we all talk about a lot is, of course, viral persistence. Is there a SARS-CoV-2 virus replicating somewhere and we haven't found it yet? So we also looked at this in the skeletal muscle cells. So we stained for a nucleocapsid protein. We did not see any difference between long COVID and healthy controls in the skeletal muscle. We do see its presence there. About 1 year after the infection, there's still presence of nucleocapsid protein in their skeletal muscle, but there's no difference between healthy controls and long COVID. Of course, we also looked for spike, and we also did not see any differences in that protein in the skeletal muscle. The third one we also looked for is amyloid-containing deposits. Of course, Recia Pretorius made a great start in the beginning of the pandemic already, where she showed that these amyloid deposits are present in long COVID patients that were not present when sampled pre-pandemic. You see the beautiful pictures right over here from our previous publication. Then we looked in the skeletal muscle cells. Can we actually find these amyloid deposits over there? So in green here, we show you the amyloid deposits, where you see the skeletal muscle cells. And you can see them very, very, very clearly. Healthy control, we also included there on the right-hand side. You don't see it at all. So these amyloid deposits are not only present in blood, they also seem to be present in skeletal muscle cells of these patients, and quite in a big number if you see, take a look at these pictures. We also captured one bigger vessel. This is a bit of a luck from our side that we captured that. And you can also see in the vessel there's a lot of infiltration of these amyloid deposits in it looks like in the endothelium, as it is migrating through or something. So we also stained a little bit further to see, can we locate in the skeletal muscle cells where it's located. So we did 2 co-stainings. One is with CD31 to see if it might be located in the capillaries of the theory that is maybe blocking the capillaries and therefore causing all the symptoms. And we did a staining for lymphatic vessels. Both are not overlapping, so it looks like these amyloid deposits are not located in the smallest capillaries, or nor are they located in the lymphatic vessels of the skeletal muscle. Where they are exactly located and what they're exactly doing there, I don't have a clue yet, but we'll find out hopefully soon. So the conclusion of the first paper is that we show that there's actually severe myopathy in these patients, and with this myopathy there are metabolic disturbances. And not only there are metabolic disturbances, there is amyloid present where we're not sure what it is yet, but it shows that these aberrations in the skeletal muscles are key characteristics of long COVID, and also during post-exertional malaise. And the beautiful thing I find about these results is that it very well explains the abnormalities you hear from the patients, where they are fatigued, they have pain in their muscles, they have the feeling that their muscles are falling off almost, they cannot walk anymore, they come in a wheelchair. It sounds like a logical connection. That was the muscle stuff. So now about the mitochondrial stuff and the IDO2. This is the second study I'll be talking to you about. It's a study in collaboration with some partners in the Amsterdam UMC as well. René Lutter you see on the right-hand side, and Le Guo. It's a paper published in August this year, where we see IDO2 presence in immune cells, which is associated with cellular stress in long COVID patients, which I will elaborate a little bit further on. First about IDO2. We also have an IDO1. When we have a 2, we have a 1, of course. So we have IDO1 and IDO2, and they're both involved in the tryptophan kynurenine pathway, which you see here on the right-hand side. So they're actually the first step in the degradation of tryptophan in that pathway. And normally, IDO2 should not be present actually that much. It's mostly IDO1 that must be present. And IDO1 is induced by interferon gamma. It's associated with the interferon response as well. It's widely present, like I said, and if the cells express IDO1, they're also protected against interferon exposure. Normally, this IDO1 goes away after 2 to 3 weeks, after the infection is a little bit gone. IDO2, on the other hand, stays positive. It has a positive feedback loop. These cells that express IDO2 are not protected against autophagy and apoptosis, and it should rarely be there. A good thing also to remember about this pathway, the kynurenine pathway, is that certain metabolites within this pathway are neurotoxic. For example, quinolic acid. That's a neurotoxic metabolite. Quinuric acid, for example, is instead neuroprotective. So that's a little bit about the background of IDO. IDO is not new, by the way, in chronic fatigue, LANS, and ME, and long COVID. A lot of is being published already. We're calling it the metabolic trap For example, it's been spoken about for many years. A lot of studies are quite active in it. Also the serotonin study, of course, where we show that a low serotonin is found in long COVID patients. That was quite recently released, of course. Also a study from the Netherlands where they show that patients treated with an SSRI with serotonin actually do better, are also all involved in the pathway with tryptophan. So it's not new, but what we did know is look for IDO2. And normally people only look for IDO1, and we looked for IDO2. And this story again started in the COVID-19 itself. So COVID-19 is a beautiful place to start and to get ideas from. We had a lot of funding, of course, in that time. Long COVID is a little bit less, but we're trying to get there. And what we found in COVID-19 is they took pulmonary tissue from deceased COVID-19 patients, and they stained for this IDO1 and this IDO2. And normally you would expect IDO1 to be present. You have SARS-CoV-2, a virus, you have interferon gamma pushing up the interferon 1, the IDO1. But we saw that rarely. We actually saw a lot of IDO2 in this pulmonary tissue. And this shouldn't be there. We saw a lot of autophagy as well, a lot of apoptosis. So this got us thinking, could this also be present in long COVID? And we started at the beginning. So I showed you this pathway. So we just measured in the blood in our long COVID patients. What are we seeing regarding the measurements of this? And the main finding here is that quinoleic acid, where I told you about, is a neurotoxic element, is way, way higher in long COVID compared to healthy controls. Fatal cases of COVID-19, it's even higher, but in long COVID, it seems to be higher. Quinoleic acid, which should be neuroprotective, is lower in long COVID patients as compared to healthy controls. All interesting signs that something is going on in this pathway. So we dived a little bit deeper and we did the staining. So we stained for IDO2 and IDO1. We took the immune cells from the patients. That was the easiest accessible material for us. Of course, we have the muscle section, but they will follow later. And interestingly enough, we rarely saw IDO1, which can happen, of course, but the fact is, in C and D, which I'll show you, there's a lot of IDO2 present. And IDO2 just should not be there. We saw it in all kinds of lines of immune cells. You saw it in the macrophages, you saw it in the T cells, you saw it in the B cells. A lot of IDO2 was present there, which could cause perhaps some of the symptoms. So we decided to take a little step further, and we decided to co-stain with for apoptosis and autophagy markers, and we tried to see if we could block IDO2 with a AHR antagonist. So the first line is just the controls, and at the bottom two rows, we added an antagonist. What you can clearly see in the first picture is that there's a lot of IDO2 presence, there's a lot of apoptosis, there's a lot of autophagy in the second picture. And the moment you start to add the antagonist, IDO2 expression goes down, apoptosis goes down, autophagy goes down. If you add more of the antagonist, even more is going down. Also shines that this process could be reversible. This is, of course, not in humans yet, so that's, of course, the next step we're going to see. Are we able to diminish those IDO2 in actual long COVID patients and maybe diminish the symptoms in long COVID patients? So we also decided to look at, is this doing damage in these long COVID patients? We had the immune cells, so what can we use as a damage marker other than the stainings we did? So we decided to look at the mitochondrial respiration. Of course, a little bit based on by the skeletal muscle tissue respiration that we saw. And also in these immune cells of long COVID patients, you see a diminished respiration in the immune cells. So we have diminished respiration in the skeletal muscle cells, we have a diminished respiration in the immune cells. These mitochondria are not functioning properly. And that's also visible again when we perform metabolomics. You see also that certain products within that TCA cycle are downregulated. Citric acid, one main component in there, severely downregulated in long COVID patients as compared to healthy controls. So with this study, I tried to summarize for you that this SARS-CoV-2 triggers a long-lasting IDO2 response, and that specific metabolites within the quinoline pathway are best kind of related to the symptoms we're seeing in long COVID patients. And that combined with the results of the first study that I showed you, where we show severe myopathy, metabolic disturbances, mitochondrial respiration that was diminished, we provide a little glimpse in what we do and what we think is a possible explanation of long COVID patients. And we think that mitochondrial dysfunction, the presence of IDO2 and the myopathy we see in long COVID patients are key characteristics of long COVID as we see. Of course, I want to thank all the people involved with this product, from the product with his work from the Amsterdam UMC and from the VU. Of course, also our funders. Thank you very much. And this is what I had to say for you today.
Thank you very much. Really excellent talk. Are there any questions in the room? Upi?
Thanks. That was a really nice talk. I was interested in the post-exertional malaise and the findings that you have with the necrosis, as well as is all post-exertional malaise the same? So is it the same in ME/CFS patients who also have significant post-exertional malaise?
I think so. So that's why we're doing the same study in ME patients now.
Including the fibrin clots?
Yeah. So we are now at 20 ME patients, so we still, at the end of February, we'll be done. And then we'll look at the results that we have and compare them to the long COVID patients we have. I think, personally, it's quite a similar picture we'll see. So we also talk a lot with the trauma surgeons that actually take the biopsies. And the funny thing is, when they take the biopsy, they already can tell if it's a long COVID patient or an ME patient as compared to LT control. They feel that something is different in the muscle already. So I think we'll see very similar results.
Okay. And a second part of that question, this is more about the clinical care.
Yeah.
So, right, with ME/CFS, there's been controversy or concern, right, about recommending exercise for this. Similarly, now a lot of concern for long COVID patients. Yeah. Any thoughts based on sort of your experience or what you're seeing?
Yeah, so exercise comes in many forms and shapes, of course. So you can do low-grade exercise where you pace yourself. I think the main clue is not to induce post-exertional malaise, which is super difficult, of course, because everybody has a different threshold, and not one day is the same in the life of a long COVID patient or an ME patient. But the fact is you still need to maintain your condition, your physique. So you do need to move and get around to get the muscles building again. But not to induce post-exertional malaise, because what we show you with this focal necrosis, you don't want that in the muscle. And it's very logical that this can cause symptoms which will affect you for 2-3 weeks, even longer, months, who knows?
There's a question over there.
Hi, interesting talk, thank you. I'm Stefano Savinelli from Ireland. My question is around physical activity. So in the first study, your healthy controls, how physically active were they? Because, of course, you're seeing muscular necrosis, and I'm wondering if you're seeing that because people with long COVID, of course, are not active because of fatigue and post-exertional malaise. So are you seeing that, do you think, as a consequence of physical inactivity rather than long COVID itself?
Yeah, an excellent question you posed there. So originally, we had the idea to exercise match them, which was impossible, we came to know during the study. These long COVID patients, just so you know, are not inactive, they're not bedridden, so they walk around 4,000 steps a day, so we monitor the steps and their activity levels, which is lower than the healthy controls. Those were around 8,000 or so, so they did walk around. We performed a study in collaboration with the European Space Agency, where we have patients bedridden for 2 months, and the things you see happening in the muscle over there are completely different from what we see in the long COVID and the ME patients. So I don't think necessarily that the aberrations we see in the skeletal muscle are caused by inactivity, what we see, no.
Okay, and one last quick question and answer.
Jérôme Marché from France. Mitochondrial dysfunction that is extensively studied, for example, in intensive care for muscles and for heart. And we know that there is a mitochondrial dysfunction linked with heart dysfunction in intensive care patients. Do you think that your conclusion, do you think there is a room for cardiac dysfunction linked to mitochondrial dysfunction in long COVID patients?
So you think?
Do you think that there is a room for thinking that there is a mitochondrial dysfunction which could explain, for example, some cardiac dysfunction, cardiac abnormalities?
So you think if the mitochondria could involve in the cardiac? Possibly, yes. We don't have cardiac tissue yet, which is fortunate, I guess. But yeah, that would be the next step to determine that. So we're thinking about making diagnostic models. So my colleagues behind you are working very hard on that. You could replicate heart tissue, of course, and see if you can make a long COVID model, for example. And if you have a long COVID model, you can have a look at if the mitochondria are affected in the heart tissue as well. If the skeletal muscle tissue is affected, it's not very far stretched to think about that the heart tissue might be affected. Yes, I do think so, yeah.
All right, so thank you very much. I think we are at the end of this session. It was really amazing. Congratulate all the speakers. Just a few notes. First is that we will have a group photo taken today before lunch. We will be told where exactly. I don't know exactly where. And also, please complete the online survey, which is very helpful for us. Now we start the coffee break, and we will reconvene at 11:45. Thank you very much.
No problem. No problem.
Perfect timing. Perfect timing.
I have the introductions, so I will start whenever. Should I start?
I think we should.
I think we should start. Sorry about that. Yes, sorry. So sorry about that. Okay, we're going to start now, and thank you so much for being here. Today is my name is Dr. Monica Gandhi, and today is the Shionogi Industry-sponsored symposium. And we have a really good discussion today about SARS-CoV-2 persistence and long COVID. What have we learned so far? And so today we're going to have a talk from Dr. Roger Paredes on long-term evolution of long COVID. And then, we're very excited to hear that because he's been really long-standing in the AIDS research field, the AIDS Research Institute. And so let me just give you a little bit of introduction to Dr. Paredes. He is the head of the Infectious Disease Department, Hospital Germans Trial, principal investigator of the Microbial Genomics Group at the AIDS Research Institute in Catalonia, Spain, Barcelona. He has an MD PhD, and he's been long-standing in working in the setting of HIV deep sequencing in both high and low-income countries, leading really pioneering research in the gut microbiome and the pathogenesis of HIV infection and the COVID pandemic. And he'll talk to us today about the progression, long-term evolution of long COVID. And then I'll introduce now my fellow UCSF faculty member, Dr. Raul Andino. And Dr. Andino's research actually focuses on this very topic, the biology of RNA viruses. And I think it's really important for us to take a step back and think about 101 on viruses. What about RNA viruses? What about DNA viruses, retroviruses? What do they do in terms of staying in the body when we think about persistent viral sequelae? And really, he has greatly advanced our understanding of viral host interactions. He has introduced a conceptual framework positing infection as an ongoing process of intra-host virus evolution. And I think that really shapes on how we perceive disease, especially in post-viral sequelae. He also, by the way, developed an innovative oral polio vaccine. So really excited to first have Dr. Paredes speak, and then I'll turn to Dr. Andino.
Okay, so thank you very much. Thanks, Shionogi, for supporting this symposium. My talk will be more clinical oriented, and then I'll leave Dr. Raul Andino to speak more on the molecular mechanisms of virus persistence. So we are now more than 3 years into the COVID pandemic. Again, these are my disclaimers. And I already showed these slides before. As I said before, we were hoping that these post-viral syndromes that Dr. Gandhi explained yesterday excellently, these would go away. That was my first hope. But Dr. Lourdes Mateo, who's sitting back there, she already told me, no, this is not true. This is staying. This is a real disease. I was skeptical at the beginning, but she convinced me. Also, the evidence convinced me that it's not true. That this is a problem. This is a big elephant in the room. This is something that's here. Policy makers and public health, I would say ministers or economy responsibles in Europe don't want to, are so far overall are looking somewhere else, but this is something that it's not leaving. And my talk will be about what should be, I think it's our responsibility to think about how can we end this long COVID pandemic, not only describing it, but also thinking ahead and say, okay, this is here. It is a very complex issue. It's not easy. We're not going to hit the home run just tomorrow, but we need to start thinking about it. And the model, and this is the model I will follow during my presentation. So we know that there's a lot of acute COVID-19. We have no I would say, milder variants in comparison with the previous ones. But of course, if the vaccine status, the vaccination status is also playing a big role, it has been said that Omicron as a virus is as pathogenic as the initial Wuhan strain. So I don't know what would have happened if the first virus that we saw as human beings was Omicron. Probably it would have been a disaster, just as with the previous viruses. But the good thing is that, okay, there's less people nowadays who develops long COVID, but there's still a significant amount of people who end up developing long COVID. And because this virus is so transmissible, at the end, the numbers of people with long COVID, even if it's 5% or even 3% or 2%, is already too much. So we have a big number of people with long COVID in Europe and in the world, everywhere in the world. And of course, some of them recover. Unfortunately, it is a minority. It is a minority, and it depends on how we define our cohorts. We might have different numbers. But also a lot of them persist. And what is important also is that now we are having reinfections, and also I think that reinfections are playing an important role in maintaining this system of communicating VISA with a lot of long COVID. So if we want to end long COVID, first of all, we want to prevent new long COVID from happening. And I will discuss a little bit what we know so far, but also we need to start thinking about treatments. It is very important to characterize our cohorts. Each cohort has a slightly different characteristics. This explains the differences in prevalence and in incidence to a large extent, but what we really need to start thinking is what can we do to increase whatever number of patients recover and also reduce persistence. If we start with the second part, what have we learned so far? So one of the main first studies is the post-COVID study. This study was performed in hospitalized patients. It was published in Lancet Respiratory Medicine. And what you can see here is that at 5 months, already 25% of, this was essentially a hospitalized cohort, already 25% had recovered, 20% were not sure, and 50% felt that did not have fully recovered from COVID-19. When they looked at what happened 1 year following the acute COVID infection, there was, up to 30% of patients who had fully recovered, 22.4% who still didn't know, but still 50% of patients who had recovered. And what is interesting is that there was a little difference from the first time point at 5 months and 1 year. And the main factors related with recovery were female sex, invasive mechanical ventilation, and obesity. Also, as was mentioned before, Scotland is and the UK have wonderful systems to look at outcomes at a population level, and what they observed in these also very large cohort of confirmed SARS-CoV-2 infections, and compared with people who were never infected, they found that only 6% of patients had not recovered, and up to 42% only partially recovered 18 months after following the acute infection. Here you can see factors related with lack of recovery. I will then dig a little bit more. I will use my also to dig a little bit deeper on a cohort that we published in, the data from our cohort in Barcelona, in Hospital Germans Trias, which is led by Lourdes Mateu and Marta Massanella, and also the whole team, where we let me start by saying that this is a biased cohort because this is a hospitalized, a hospital cohort of ambulatory patients. So because our healthcare system in Spain, like in many other places in Europe, it's so ill prepared to deal with long COVID patients. Of course, we always, and it's difficult for patients to reach us, we always have patients with more severe COVID present, long COVID presentation. So this was, and Marta Massanella presented an update in the numbers yesterday. I will just stick to those published. So this is an observational prospective cohort study of COVID-19 survivors between May 2020 and February 2022. Essentially, almost all of our patients were not vaccinated when they were recruited, and this is another source of bias. So, and this was a pre-Omicron cohort. So it's the third source of, I would say, bias. So from this cohort called King cohort, we identified a number of patients who did not have persistent symptoms, but also up to 62% of our patients, 341, had fulfilled the criteria for post-COVID condition. Importantly, an advantage in comparison with the previous mentioned limitations is that Dr. Mateo's team performed a systematic collection of a comprehensive list of symptoms and functional scales. And this is an advantage relative to sometimes public cohorts because based on reporting. The reporting was done using in a specified way. In our cohort, the key baseline characteristics were that most patients, both in the PCC and the no PCC, were females. So we're actually in the PCC were more, almost 70% of our patients in the PCC group were females. It is interesting that they were less likely to have tertiary or higher educational studies. They were engaged in less likely to be engaged in regular physical activity, had a higher number of comorbidities, and less of them had been hospitalized. So it was the acute COVID-19 had been relatively mild, and almost all of them had been infected with ancestral variants. Essentially, the most prevalent symptoms in our PCC cohort were those that have been described elsewhere, no major differences. And here's a very nice graph done by Marta Massanella, clustering all these groups of symptoms. And the first issue that we wanted to ask was if there were determinants of onset. And what we observed is that there were a number of conditions like fibromyalgia, headache, insomnia, and autoimmune disease, for example, that were significantly associated with increased risk of developing long COVID. Actually, solid organ transplantation, male sex, immunosuppressive therapy were on the other end. We don't have enough power to provide definitive conclusions, but this is another area of interest, whether immunosuppressive therapy or maybe immune modulators could be preventing the PCC, but it's open for discussion, and you guys might have more data on that. But also the determinants, the presenting symptoms were also very important. So patients who presented with dysphonia, tinnitus, visual alterations, insomnia, and also neurocognitive complaints, neurosensitive alterations, tachycardia, dizziness, all these patients were clearly more likely to end up being in the PCC group, whereas things like fever or weight loss were not really discriminating the risk of PCC. Then we constructed two models, multivariate models to see which could be these determinants of onset. The model on the left-hand side only includes pre-existing conditions. It had a pretty nice fit. It always has 75% area under the curve, but the model on the right, which combined pre-existing conditions and presenting symptoms, had a much better fit. Of course, one of the key aspects is that we need an external validation of these. This is what we found in our group, but it would be very nice to see how this performs in your cohorts, so you can easily take these data and see whether we are right or wrong, and I think that would be very important. What we saw here was that actually male sex and tertiary studies, for example, were associated with a reduced risk of developing long COVID, and then a number of symptoms at presentation that are shown here below were associated with increased presentation of long COVID. Again, we evaluated symptom clusters, and essentially we replicated what the recover group had done. Actually, when we saw the presentation from the paper from the recover, we said, "Oh no, they scooped us." And actually, but that's very nice. What we see, however, is that, and this is something also for discussion, one of the aims of these clusters is to identify patients that can be separated and that can be mutually exclusive. That would be what would lead us clinically to maybe targeting specific interventions on the different clusters. Honestly, we don't see that. What we see, and of course it's a small study, what we see is that these clusters are actually separated because of the addition of additional symptoms. For example, everyone has fatigue, cluster B and C has neurocognitive alterations as well, and then of course cluster C is the one with more symptoms, cluster B has a little bit less, and cluster A would be the group of patients with relatively, less symptomatic. Again, as I mentioned before, we could see, we were quite obsessed with finding organic evidence of lesions, because this is what our policymakers they dismiss sometimes. And as I said before, there were a group of, I would say women, because most of them were women with chest pain. And when we did adenosine stress MRIs, there was actually myocardial hypoperfusion in a significant number of them. Then we wanted to ask ourselves, okay, which are the factors related with recovery? Because what we want these patients is to recover. And the first finding was that only 7.6% of our cohort fully recovered over 2 years. One limitation of our study is that we don't have the gradation, so we were not. It is possible that there was another fraction of patients who had relative improvements. Here we are showing return to baseline, and baseline is before COVID status, but it was only a minority. And then because this was a small group, what we decided to do is a direct cyclic graph approach of the PCC resolution. And also what we have found here is, for example, there were factors like smell and taste or hyperexia, which are actually associated with an increased risk, an increased chance of recovery, whereas myalgia, dyspnea, tachycardia, neurocognitive disorders at baseline were actually highlighting which patients were not recovering. Importantly, almost all patients who recovered belong to the cluster A. So, and that also provides another clinical insight. So if you have patients with more symptoms, with a more severe disease, they are less likely to recover fully. I'm sorry because we missed, this is a river plot of what happened with vaccines, with vaccination dose. And of course, there's a huge controversy here about symptoms. I don't know what happened to my, here. Okay. And long COVID patients some long COVID patients are scared of becoming vaccinated again, because there's a lot of fuss around saying, okay, vaccines could worsen our long COVID symptoms. Essentially, this is the first dose, second dose, and third dose. This is not a causal, it should not be interpreted causally, but essentially what we saw was that there was a decrease in vaccination as we went ahead, and we think that's not good. But essentially, most patients felt no changes when they were vaccinated, and I think it's also important to highlight that. Okay, in conclusions, there are pre-existing medical conditions are associated with a clinical presentation. This allows some early stratification of risk. There are subsyndromic clusters. This is concordant with recover, but what we see is additive severity of single multisystemic multifaceted post-viral syndrome, and recovery from PCC is rare. So healthcare systems must acknowledge PCC and be prepared. Additional one question is what happens with Omicron, and these data from Denmark. even if Omicron is associated with less at risk of developing long COVID, what you see is that once you get Omicron, the disability scores remain the same, are similar. So less chances to have Omicron, but if you have Omicron and long COVID, the disability remains the same. So there's failure to improve in this cohort with different measures of asthenia, quality of life. So it's, we should not undermine, just say, okay, because you were infected with Omicron, the chances of developing long COVID are lower, but if you get long COVID, the evolution seems to be very similar. There's a very large population-based study in Zurich, and it's a complex slide, but what I want to show is that up to, in this very well-done study published in BMJ, up to 18% of patients following acute COVID develop long COVID, so it's a significant amount, but also the evolution was a little bit hectic, but a lot of them continued with having symptoms. Here you see the same data looking at different symptoms, and what you can see is also persistence even in this Zurich cohort. Looking, for example, at no recovery at 6 months, but problems with self-care, problems during usual activities, pain or discomfort, anxiety, depression, mobility problems, fatigue, dyspnea. So it doesn't seem to go away, not even in Zurich. And of course, this is leading to a lot of disability. And this is something that we need to bring back to our politicians and say, okay, we need to do more. So in terms of prevention, what can we do? So the first thing is also, there are four aspects that I think are important. First is vaccines. It was Dr. Gandhi mentioned that yesterday. The second one is understanding the role of variants, avoiding reinfections as well, and early antivirals. And I will go very quickly through, because there has been a lot of research, and what you can see here is that a complete vaccination schedule is actually reducing your chances of developing long COVID. So people must be vaccinated, and also we need to strengthen this message that even long COVID patients have to be vaccinated. This is a meta-analysis that has been accepted for publication in Lancet Respiratory Medicine, where I'm showing it with permission of the authors. And this is looking at 4 different primary care cohorts, 2 in the UK, 1 in Catalonia, 1 in Estonia. This is done by Dr. Prieto Alhambra's group at Oxford, confirming that any vaccination is actually associated with reductions in the risk of long COVID. So what about variants? So you can see here, as was mentioned yesterday by Dr. Gandhi, that Omicron is actually associated with lower risk of developing long COVID. That does not mean, as I said before, if you get long COVID, then the evolution, so far, we have not seen that the evolution of Omicron once you have long COVID is different from the previous one. The good news is that with Omicron, you get less long COVID. However, there are so many infections that then the absolute numbers might still be really worrying. And as was mentioned here, you can see the effect of, there's a combination effect between both vaccination and Omicron compared to Delta. So you can see a larger reduction when you look at all age groups in this large study published in Lancet, comes with Omicron, but also when vaccines have been given 3 to 6 months. So if your vaccination has been performed in the previous 3 months, there's already a reduction in the risk, but when you go beyond three months, the risk is higher. And these are the data separating people above and below 60 years old. So in other words, there's no evidence of heterogeneity. So this both vaccination in the context of Omicron works for the younger, but also at the older patients. What happens with reinfections then? And in this veteran affair, reinfections are a problem because in this Veterans Affair study, they are associated with increased risk of all-cause mortality, hospitalization, and at least one sequelae. You can see then that these effects, last, and this is up to 180 days since infection. Of course, they decrease, but they remain at a certain level. And in also another paper that has been accepted in Nature, well, it's actually published in Nature Communications already by the group by Dr. Alhambra, which we helped. Reinfections in 2 different primary care cohorts were associated with increase in symptoms all over the place. So reinfections for long COVID are not good. So we should really avoid them. And what can we do to avoid them? So I will not touch into the masks and distancing. This is something that it's more complex, and we can, but it's also important to discuss, but at least we have some very early data on treating with early antivirals. For example, nirmatrelvir, ritonavir has been associated also with reductions in PCC. Here, also reductions in thrombotic diseases following acute infection. There's this amazing data from early metformin, the group by Bramante and colleagues, and it will be shown later during the presentation, where actually early metformin is associated with reduction of long COVID symptoms. And this is a very interesting, it has been shown, I've seen the presentations in the past, metformin might have some antiviral effects, but it might also have some other immunomodulatory effects, so I think this will be very interesting to understand. And also, of course, ensitrelvir in these data were presented at CROI. Ensitrelvir is also an antiviral done by Shinogi. In this case, there's a consistent reduction in a number of COVID-19 symptoms. It is true that many of these findings were not expected when the clinical trials were designed. But I think it's good enough, and they are important enough just to think about, prospectively incorporating long COVID outcomes, at least up to 3 months. And this is something that can be done. It's not impossible in all these new clinical trials targeting antiviral strategies or metformin as well. So in conclusion, I think I'm on time. Yes. So the first conclusion is that long COVID lasts for long, and in some cases for very long. So this is not going away. This creates high visibility. The long-term duration, once you unfortunately have long COVID, does not seem to be affected by variants or vaccines as of today. Variants or vaccines are reducing your chances of developing long COVID, but if unfortunately you have long COVID, at least I've been unable to see a difference in the evolution by Omicron versus other variants. Improvement is possible, so I also want to bring a little bit of hope. Improvement is possible, but certainly is for the less severe cases. So we need to do more, and governments need to do more. There needs to be more funding because we have the urgent need for prevention tools to reduce new incident cases and worsening of symptoms. That includes vaccines. Long COVID, people with suffering long COVID must understand that vaccines are good for them, even though there is a small proportion of patients that might have a transient worsening, but vaccines are important. It is important to avoid reinfections. So and this is an opinion, in my opinion, long COVID patients should be considered a high-risk group, not necessarily for hospitalizations, but in terms of I think this should be a group of patients where the antivirals should be really targeted. And we certainly need to treat reinfections very quickly. This is not in the current guidelines, so this is up to discussion right now, but this is, I'm giving you my opinion. And also the urgent need of treatments. Every cohort is different for treatments for established long COVID. So, and I would like to end again by acknowledging the very important role of patients. In our case is a group of COVID persistent. I think I come from the HIV world, and without patients and without patients pushing, it would have been impossible to make all the advances that we have observed. And unfortunately for patients are already carrying a high burden, and they probably have to carry the burden of pushing even further, which is bad for them because they are tired and but it's not simply, governments don't simply work or start doing things because of science. And of course, I want to acknowledge Marta, who's the lead, Marta Massanella, who's the leader in the lab, so the lab studies, and Lourdes Mateo, who created this cohort and believed in long COVID since the first day, and also, of course, all the team, and finally, our collaborators at Oxford. Thank you very much.
Thank you so much. We're actually going to do questions after both talks, but that was a great overview of not only the prevalence, the evolution, what is the effect of variants, and then what we can do about it and the need for more. So the next talk is Dr. Raul Andina, and this is going back to 101 virology, retroviruses, RNA viruses, DNA viruses, and about persistence when we think about antivirals. Thank you.
Thanks, Monica. Yeah, I've been charged with trying to review some of the things that we know in other viral infections that induce persistent infections, and see whether we can, take some of these lessons to illuminate a little bit what's going on with long COVID, but also with the caveat that every virus does this kind of things in their own way, and it may not be exactly right to apply what we know about HIV, let's say, on long COVID. And so I really am going back to 101. And I think just to put on a sort of a conceptual framework here, if we want to really tackle these past cases, these long cases, we need to understand the drivers in order to be able to block the evolution or the development of the long COVID. Otherwise, we're going to be chasing symptoms rather than the cause. And so here there's few hypotheses. I'm sure there are more, and I have to say that none of them are exclusive. And in fact, what we've seen in the last day and a half is that people start to classify long COVID in different subgroups with different symptomatology, perhaps not the symptoms that the patient have, but the responses that we see when we look at immunoresponses, for example. And this could be because the cause of this long COVID could be multifactorial. It's a little political correct things to say, so everybody is happy that it studies something that is relevant, but also I think it's important to understand the complexity. So this could be a hit and run, something that is immunopathology that is long-lasting. Maybe this antibody or some T cells that are induced during the acute phase. It could be that SARS-CoV-2 persists, and so we're going to discuss a little bit, whether this is possible. And the third possibility here is that there are dormant viruses in the patients that get infected, and those dormant viruses get activated. Infections could be acute or persistent, and of course, we know very well that acute infections has a rapid and cell-limiting effect. Persistent infections is longer, sometimes the whole life, and the stability of this persistent infection depends very much over the different virus. And most persistent infections have to deal with immune responses, somehow has to evade it. Here's just a schematic of, the classical, I don't think, this is it. Classical acute infection where, virus is eliminated, or there is reactivation in the case of herpes virus, for example. There's some persistent infections in which the virus is not reactivated. It's producing the whole life, but it's asymptomatic, and we don't understand exactly where the tolerance of these infections come from. And in the case of HIV, we have an acute infection. The virus seems to be controlled, but eventually the virus gets activated again, and this leads sometimes to opportunistic infections and death. So I'm going to just go quickly through a number of viral families. I'm sure you guys know many of these examples. I just wanted to put it all on the table because I think it could be, sometimes for me, even preparing this lecture, for me, it's good to review some of these cases. And the important thing is that, the immune system cannot clear the infection, that often you can rescue virus, observe genomes or proteins along these persistent infections, and it depends very much on what is the strategy of the virus to induce this persistent infection. In the viral genomes, proteins sometimes are not detected at all, and we'll see this in the case of herpes virus. There's no single mechanism, as I said, and this immunoevasion is very important. And of course, the virus cannot be causing the acute cytopathic effect that is classical in the acute phase. Here's the long list of all the human viruses that cause persistent infections. They go from adenoviruses, herpes viruses, polyomas, measles, rubella, etc., of course, HIV. One of the things that is classical here, and we've been talking about it, is this CTL effect on clearance of the infected cells. And for that, there is this recognition of the CTL with peptides presented in class 1, MHC class 1. And this sort of complicated scheme shows you in the yellow boxes the name of different viruses and different proteins that encode these viruses, blocking different steps in the peptide presentation process. So the paraproteins have to process by the proteasome and translocated into the ER, and then it's assembled in the class 1, and this is sent to the surface of the protein that is infected for the CTL to recognize the cell. And you can see in the yellow boxes all the different viruses that are blocking different steps in all this pathway. So clearly, viruses like HIV or herpes or EBV, they spend some energy or some part of their genome to try to block this particular CTL effect. So some viruses, like HIV and CMV, what they do is induce apoptosis of the CTL that is coming to clear the infection, for example, by inducing this FASL, this ligand, that induce apoptosis. So this is a very classic example of some viral defense that is counteracted by viral proteins. The other thing that is clear is that the tissue tropism of the virus is very important. There are certain privileged organs where the immune responses are different. So the virus doesn't have to invest a lot of energy there, because if it gets into the right niche, it can live there for a long time without being cleared by CTLs. And a classical example is the CNS, for example, but also the vitreous humor in the eye and some areas in the lymphoid organs. All these areas are immunoprivileged areas that clearly can be places where we may actually see these persistent infected infections. Of course, one thing that is sort of an overall theme is many viruses choose to infect cells of the immune system for a number of reasons. Maybe there are more available cells. The virus can be transported to different places in the body of the infected individual, and that might facilitate transmission, for example. But also, this could be a strategy of the viruses to try to block the immune responses, or the correct immune response. And this is a classical example, this HIV one, where infecting CD4 cells disrupt the regulation of the immune system. So I just want to touch on a couple examples. And measles is an RNA viruses, is a negative stranded RNA viruses with one single genome. And many, many people die of this measles, but it's preventable by vaccination. Once again, education is an important aspect here because vaccines are being attacked these days. And the vaccine induces long life immunity, but if you're not immunized, you can end up with this very severe subcutaneous sclerosis, panencephalitis, which is a progressive degenerative encephalitis. And what happened is very interesting. The genome of this virus gets deleted, and there is a subgenomic RNA. And it's deleted because during the viral replication, the RNA polymerase makes a mistake and delete a piece of the genome. And now the virus often doesn't carry the envelope proteins, and the question is how it's transmitted, but this virus is able to induce syncytials, can be transmitted through synapses, and what is seen in these patients is that the virus is able to persist for many, many years, and you can detect actually viral particles in different parts of the brain of patients that are, in autopsies of people that are dying for other reasons. So the genome is spreading is an important point here because this virus is finding a way to spread through the not only persist but also spread through the synapses, these connections. So in SARS-CoV-2, we all know about this genome, and I just wanted to point out that all these genomic RNAs in this part on the 3' end of the genome, they are generated because when the polymerase is reading this part, it slow down in this specific cis-actin elements, these TRS, and also here marked in these black segments. And the polymerase is slow down there and jump to the other end of the genome here, and it captures this other piece of RNA, the lRNA. In the lRNA, you have cis-actin sequence that are important for translation, but also for replication. So the subgenomic RNAs now have the 5' end cis-actin element for replication and the 3' end cis-actin element for replication. So the subgenomic RNAs can actually amplify it, and they amplify it 100 times more than the whole genome. And so when we sequence, either in cell culture or in infected animals, what we see is that this process here in D is the normal process. You see a deletion of this area here, ORF1A and ORF1B, and the pickup of the subgenomic replicons and this amplification that I was talking about. But there's also these other type of jumps that are not the ones that are regulated by these 6 actin elements. They are less frequent, but is observed. So in a way, what you can imagine is that the polymerase is prone to jump. This jump is facilitated by these 6 actin elements, but sometimes it makes mistakes and it jumps in the wrong place. The consequence of that is that you see an accumulation of subgenomic genomes and infected cells that don't have the entire genome. This is what we call defective particles, defective genomes. And these genomes is really very intriguing. What is the function? Some evidence indicate that the generation of these subgenomic RNAs attenuate viral infection, so reduce, because it compete with the full-length genome, for example. And this type of things, one of the things that I just wanted to point out, RNA stability is measured in hours, maybe a day, but not in weeks and months. So if we see RNA or even proteins of SARS-CoV-2 persisting in infected individuals, I would argue that there must be a source of polymerase. Now, the polymerase is encoded in ORF1A or 1B. You need the entire unit. So if you delete this part, where the polymerase protease come from? And I would argue that there's two possibilities, is that there is a co-infection, and there is a little bit of a full-length genome, or there is these big deletions are not what is causing these persisting infections, but maybe other kind of deletions. And that is what we observe in Coxsackie virus, another RNA virus that causes persisting infection in heart and also in pancreas. And the arrow, this blue arrow, is showing this small clover leaf RNA structure that is essential for RNA replication. And what we know now is that patients with dilated heart, they have accumulated viruses with a genome that has small deletions in this clover leaf. The consequence is that the entire viral replication, the rate of RNA synthesis is reduced. So the virus is not so damaging anymore. The virus does not replicate as strongly as the wild-type virus, but it persists because it cannot be cleared, because it has a way to downregulate MHC class 1. And this persistence, both in pancreas and heart, is inducing inflammatory response that result in these syndromes, this pathogenesis. One of the things that's interesting is when you go and see the pancreas of an infected monkey with this type of genomes, you see that only one cell out of million cells are positive for the viral genome. And yet, you see islands of interferon-stimulated genes around these infected cells. So the response to these fused infected cells, in this particular case, is inducing a high inflammatory response, which lead to pancreatitis, for example. So the question is, considering this case, considering what I was discussing with respect to how you maintain the RNA, one wonders if we, in SARS-CoV-2, we see the same thing, whether we see these inflammatory responses that we see in these other viruses. And I think the evidence is that we don't see these inflammatory responses, or we are not looking in the right tissues. Hepatitis V virus is another interesting case. It's like HIV in many ways. It's a RNA virus which actually has a reverse transcriptase that convert the RNA into DNA, and the genome that's encapsulated in the particle is partially DNA, partially RNA. Now, the difference with HIV gets integrated into the genome, whereas this virus lives for many years as an episome, a circular DNA that is in the nucleus of the infected cell, and it cannot be cleared. This episome gets associated with histones and gets silenced with histone, or regulated by silencing of the chromatin silencing. And the virus, many people in the world is infected with hepatitis V virus, and right now the therapeutic target is try to see how we can eliminate this persistent infection that results in cancer, hepatitis cancer. HCV, another case, and HCV is very interesting because 60 to 90% of people gets this persistent infection. So the virus per se is not; it doesn't replicate very well, and probably this is why, and also because liver is a special organ. This is why this virus induces this very frequently, this persistent infection, and viruses not recover that frequently, so there's less possibility of recover virus, but that viral genome is there. And after 30 years, again, this causes cancer. Now, finally, the latent infections. like produced by DNA viruses. These are the most classic and well-accepted viruses that cause persistent infections. And here we have viruses that produce viral gene products, but the cell sometimes is it doesn't produce, it doesn't replicate. For example, in the case of just to point out the different DNA viruses, and herpes virus, for example, it will infect neurons, and neurons do not duplicate or don't divide as often as other cells. So the genome is not diluted by the cell proliferation. And so the genome does not replicate. It's completely silent. There is no proteins being produced. There's no RNA being produced. It's essentially silent. The only thing it's producing is a few microRNAs that control the viral gene expression. In contrast, EBV, for example, or CMV, they actually are self-replicating DNAs, like in the hepatitis B virus, and these viruses live, for example, in B cells, and they do express certain proteins, and so they need to do something to prevent that the cell will be detected as an infected cell. And finally, there's this herpes HHB6 is another herpes virus, in this case, integrate like HIV in the chromosome. And quickly, because my time is I'm running out of time now, I just wanted to point out that many people are infected with herpes virus. Herpes can live for a long time in sensory neurons and gets reactivated. And the reactivation is only in few neurons, and it causes these mucosal tissue blisters. And the activation by herpes virus is by modifying the chromatin that is silencing the genome. So at some point, there is stress, UV, other effects that activate or eliminate the silencing produced by the chromatin. The virus gets activated and starts to replicate. In the case of Epstein-Barr virus, 95% of the adults in the US are infected. It lives in B cells, during the acute phase, induces infectious mononucleosis, but in the long run, it could also induce cancer. And just here, just put a schematic that the virus infect through the saliva. So this is why this virus is so infectious and it is transmitted. But immediately after the infection, establish a persistent infection in these B cells. They can live in bone marrow or when lymphoid tissues, and induce certain, you can see the infected cells because there are some antigens, these EVA, that mark the genomes because this virus is actually replicating because it needs to replicate to be maintained in these B cells. And at some point, these B cells get activated. And I wanted to emphasize this because what I'm going to tell you in a minute. Gets activated probably because there is some other infection, and this activation result in the production of, or the induction of this, another round of replication of EBV, which result in new virions, and this is probably how the virus transmitted. So I just wanted to leave you with this thing, this picture. There are so many different persistent infections that most people have, and the question could be that if there is an interaction between SARS-CoV-2 infection and these other persistent infections, one needs to look at this in a more holistic way and not just one thing. And also, if you are activating different persistent viruses, dormant viruses, maybe the response, the immune response that you're going to notice is going to be different in different patients. we've been doing some of this work on SARS-CoV-2 transmission using this household cohort where we identify an index case and then we engage the entire household in a study that basically is designed by studying every day or collecting everyday saliva and nasal swab and feces and tears over 28 days. And this allows us to look at transmission, who was infected with what, when, and also the kinetics of replication, because we can see people that were not infected and then get infected, and we can see at day 2 or 3 infection. So this provides some information that in large cohorts we don't have, but this more sort of precise cohort might give us that information. And this particular cohort, we've been looking at 4 months post-infection, post-acute infection in patients, and we identified in the cohort there was 300 families and more than 1,000 patients. But in this particular case, we identified about 31 past cases compared with 73 non-past cases. Females, males is about 50%. And with that, we could ask the question at the time of acute. So we noticed this 4 months later, so we can go back to the repository and see what happened during the acute infection. And what you can see that both by PCR, the viral load, or infectious virus isolation, those individuals that were eventually developing PASC has a significant increase in virus replication in the acute phase, and also you can see that lasts longer. You can see that at 15, 16, 18 days, you still can detect virus in saliva and nasal swabs, and this probably is the simple idea here is that if the virus initially replicates better, if you initially, because your immune condition or physiology or whatever, you allow SARS-CoV-2 to replicate higher, or if you have not been vaccinated, then the virus has higher chance to establish some kind of infection or inflammation in certain tissues because it will be spread with higher probability to other tissues. And this is just something that we've been discussing, so I'm not going to use my time on this, but it's just to say that now it's very clear that the virus is pleiotropic in terms of the tissue distribution. This is 11 patients that have been died with COVID. And you can see that, I think this paper was mentioned early today. You can see that there are RNA in many tissues, including the CNS, and proteins in the CNS. This is this picture corresponds to, I think, 14 days post-infection, but there is also cases that were detected more than 30 days post-infection in this particular patient. So the involvement of the CNS, I think, is reasonable to accept it. And here's just to bring this idea that in this particular study, they divide in 5 different classes depending on the symptoms, and you can see that the inflammation patterns, and these are all inflammatory genes, are very different. In yellow, you can see that this in this area here, these particular clusters are inducing some inflammatory genes that the other clusters don't. So it's this long COVID could be very different, classified depending on the immune response. And finally, one thing that is a little bit ongoing, but I didn't have the time to put together, and this very early times. But what we can say is that in our cohort, we see that there is an activation or reactivation of EBV based on 3 criteria. One is that We see IgGs that normally you don't see IgGs against ABV in these patients. We also see right now some evidence correlation about 50% of the people that we have in the cohort, but it's a very small cohort. They have DNA, EBV DNA by PCR. And right now we're doing sequencing metagenomic studies to try to understand whether there's different viruses are reactivated in this context. And finally, I just wanted to acknowledge the people that were involved. Dan Kelly and Michael Peluso, both of them are colleagues of us with Monica and UCSF, and we've been collaborating since the beginning of the pandemic. And Miguel, Michelle, and Jing are Jing is a student, and Miguel and Michelle are postdocs. Actually, Miguel just took a position in Mexico. And thank you for the attention.
That was excellent. Both talks were excellent. That was exactly what we wanted, which was to really go over all the viral families. While people are raising their hand for questions, I have one for you, Raul, which is, it seems like, can you explain SSPE a little bit more? There's no infectious virus, and yet the genome is still spreading. Because you just showed in that last SARS-CoV-2 slide that infectious virus, even in PAX patients, does go away. And so what is the mechanism by which it's still spreading, even with MHC1 downclassing?
Is it working?
Yes, just press the...
Yeah. Press this? No.
Oh, press this. Oh, okay.
Is it working? Yeah. Working? Yeah. Yeah, so I think what happened there in the measles virus, you have a deletion of one protein that is required for full genome packaging, but you still have certain proteins that enable transmission of this RNP, RNA protein complex. The RNA protein complex is the unit of the infectious unit. This can be replicated, encode the polymerase, and this is the important thing, that if the polymerase and replication machinery is still encoded, this shorter RNAs can actually replicate and propagate. Now, how exactly is propagating from neuron to neuron is not absolutely known. I just saw a report that the envelope protein, there's two kinds of envelope proteins. One can cause syncytia, and in patients where they develop this, you see more of the protein that produces syncytia. This is a little bit of evolution. What virus is the one causing? So probably that protein and the syncytia is important for transmission.
Thank you so much. Does anyone have any questions for either Dr. Paredes or Dr. Andino? And it looks like there's one here, one here, one here. So 3 already and 4. Yeah, so could, do we need the microphones or? Okay, go ahead, please, one.
You can go first.
Okay,
I'll go first.
Yeah.
Sorry, I'm Carolyn Bramante. I'm the PI of the metformin trial that you referenced, and it's actually pretty consistent with the data that you showed in your figure 3 or figure 1 of your Lancet Regional Health paper. The odds ratio for post-COVID condition in people with diabetes was 0.38, and that's virtually the same as the odds ratio for developing long COVID in our trial for people who started metformin within less than 4 days of symptom onset. So it's nice to see that consistency across your data and our clinical trial data.
Oh, that's great.
Yeah, thank you very much. I'm really looking forward. I think your paper is amazing, and I'm really looking forward to know more about that.
Yeah, oh, that's great. It's really nice to see you. Okay, number 2 is over here.
Roger, that was a great summary again, and very interesting data. So next week we have the COVID Clinical Forum, and in preparing for that, looking at the updated WHO guidelines, they've sort of placed treatment for people who are only at moderate risk, which according to their definition includes those over 65 and those with coexisting morbidities, as sort of weak evidence for treatment, ignoring really the potential impact of treatment on prevention of long COVID.
Yeah.
So I was wondering if you could comment on that, and then related to that is there any evidence from people who received either corticosteroids or remdesivir with moderate to severe disease that there's an impact on the incidence of long COVID?
So if I had any power, I would certainly recommend, and this is my personal opinion, it's not, but I would certainly recommend that the long COVID patients be included as a preferential group of patients to be treated, also to avoid reinfections. But at the same time, also I think you're not actually asking about the long COVID patients. So you're asking about outpatients. I think that the evidence is increasing. The evidence is There's evidence from the ritonavir studies. There's evidence also from the Shinogi studies and ensitrelvir. There's evidence on metformin. And I think that so far the reason for receiving these early antivirals was to avoid hospitalizations. With some exceptions in highly immunocompromised patients, the rate of hospitalization is very low. And now there's a shift. We had a discussion paper like saying, okay, maybe now the endpoint should be improvement of symptoms, but then the cost of that drug is different because what you gain out of it. But however, in terms of reducing long COVID, I think long COVID is at least, I don't want to get into battles number, but it's at least 5%. Hospitalizations are 2%. So I'm completely in favor. And then there's also some, I've been involved in some studies also with other antivirals in hospitalized patients, and there seems to be also an effect. I think that this idea of treating virus infection very early is favorable all the way around.
Okay, let's go to number 3. We also have one on the chat.
I have a question for Dr. Andino. First, thanks for the great overview on viral persistence. I wondered if you could elaborate a little more on SARS-CoV-2. You showed us the possibility of aberrant jumps to make subgenomic RNAs. Is this happening in vivo? Has it been detected? And could it depend on the type of cells that is being infected? For instance, we heard yesterday about macrophages infection. Could this happen in epithelial cells?
Yeah, so that's a good question. It's hard to know at this point whether there is any cell dependency for the frequency of this kind of errors in the replication. In general, you see it in cell cultures more or less with the same frequency in different cell lines. In vivo has been detected, but obviously one of the things that we don't have is a good data on long COVID, for example, persisting infections in patients. I think that would be so important to do it. It's difficult because it's you don't have too much RNA, as we discussed earlier today, and it's a very long RNA that you need to amplify. So for sequencing and that kind of thing is difficult. So we need to improve our methods to detect that.
Okay, we actually have one on the virtual audience, and I'll go to 1, 2, 3, and I think that will be it. So quickly, this is for Roger. Do you know why depression is one of the risk factors?
So depression is interesting. We also, as I mentioned before, it was one of the skepticals at the beginning. So we looked at depression tests formally in our very early in our patients, and in summary, there was no depression. Very little amount of really depression, but over time, our patients increasingly became depressed. So because of this idea that they don't recover. But initially we
we ruled out depression as a major factor, actually. There might be some people who are depressed because depression is very frequent, but over time, they really become depressed when they see that they don't improve.
Okay, so maybe predictor versus. Then one over here.
Thank you. Question to Professor Paredes. Roger, congratulations for leading so many successful initiatives in COVID-19 and long COVID. I want to ask you about the Chinese cohort of Professor Bing Cao. They just published the 3-year outcomes. I'm sure that they are working in the 4-year outcomes. It seems to me that the incidence of long COVID is less and is also milder in China. Do you think that long COVID in China is different than in the West? Can you comment on that?
So I'm not sure that the long COVID is different in China than in the US or in the West. I think that the overall incidence rates could be decreasing, and there are also other reports in the US, I think, showing that the overall incidence rate is decreasing, and this is good news. But these are rates, and so you need to think about the absolute numbers of patients. Even though with Omicron and with increased vaccination rates in the cohort, that's having an impact in long COVID. We have the proportion of new long COVID cases is lower than in the past, but that does not mean that the problem is going away. I don't know if I answered.
Okay, and 2 over here.
And the congratulations is for the team, not me. Thanks.
So thank you. Excuse me, I will ask 2 questions, one for my colleague, for you, Roger, and one for Raul. Your presentation was really fantastic. And Roger also. So for Roger, it is, you have noted that the tertiary or higher education level was linked to the risk of PASC. So why? Do you think it's because of the difficulty of access to the out-COVID clinic, or is it for another reason?
So we don't know. I mean, we cannot, we decided to report this. I think it's a very interesting finding. We don't have an explanation. There are 2 options. One is that one is more of a, let's say, a social biological option, which is people with a higher level of education might have more, let's say, brain reserve. Yes. But forgive me for using the wrong terms. I'm not a neurologist or neurophysiologist. The other option is also that there are social determinants of health. COVID and all infectious diseases have hit much harder underserved populations. It is possible that people who are poorer have less access to, and also the educational level might be highlighting people who have a lower social environment. So the truth is that I don't know, but I think it's certainly we should explore more.
Okay, and then your second question, and then
yes.
we'll go to 3. And then
so
we'll
it's for Raul. In which type of structure do you think the virus remains inside the cell? It is in exosome or elsewhere? And do you eliminate completely the risk of integration, for example, in DNA?
The integration
yes.
in DNA. Those are good questions. In general, what I've seen on this data on patients, it seems that the RNA is associated with Golgi or ER, where more or less where there's the concentration of the RNA replication machinery is where the RNA is made in the cell, in the cytoplasm. Whether there is any reverse transcription by endogenous retroviruses to create DNA in the context of this, I don't think it has been addressed. It's a very interesting problem, because these endogenous retroviruses often get activated during stress. Infection is a stress, so it could be that there is something like that, and this will not require then the polymerase of the virus or anything, because it will be integrated into the genome like HIV. So it's a very good idea, and maybe somebody has to look at that. Yes.
Okay, last question.
So one question to Roger. It seems to me that you are very enthusiastic, as I am, about the finding of metformin given in the acute phase, reduced by 40% the risk of long COVID. Are you aware of anyone who studied metformin in the treatment of long COVID, and to what extent this may be at the basis of a synotherapeutic approach in long COVID and addressing the fact that presumably there are signs that long COVID may produce accelerated aging?
I'm excited about metformin, but also on the antivirals. I would say I come from the antiviral world. But I think, in short, I am not aware. This is a trial that should be done. It might be being done, and I just missed it. So sorry, but because maybe you're raising your hand, so that could be happening. What I think, and maybe we'll discuss more about tomorrow, I think we need to start. So we have been in an observational phase, let's say. We've been characterizing our patients. We need to continue to characterize our patients, of course, and get a big, but what we really need is adaptive clinical trials that test the different hypotheses. Metformin is certainly a good candidate from my point of view. Also, other antivirals, I mean, there will be a lot of discussion.
Actually, I thought this meeting ended with a lot of hope with that last question, with the metformin, with antivirals, with figuring out both those agents to prevent and treat long COVID. So thank you so much for the great talks, Dr. Andino and Dr. Paredes. And thank you very much. We'll convene for lunch.
Thank you.
Okay, so we're going to get started on the next session now. Just an announcement before we start. We're going to change it up a little bit. In this session, the first two speakers, who are both going to be speaking about treatment, will speak, and then we'll follow that by a Q&A for both of those first two speakers. So we'll hear two speakers followed by a Q&A. The third speaker is going to be joining us remotely. We have a recording for that third speaker that we'll listen to, and then we're very pleased that speaker will be on Zoom, so we can still have the Q&A for that speaker, and then finally we'll have the two abstracts. So a little bit different format for this, but I think we're good to go, and so we'll get started right away.
Alors, I'm very happy to present you, Dominique Salmon. Dominique Salmon is an infectious disease doctor in Paris, professor in French. She has a long work on and investigate major project in the field of HIV and hepatitis C. Since May 2020, she has been involved in the clinical management of long COVID patients, and remains a driving force in France for research in this field. We listen to you, Dominique, especially in the current treatment option.
Thank you, Amélie, for this kind invitation. Good afternoon. I hope everybody goes on well. I have not the first slide. Never mind. Huh? Currently, we know that there are more and more arguments that long COVID is only an extension of a viral disease, but no treatment addressing its underlying physiopathology is yet available, such as antiviral and or immunomodulatory drugs. However, also we have to be humble. We have few therapeutic options. A symptomatic approach is necessary and useful. So I am happy to suggest you the following plan. First, diagnostic stage, current available approaches, then the research therapeutic option, and to discuss with you the remaining challenges. The first stage is to identify specific diagnoses that can be treated by a detail-oriented and empathetic listing, and to opt for complementary assessment. Once this stage has been obtained, you can have a specific organ-based lesion to treat, for example, hyperventilation symptoms, POTS, cutaneous urticaria, digestive syndrome, irritable bowel syndrome, etc. The second stage, as it is recommended in France, and you will tell me if it's different in other countries, it is a current strategy that is currently based on 4 pillars. The first pillar is the symptomatic treatments. The second one is information and self-management by the patients themselves. The third pillar, very interesting, is rehabilitation. And the fourth one is the management of anxiety and disorder that are not always present, but if present, it's important to take that in count. Concerning the symptomatic treatment, they need to be individualized before finding a treatment tailored to each patient. So it takes often 3 or 4 consultations to obtain something. Regarding pain, we can use analgesic, anti-inflammatory drugs, or anticonvulsant in neuropathy. It's better to avoid high-dose corticosteroid. Also, low dose may be useful in case of some symptoms, for example, arthritis, myositis. For POTS, who is really frequent, beta blocker or ivabradine in case of hypotension can be useful. And in this context, there is a trial with ivabradine, 5 milligram BID, showing really an effect on the Hertz rate. So it's one of the first trials that was published. For bronchial hyperreactivity, that is also a frequent symptom, you can use bronchodilatator. Our colleague pneumologists often use high-dose prednisone. I'm not sure it is the best, but it is used. Always in this field of symptomatic treatment, a lot of our patients have digestive symptoms. So usual treatment like anti-ulcer may be used, but antihistamine, anti-H2 histamine is really useful in case of irritable bowel symptoms. Don't overlook also the possibility that some patients have gastroparesis, and in this case, we can use specific treatment, like in patients from ICU, low-dose erythromycins. The use of probiotic or butyrate supplementation can be also useful. A part of our patients, not all, it's really not a treatment who has to be given to all patients at the same time because we have different profile, but some of our patients, about 10-20%, have symptoms suggestive of mast cell activation. It's often a combination of symptoms, cutaneous, digestive, muscular, and in this case, antihistamine H1 and H2 combination can be useful. A poor diet, with histamine poor diet, and also sodium chromoglycate before meals. And in case you have to use very big dose or you have severe symptom, an allergologic advice is necessary. Antihistamine is a field where we have already pilot studies. Here, there is a pilot study of 20 cases of patients who receive either no treatment, either a combination of anti-H1, loratadine, or fexofenadine, and famotidine. And in the second trial, 14 patients received anti-H1 and anti-H2 versus 13 control. And you can see that at baseline, the patient did not differ for those symptoms: fatigue, brain fog, increased heart rate, and abdominal pain. But after 20 days of this treatment, there was a decrease, not only in fatigue, but also in brain fog, increased heart rate, and abdominal pain. So, of course, if it doesn't work, we have to stop those drugs after 20 days or 1 month. But sometimes it's really useful. And a randomized trial is underway. You can find all the trials that are underway on the website clinicaltrial.gov. Concerning neurovegetative symptoms, it's much more difficult, as it is in the rest of neurology in general. You can first recommend to your patient non-pharmacological measures that are listed on the right of the slides. Replace the treatment exacerbating hypotension, for example, beta blocker, tricyclic antidepressant, and seek for specialized advice in case of severe symptoms. Sometimes some patients need to get Milodrine or fludrocortisone, but it's quite rare. So I will not list all the symptoms because, as you know, there is a long list of symptoms, but it is the same pragmatic attitude for sleep disorder, cutaneous symptoms, etc. So that was the first pillar. The second pillar is training the patient to self-management. A lot of patients, they overestimate their functional capacities and they are unaware of the situation responsible for symptom exacerbation. So such worsening may lead to a malaise that's called post-exertional malaise. So it's important to train them on energy conservation technique, and the global word is pacing, and my colleague Fanny Brunet will detail this approach. She will also detail the third pillar, that is rehabilitation. There is a lot of rehabilitation possible in different domains. We don't know exactly why it works. Probably it educates some region of the brain that are not armed to compensate the regions that are armed. The fourth pillar is the management of anxiety and depressive disorder. So also not present in all patients. The screening of those manifestations is important. Some patients may have, for example, post-traumatic stress because they have been in ICU for 1 months. Some other have suicidal idea. So it's really important to discuss with the patient directly of these aspects. And the classical treatment are really not contraindicated. For example, on anxiolytics, antidepressive drugs, and mainly of the series of selective serotonin or noradrenaline reuptake inhibitors. And we know that serum serotonin are low in COVID. So those drugs probably increase the level of serotonin, and it's known also that those drugs have other properties, immunomodulatory properties. And in mice, for example, it has been shown that fluoxetine was able to reverse some neurocognitive function. It's for Guillermo. Okay, so probably also in man, those drugs can also improve the cognitive function. So let's move now to the future. Many clinical trials are underway for the treatment of long COVID, but there is few causal intervention. So I took from the website those that could be interesting and class them into 4 classes: those with antiviral potential effect, those with immunomodulatory effect, those concerning anticoagulant approach or oxygenation, and the last part, rehabilitation approach, and also Fanny will deal with that. First, be aware that all those studies published so far are really small study, usually pilot study, sometimes randomized or not. They lack power. The relative effectiveness is quite low. The rationale is not always clear, but it's like that in medicine when you test. And there is no follow-up. It is a main drawback. So you have an effect, but you don't know when you stop what will be the evolution of the patient after. Anyway, what is available concerning antiviral approach? After having observed some case of improvement with Paxlovid, also there is relapse, there are several randomized trials that are currently testing Paxlovid, at least 2. One, the Pax Long COVID trial that has enrolled 100 patients in 2 arms, one arm with 15 days Paxlovid and 15 days ritonavir in the other arm, and a recover trial with 900 patients, so much more ambitious, with 3 arms, one arm receiving 20 days of Paxlovid, one arm 15 days of Paxlovid, so 5 days is not sufficient, and one arm with ritonavir. So both trials are underway, but I think we will have the results at the beginning of next year. And you can see that the main endpoint is for the moment a clinical endpoint. I think there will be sub-study within those trials for virological endpoint. Another trial, very interesting, it is a temelimab long COVID trial. Temelimab is a monoclonal antibody directed against a protein, the name is HERV-W, involved in microglial activation. This protein is a retroviral protein, endogenous human retroviral protein with abnormal expression, can be triggered by SARS-CoV-2. It's present in brain of patients with multiple sclerosis and sometimes in patients with SARS-CoV-2. And when it is present, it aggravates the phenotype of microglial cells in aggressive phenotypes and gives the lesion. So the patients that are included in those trials are patients with long COVID, with neurocognitive disorder, and who are positive for HER2. There is a phase of screening. They receive temelimab, IV, several infusions over 6 months, or placebo for 6 months. The main endpoint is also a clinical global health endpoint. So I know that there is 2 trials that are nearly have finished the inclusion. So I think we will have also soon the result of those first trials. It will be very interesting. Let's change now to the immunomodulatory approach, what is in this field. So not a lot of things. However, there is a possibility maybe with low-dose naltrexone. Naltrexone is an antagonist of an opioid receptors. It exerts anti-inflammatory and immunomodulatory activities, and it's used in some conditions that overlap with PACS, for example, chronic pain, multiple sclerosis. So there is very little results, but there is, for example, a retrospective cohort of 59 patients who receive a median dose of 2 milligrams, so you know it's tenfold less than the dose you use in drug users, and for a median duration of 143 days. And at the end of the treatment, 62.5% of the patients reported improvement of at least one symptoms. 5 had to discontinue because of adverse events. So there is also a placebo-controlled trial, at least one, that is underway on the 160 patients in British Columbia University. Alors, a trial that is it's not a trial, and it's just a very recent report of 3 cases, very striking, of patients who had severe long COVID symptoms and had a rapid remission after 1 infusion of monoclonal antibody. I'm sure you all have seen these things. The initial infection was with pre-Delta variant, and they received the first generation of monoclonal antibody. It was casirivimab and indevimab. The name is Renoprev. So it's 3 on a series. The authors say in their letters that there is a series. And we don't know the exact mechanism of action. Is it a neutralization of the virus? It is a displacement of autoantibodies. Is it an enhancement of some immune response? We don't know, but it's interesting. And there is also a placebo-controlled trial ongoing on this field. Last for this part, it is the approach pursued by Patterson with maravigorot and pravastatin. Okay, I know there is a lot of criticism against its approach, but it is published. Huh? So in cardiovascular disease, we know that activated platelet, monocyte, and endothelial cells interact to create a prothrombotic environment and vasculitis. And in long COVID, it has been shown that spike protein was inside some kind of monocytes, the CD16 plus monocytes, and those monocytes activated express CCR5 and CX3CR1 fractaling. So the hypothesis is that by using maraviroc, which is a CCR5 antagonist, and pravastatin, which is a CCR3-CR1 antagonist, this could disrupt this adhesion between monocyte, endothelial, and platelet and lead to macrophage monocyte apoptosis. So they published a pilot study with 18 patients who received the combination for 12 weeks, and they observed a decrease in some vascular markers, especially VEGF, and CD40L, and also an improvement in some function. So I know that some patients, they go to Patterson, they pay a lot to have this approach. I discussed with the team. The team told me that it is not constantly efficient, and the effect is not permanent, and sometimes there is also reactivation of latent virus. So be aware that it is really only pilot things. So let's move now to the anticoagulant and tissue oxygenation approach. So we had this morning wonderful talk by Eteresia Pretorius, but she didn't show her results because they are only on preprint. Donc following what she explained us, the finding of fibrin, amyloid microclots, and platelet hyperactivation, she treated 91 South African patients with dual platelet therapy, clopidogrel and aspirin, and oral anticoagulant therapy. For 2 to 4 months, there was those who were very early in the symptoms, they received 2 months. Those who were late in the symptoms, they received 5 to 6 months. And at the end, you can see on the right, they observed a decrease in a lot of symptoms. So it's an open study. We know that also long COVID could improve slowly. So it's only the beginning, but it's interesting. And I had a look on the secondary effect, because of course, to receive triple anticoagulant therapy, it's quite dangerous. So there was 5 patients who reported serious bleeding. But I think it's quite a fascinating approach, going well in the context of the physiopathology, and it's worth doing a randomized trial to prove if it's efficient or not. Also in these fields to improve oxygenation, there is a trial that tested hyperbaric oxygen therapy on neurological function. So you know that HBTO is sometimes used for patients after acute stroke or neurological severe confusion to improve neurocognitive function. In this trial, 73 patients with neurocognitive disorder received 40 sessions of HBTO at 100% oxygen on 2 atmospheres versus control who receive only normal oxygen therapy. So it lasts a few months. It's very heavy as approach. And 3 weeks after the last session, a modest but significant improvement was observed, first in brain perfusion, and secondly on cognitive function. It's really modest. It's really modest, and the limit of this article is that there is no follow-up. So we don't know if it's a permanent effect. But it's interesting, and it asks me the question of giving sometimes oxygen for the patients who are really severe to improve oxygenation. So other approach, I will not detail 70 trial, and just to focus to finish on the vagus nerve stimulation, vagus nerve inflammation and parasympathetic dysfunction. We all know that it is important in long COVID and that it contributes to dysautonomia. So the aim of VNS is to increase parasympathetic pathway and restore the balance between vagal, who is low, and sympathetic pathway will remain high. So it's an approach that a patient can have at home by self-administration at home of an auricular sonde, je sais pas comment dire. Okay. And in animal study of inflammation, VNS was associated with a decrease of inflammation, with an increase of anti-inflammatory effect, and a decreased tissue injury and increased survival. So our colleague from Belgium, they were the first to use this approach. They published in 2020 a small study where 20 subjects were treated daily for 35 minutes for 10 days with this approach, and they showed that nearly all patients had an improvement in symptoms, but there was no modification of inflammatory marker. So I had a look on the web and found that there were 3 little studies in this field. The first with 12 patients who received VNS or control for 2 weeks, and then there was an open label for VNS for everybody. Another study with 14 patients that were treated for 6 weeks, and in this cohort, 8 over 14 had an improvement. And at the first Congress in Belgium on long COVID last month, Professor Verbranck showed his results on 175 long COVID patients and that were treated with VNS, and showed that there was an improvement in 69% of them, and mainly on patients who had dysautonomia. It was partial in 96, and there was no improvement in 26. So I think that is also a logical approach, except if our patients are very, very impaired with dysautonomia. Maybe if there is some action of the vagus nerve remaining, it can help. So there are still many challenges. We are only at the beginning, and the three main challenges for me are to elucidate the interrelation between all the potential mechanisms that we have discussed. The first question is, are the viral antigens that we found, do they reflect replicative virus or not? And what is the exact toxicity of spike? That is really the two questions that we discussed this year, and I think next year we will have the solution. The second really important thing is to find a biomarker for long COVID. So it will allow to make a diagnosis, to guide therapeutic research, and several biomarkers have been discussed: the cytokine, the spike protein level, the metabolomic profile. Maybe it could be interesting, but not are present. But no marker is present in all population. For I think that our population are too heterogeneous. So it's not a cluster at the beginning, but maybe it's an evolution profile. We must define very different populations, severe, not severe. Because if we pull all the patients in the same study, it's confusing. And the last challenge, of course, is to find etiological treatment. Probably it will not be only an antiviral treatment, but maybe a combination of antiviral and maybe anti-inflammatory drug capable to cut this vicious circle. And at the end, we are only at the beginning of this therapeutic research, but even if we are at the beginning, we cannot let the patient in such dramatic situation. And it's crucial to begin trials. We have done that for acute COVID, we have done that for HIV, and even if the trial will not lead to the direct success, even a failure is important to learn something, and we can build on that. And I wanted to cite the Recover Initiative from US. The NIH have defined 5 main axes: dysautonomia, cognitive dysfunction, fatigue, exercise intolerance, sleep disorder, viral persistence, and in each field there is a team building not only physiopathological study but also clinical study. So I hope that in Europe we will be able to join and to do the same. Thank you very much.
Many thanks, Dominique. I introduce now Dr. Fanny Brunet. She's doctor specializing in functional rehabilitation in a public hospital in France in Saint-Maurice. She's a member for French health authorities group that drew up recommendation for therapeutic management. And now we listen to you with a particular focus on a PEM.
So hello everybody, I'm very happy to be here with you. So let's talk about rehabilitation and post-exertional malaise management. We can say PEM management. So, nothing to disclose. The plan is, firstly, I will explore with you symptoms and syndromes we deal with in rehabilitation. Secondly, we will have a look at the latest scientific literature and French National Authority for Health recommendation. Thirdly, we will define what is a post-exertional malaise, a PEM, and how to deal with it. And finally, I will share with you our experience at the Saint-Maurice Hospital. It's a hospital near Paris. So, symptoms and syndromes we could manage in rehabilitation are the following. We have reduced aerobic exercise capacity. In the literature, you can find synonyms like deconditioning or muscle functional loss. We could manage hyperventilation syndrome, anosmia, cognitive impairment, and fatigue and PEM. Remember, yesterday we said fatigue and PEM are very important symptoms in long COVID, so it's very important to manage them. First, reduced aerobic exercise capacity. According to the scientific literature, there are a few randomized clinical trials available, but there is one meta-analysis of 14 randomized clinical trials, very interesting. They used different rehabilitation methods like muscle straightening, aerobic exercise, balance exercise, and respiratory rehabilitation. The others used the following assessment methods like 6-minute walking test, 30-second sit-to-stand test, MMRC for the dyspnea, pulmonary function test, and quality of life. The results are greater performance in 6-minute walking test and improvement of dyspnea and quality of life. Okay, but no concept of fatigue and PEM on this meta-analysis. Then we have the RECOV trial. It's a very interesting trial of 8 weeks with 4 groups. The first group followed a supervised training program, a little bit hard, without inspiratory muscle training. A little bit hard because there is resistance training, like a squat, bench press, moderate intensity variable training, and light intensity continuous training in pedaling. The second group followed an autonomous inspiratory muscle training program. What is it? It's just a protocol with this material, power breath, just here. One set of 30 repetitions twice a day, daily, throughout the week. The third group followed the supervised training program with the inspiratory muscle training. And the fourth group, it's a control group, with training based on the World Health Organization recommendation. The others use the following measurements: VO2 peak exercise test, muscle strength, MMRC, fatigue severity scale, and shoulder fatigue scale. The results are 80 participants in total, and patients in group 1 and 3 noticed a significant improvement in dyspnea, fatigue, and muscle strength, but not in the VO2 peak exercise test. But there is in the RECOV trial, there is no mention of PEM, neither. So now, what about hyperventilation syndrome? Hyperventilation syndrome is very recent. The cause is really unclear, maybe anxiety. But no randomized clinical trial available, but there are recommendations of the French National Authority for Health. Specialist physiotherapists are required. They have to observe the patient breath, to teach the patient to control their breath and at rest and during exercise. Maybe we could use relaxation, maybe sophrology, and self-training is also interesting. What about fatigue? Fatigue is sometimes assessed in previous study. There are 6 relevant studies in a little review with just case report and case series, non-clinical trial randomized. The program was just physical activity, aerobic exercise, resistance training, 3 days a week. The others used the following measurements: box scale and several fatigue scale, like fatigue severity scale, CES fatigue scale, and FACIT fatigue scale. The results are very encouraging, with a statistically significant decrease in board scale value, and nearly all patients felt fatigue. But, one more time, no mention of PEM. The recommendation of the French National Authority for Health or listen to the patient with empathy. The therapist has to listen to the patient with empathy. He has to look for signs of anxiety and depression. Every time he has to measure fatigue according to shoulder fatigue scale. He has to prevent fatigue with the patient by recognize energy limits in daily life and what triggers fatigue. It's very important. And he had to do moderate and progressive physical activity, and sometimes a psychotherapy if it's necessary. Now, cognitive impairment. So, for cognitive impairment, there is one case control study with a small group of patients who receive a 6-session intervention with just cognitive exercises, and the control group with any treatment. And it's a good news because we have, in the study, an improvement in performance of cognitive tasks and better quality of life. Several ongoing clinical trials, there is several ongoing clinical trials, such as COVCOG. What is COVCOG? It's a trial with 130 patients within 2 groups. One group with cognitive intervention, like psychoeducational modules, attention and working memory exercises, executive functions, and long-term memory exercises. One group with just affective intervention, and the others will do assessment before the treatment and 2 months and 8 months after treatment with a test with a neuropsychologist and many questionnaires like a brief MMQ and quality of life. It's an ongoing clinical trial. As for anosmia, there were no specialized long COVID review on anosmia, but we know that it is one non-specialized long COVID review. Treatment of post-viral olfactory dysfunction, rehabilitation is very effective to treat post-viral olfactory dysfunction. So the recommendation of the French National Authority for Health or patients need to undergo olfactory training twice a day, and patients have to smell odors with high molecular weight, like vanilla, coffee, essential oils. So now let's talk about PEM, post-exertional malaise. What is it? It's an intense state of exhaustion with a worsening of symptoms and reduction in performance after physical, cognitive, emotional activity that would not have caused problem before illness. This is a definition of the French Association of Chronic Fatigue Syndrome. Why? Because this symptom is really similar to that of chronic fatigue syndrome. This symptom often appears later, the next day or maybe 72 hours after exercise. The duration is 12 hours and more, and more than 50% of long COVID patients suffer from PEM. This is a Doppel questionnaire. It's a questionnaire which helps the therapist to diagnose PEM. The patient, for each symptom below, the patient have to circle one number for frequency and one number for severity. The higher the score is, the more frequent and severe the PEM is. So what can we do with patients with PEM and physical activity? Unfortunately, there is lack of scientific literature. Just one review and one case report interesting. The others suggest a similar rehabilitation protocol for POTS. POTS, it's a postural orthostatic tachycardia syndrome, and PEM patients. So they recommend a gradual rehabilitation, starting in a sitting position, if it's necessary, and progressively increase the difficulty over several weeks. And what is the recommendation of the French National Authority for Health for the physiotherapist? The physiotherapist has to diagnose PEM very early, evaluate aerobic and anaerobic physical capacity and fatigue with Pichot scale or Chalder scale. He has to do a rehabilitation program with the patient with aerobic exercises, but it could be only walking or bicycle, muscle straightening, and balance exercises. He has to adapt exercise intensity all the time, depending on Borg scale results. And he has to advise the patient to stay active after rehabilitation. In general, how to deal with fatigue and PEM with your patients. Patients can learn to prevent the occurrence of PEM thanks to pacing strategies. As said Dominique, pacing strategies means adapting and adjusting the different patients' activities in terms of physical, cognitive, emotional effort within the limits established by the illness. There is one retrospective French study made by a medical team in Angers, in France, with 86 long COVID patients. All patients applied pacing strategies. Engagement in pacing subscale was used for evaluation of degree of adherence to pacing strategies. And it's very good news because there is a link between high EPS scores and higher recovery improvement rates. How to teach pacing strategies to a patient? It could be very simple. First, ask patients to keep a daily diary. In this daily diary, patients should identify the triggers of PEM. They have to note type of activity, intensity, frequency, duration, such as effort, emotion, stress. And then, with this, they have to adapt the level of activity by every day prioritize tasks, planning, splitting the activity if it's necessary, getting a lot of rest, very important, and asking for help. And they had to conserve energy and stay positive. So now, let's talk about how we experience at the St. Maurice Hospital. We have a multidisciplinary rehabilitation program to manage fatigue, PEM, cognitive impairment, and reduced aerobic exercise capacity. First, we have a 4-step examination. A complete examination by a nurse and a physician specialized in rehabilitation with evaluation with several scales like HAD scale, shoulder fatigue scale, pain diagnostic questionnaire, and just a little physical evaluation with 10-meter walk test and 1-minute sit-to-stand test. Then a sport coach, not a physiotherapist, a sport coach, evaluates the patient's physical skills with balance, with the single leg stand test, strength, aerobic physical capacity, and fatigue. Thirdly, a neuropsychologist evaluates the patient's cognitive skills with a lot of evaluation, standard evaluation in neuropsychology, like memory, speech, executive function, and attention span. And finally, nurse and occupational therapist evaluate how the patient deals with fatigue. So what is the rehabilitation program? The rehabilitation program is at home because fatigue and PEM. First, patients do physical training with a sport coach twice a week during 6 weeks. The duration of each session is 45 minutes. Aerobic exercises, stretching, balance, and pacing strategies. The sport coach has to manage PEM if it's necessary. He could adapt the difficulty of the session in case of PEM, he could end the ongoing session, and he could simplify the exercises for the next one if it's necessary. Patients do cognitive training with a neuropsychologist after the sport coach, and thirdly, pacing strategies with nurse and occupational therapists. We have a discussion group with a physician and the neuropsychologist on 3 different topics: well-being, long COVID and family, long COVID and professional life. And finally, the physician follows up patients in consultation. To conclude and take home message, I think comprehensive rehabilitation program plays an important role in dealing with long COVID patients. It should be adapted to each patient's needs. Don't underestimate the importance of PEM management, even if scientific literature is very scarce. Pacing strategies prove effective in PEM management, but more clinical trials are required. Thank you for your attention.
There is any question now for Dominique or Fanny? I have a question for Dominique.
Yes.
Yes, since yesterday we talk about women with long COVID. They are very represent, and there is no current option for women for hormonotherapy or other thing.
In fact, we don't know for the moment why women are more at risk of long COVID. Maybe it's hormonal, maybe it's also genetic, we don't know. What can we do? We can sometimes, comment on appelle ça là?
Pilule.
Pilule, ouais, en anglais.
Estrogestative
Yes.
hormone.
Yes. What I do is for patients who have exacerbation during menstruation, I prescribe estroprogestative treatment. Like that, they have less exacerbation. But yes, it's a good question. I think we will find the reason.
Thank you. I had a question for Fanny. So the program is very personalized, and it's very interesting that it can be done at home because of obvious fatigability of the patients. But is it applicable? How do you manage to have these 3 people coming to the home of every patient? Is there support at the region, national level? Because it's very demanding on the clinicians and the therapists.
No, I don't think it doesn't exist in France. I think we are the only staff who do rehabilitation at home.
It's done in other diseases.
It could be done in other diseases, yes, in Parkinson's disease, other handicap, but not long COVID.
So one question for Dominique. And so you showed us different approaches. Do you believe that the capacity to clustering patients and symptoms may help to choose which kind of strategies and maybe multiple strategies according to the patient? Sometimes we use a clustering of symptoms. Maybe we are not clustering patient according, I don't know, metabolic and other issues. Do you believe this should be a way, in the absence of biomarkers, to choose for randomized clinical trial?
Yes. Yes, I think the clustering we use until now is not the only one. It's not the only good one, because we cluster by symptoms, but in fact, we realize that a lot of symptoms are of dysautonomic origin. For example, hyperventilation, but also digestive symptoms, also fever and shivering. So it's not the good way to cluster. One good way could be if we have biomarker, that's sure. If we have some patient with microclot and some with no microclot, with spike detection in blood and no spike detection in blood. And another way also could be to define trajectory. You know, trajectory over 1 or 2 years, because some patients are rapidly recovering, maybe they don't need something, but some patients are very severe, and those one, you can take the risk of giving anticoagulant therapy, for example, because they are at home, they pass the maximum of their time in bed, so those patients, they need more. It's not maybe the same way of, it is not the only way of classification. I think there will be other way, but a first answer to your question.
Hello, Vincent. I have a question for Fanny. You said that you give respiratory exercise for hyperventilation syndrome at home for patients. Do you have any idea of which kind of exercise?
You talk about self-training?
Yes.
Les exercices de respiration, qu'est-ce que tu donnes comme exercice à faire aux patients à la maison?
in our rehabilitation program, we don't have exercise at home for inspiratory exercise. You talk about recommendation of authority for health? No?
I thought you talked about it in your slide, but never mind.
No, okay.
Hello, my name is Troy. I'm a patient researcher from Renegade Research. I had a question about lactate testing for PEM when you're doing rehab with the patients. Have you ever tried or thought about trying doing lactate testing to get an objective measure that would be useful for both the clinician and for the patients?
No, we didn't make lactate testing. Did you have any information about lactate testing?
Yes, some people in my research group are studying high lactate levels in patients with long COVID, because it's been shown in patients with CFS, also having high resting lactate levels and postprandial lactate levels. And they haven't published the research, but there's already existing research on it. And I personally have used lactate testing for when I'm doing movement or exercise to see if I'm going above zone 2. And I find it useful for myself.
Okay, so there is a link between PEM and higher level of lactates?
There might be, I mean, theoretically.
Okay.
But I think personally, I see a connection.
Okay. Just a comment. Yes. Usually lactate are normal at rest. So if you measure lactate, it's after maximum exercise. I mean maximum for the patient.
Yes.
And then you observe high lactate levels.
Mm-hmm.
It's published. It's
Yes.
published, and it's an argument for the mitochondrial toxicity, dysfunction.
I just thought it would be something to use along with the Borg scale, so that the patient and the clinician could know that, oh, when they get to 3 or 5, that this would be the point when they should stop.
Thank you for that very lively discussion. I think it's time for us to move on to the next. Oh, I'm sorry, it's a patient rep. Do we have a patient representative here that wants to speak? Let's have one more.
Thank you very much, Fanny, for your talk. So Pauline Oustric, President of Association of France for Long COVID. I'm really impressed that you are the first, how do you call that, rehabilitation program that do it at home, because most of them are in hospital. Yes. And the problem with that is that patients can't have both rehabilitation plus working, going for socials, and most of the time they have to leave any social or professional duties. So I was wondering, do you have data, or do you know whether your patients are able to keep their work or other activities while doing your program? Because they're doing at home, so do you know whether they are still able to do it? Because most of the time patients with post-exertional malaise, when they go to rehabilitation, they have to stop everything else. So they can't do rehab plus going to work, plus helping at home, plus caring for the kids. So do you have any information on your patients on that?
During all the rehabilitation program, we can adapt. If a patient needs to work all the time, so you can do rehabilitation like physical activity during lunch time, but 1 per week, because of PEM, of fatigue. And, sorry, what is the second question?
That was the question, because we were in an association. The problem we see is that people who go to rehab, they have to quit their jobs, or they have to stop everything they have at home, because they can't do both. It's too difficult with fatigue and post-exertional malaise. So if they go to rehab, most of the time they stop working. So I wanted to know if you had that information on that.
No, it's a therapist who has to adapt the rehabilitation, not the patient. If a patient is able to work, it's not a problem for us. You know? we can adjust, and if it's necessary, we can do rehabilitation plus tard. Later.
Merci,
Okay.
Fanny.
Thank you for that important question. So we're going to continue on with the next speaker, who again is going to be giving a recorded talk, but will be available for the Q&A after. So I'm very pleased to introduce Dr. Terry Siegel. Dr. Siegel's expertise is in the area of general pediatrics, pediatric and adolescent endocrinology, and adolescent medicine, and is at the University College Hospital, London, and has been there since 2007. So she brings a tremendous amount of expertise in the area of post-COVID syndrome, as well as ME/CFS, and more broadly for adolescent and pediatric medicine. So welcome, Dr. Siegel.
Thank you for inviting me to speak at the conference, and I'm sorry that I'm not able to be there in person. SARS-CoV-2 has caused a spectrum of illnesses following infection, with the vast majority being asymptomatic or experiencing just a very mild illness. A few having severe COVID-19, and there have been a group getting multi-system inflammation. And then the post-COVID condition has affected some children and young people as well. I won't go over all of the definitions, as I'm sure they're well known to you, but the NICE definition is for adults, and the WHO created a children's definition in 2023, and there's the Delphi research definition for children. And these all are similar in the sense of having needed to have an infection plus a variety of symptoms which interfere in quality of life and may fluctuate or relapse over time. As COVID is less being tested for, this is going to confuse a diagnosis in the future. In terms of prevalence, it's complex and variable. As you can see at the long COVID in children and adolescents, a systemic review and meta-analysis on the left has showed quite a spectrum of different reports and has come to a pooled prevalence of about 25%. The limitations of this is that some of these are self-reported and there is not always a control group. And so there are different studies with different prevalences, such as the ZOE study, such as the CLOCK study, which looked at test positive and test negative young people in the UK and showed that 30% of test positive patients versus 16% of those negative had at least 3 symptoms. The Office of National Statistics, ONS data, shows the lowest prevalence of 0.5%. Clinical characteristics in the literature show that females are more affected by males, older than younger children, and comorbidities increase the odds ratio to get long COVID by 1.68. Hospitalization during the acute phase also increases the odds ratio, and vaccine reduces the risk a little. Omicron variant is the only one that's not associated with development of long COVID. Patients are more likely to have a family member with long COVID. Wolf et al. Undertook a systematic review of prospective cohort studies and showed that pre-existing asthma or rhinitis may increase the risk, and ADHD also may be a risk factor, according to Maison's paper. Children also had a higher risk of new conditions after COVID-19, such as mental health conditions, and genetic risk factors for severe and fatigue-dominant long COVID also exist. In terms of clinical presentation, every system in the body can be affected, from psychological with anxiety and depression and mood changes, cardiovascular, in particular palpitations, and tachycardia, especially on exertion, chest pain, breathing difficulties. These have been fully assessed in unpublished data from pediatric respiratory team, And the main diagnosis is dysfunctional breathing, and this may well have an autonomic link. GI issues are also common and can be quite variable. Other problems such as fatigue are extremely common. Post-exertional malaise is part and parcel, and we're seeing more and more autonomic dysfunction. Neurological symptoms such as headache and dizziness, blurred vision, and brain fog is a really debilitating symptom, causing blunting and memory issues. And ear, nose, and throat symptoms such as parosmia, rashes, COVID toes, and muscle pain, spasms, and joint pain. And importantly, these symptoms can follow on from COVID, or there can be a little gap. And you can also get long COVID from asymptomatic infection, and they do tend to fluctuate and relapse over time. This is looking at children and young people with long COVID, comparing those seen in our post-COVID services with the non-hospitalised national cohort clock study. And as you can see on the left, on this heat map, tiredness was present in 98% of those in the clinic, headaches and dizziness and lightheaded in over 70% as well, and shortness of breath coming up very high as well, and the numbers being far lower in the clock study, which is self-reported symptoms. And you can see that the clinic patients, 91% of them met the research definition of post-COVID condition versus 25.6% of the clock patients. And in terms of the quality of life, where the brighter pink shows more problems, you can see that in the post-COVID service patients compared to the clock, they were more severely affected in terms of mobility, activities of daily living, I think pain or discomfort, and looking after themselves and feeling worried or sad. So these patients attending the clinic have more symptoms and are more severely affected by their symptoms. The most common symptoms are fatigue, muscle and joint pain, headaches, insomnia, brain fog, etc. In a meta-analysis of controlled and uncontrolled studies, Beinoun et al. Identified that the pooled risk difference for post-COVID cases were higher for cognitive difficulties, headache, loss of smell, sore throat, and sore eyes. The range of presentations in terms of phenotype that we're seeing in clinic are all that we've mentioned already, including the group that are very much like ME/CFS, the young ones who get post-exertional malaise, the group who have a functional neurological presentation, gastrointestinal disorders, and we have a few patients that are tube-fed, dysfunctional breathing, chronic pain, autonomic dysfunction, rashes, and some do desaturate on the sit-to-stand test. The comorbidities are seen such as other medical conditions, low mood and anxiety, and neurodivergence. Common functional difficulties that are seen affecting young people are their symptoms are worse after exertion, even showering or activities of daily living, and especially sport and exercise, such as walking the stairs. Their school attendance can be affected, getting to sleep and getting up can be affected, concentrating and keeping up with schoolwork, and then social activities such as going out with friends and doing hobbies and interests can all be affected, unfortunately. And understanding an illness that you can't see is difficult, and it's difficult for patients who don't necessarily look ill when they do manage to get to school, but then their friends and teachers aren't seeing them when they're actually completely unable to function at home. So it's important to listen to and believe the patient and keep an open mind. It's important to do a thorough biopsychosocial history, looking at biological factors, psychological effects and factors, and social effects and factors to do with the illness and the symptoms, and including family history. We find creating a formulation which includes predisposing, precipitating, and perpetuating factors, both biological, psychological, and social, is helpful, and the families seem to appreciate that way of thinking about it as well. We investigate and treat individual symptoms as they evolve, and focus on improving function and lessening the impact. We monitor progress with the patient, noting what is helpful and what's less helpful, and acknowledge and explore the challenges. Where it is possible to join the body and mind, that's important, and important to keep up to date, because there aren't that many medical treatments currently that we can use, and hopefully they'll be coming. In terms of etiology, we'll be hearing about all of this in the conference. There are a plethora of possible explanations of the etiology, and we're waiting to find out more. And in terms of children and young people, also to consider the preceding factors, whether there's an element of link with allergy, neurodivergence, and whether anxiety is playing a part due to the illness or underlying as well. There is not much evidence on the etiology. It's been noted that most children have normal coagulation profiles, but the severe subgroup have significantly a higher probability of mild abnormal D-dimers compared with those who recover completely. And so this does raise the question of the possibility of chronic endothelial inflammation playing a role. In terms of where does post-COVID syndrome fit in with other illnesses such as ME/CFS and other post-viral syndromes, it's important to also consider this in the whole, in the round. We know functional symptoms are common in adolescence, and pre-pandemic norms do show that fatigue and pain are common in adolescents. The pandemic has been very difficult and worrying for young people, and we're still only just starting to see the effects of the lockdown and the pandemic itself. Post-COVID syndrome in some cases overlaps a lot with ME/CFS, but it has its own particular symptoms in other cases, such as the respiratory symptoms and the rashes and COVID toes, etc. And so I think it would be a mistake to merge it too much with other syndromes. Our service is a pan-London collaboration, a tertiary service where patients are referred from school, GP, paediatricians via a paediatrician in order to be assessed before they come to us, because at the beginning of the pandemic we didn't know whether they would be affected like adults with secondary organ damage, etc. But thankfully that has appeared to be extremely, extremely low. They then, after referral, come to a virtual multidisciplinary team meeting where the patient is discussed with the referrer, with a host of specialists such as paediatricians, adolescent paediatrician, psychiatrists, rheumatologists, respiratory paediatricians, psychologists, psychotherapists, physiotherapists, occupational therapists, and infectious diseases specialist. And between us, we discuss the case and give advice, and then we take some of those patients into our face-to-face clinics where they're more severe. The two clinical hubs accept patients after that multidisciplinary meeting to a face-to-face assessment, which is an interdisciplinary assessment comprising of a medical component, psychological and rehabilitation, i.e. physio or OT, all together doing the assessment. And then bespoke follow-up, which is usually up to about 6 sessions of a mixture of physiotherapy, occupational therapy, and psychological and medical. And then we continue to do 6 months medical reviews, and we monitor our outcomes with modified ISRIC outcome measures. So far, we have been referred 403 patients, of which we have seen 213 in the clinics, which is 60% of those discussed, and the other 40% have gone back to the referrer for localised care. What we have noted is that from an ethnic perspective, 50% are from any white background, and we're not seeing as much ethnicity as we should be. And our average age of patients is 14. This slide shows the index of multiple deprivation, and with the lowest number being more deprived, and the mean for the London area is 3, but the mean for our patients is 6. And so we're seeing a less deprived group of patients than is representative of the area. And we know that COVID has affected all groups, and if anything, this is unrepresentative, and hence we do need to be looking to find harder to find young people more persuasively. 74% of patients had a previous medical diagnosis of those referred, 42% asthma, 17% neurodiversity or neurodevelopmental issues, which was higher than what is normally quoted as the norm of up to about 10%. And it's not really clear why that is, and more work needs to go into this. And 22% had a prior mental health diagnosis, which is pretty much in line with normal rates. The mean number of symptoms in our service was 7, and the symptoms that we saw were fatigue, headache, anxiety, mood changes, brain fog, dizziness in reducing order of frequency. Symptoms, according to severity, the more number of symptoms people had, the more severe an impact. And this also correlated with what the symptoms were. So brain fog, difficulty concentrating, and memory loss were more linked in with the more severe group. In terms of key principles of care, care should be locally led where possible, family-based, and a holistic assessment should be undertaken to exclude alternative diagnoses, secondary organ pathology and comorbidities, and then medical and multidisciplinary management for any medication needed and rehabilitation. In terms of assessment, baseline blood tests and then additional investigations as required, including, for example, brain MRI or echocardiogram or 24-hour tape. And the bedside assessment should include a heart rate and blood pressure monitoring, a 1-minute sit-to-stand test checking for desaturation, and it's important to do a nathaline test where required, as we've been finding more and more autonomic dysfunction in this group. Any medical conditions such as migraine are treated at clinic, and the other medications are there to provide symptomatic relief and treat any necessary medical conditions. So we use a lot of melatonin and amitriptyline for sleep and pain, migraine treatments, antihistamines, anecdotally been useful, and gastrointestinal medications. And autonomic management, as I've said, is becoming more and more important. And the non-pharmacological treatments such as fluid, salts, pressure stockings, and then we're using more and more of the medical treatment such as ivabradine, midodrine, beta blockers in conjunction with specialist advice from cardiology, and we are referring on where needed. We're awaiting results from the adult treatments research projects, and in the meantime there is very limited evidence of what we can use in children and young people. There is quite a lot of experimental and off-license treatment being used in children and young people in the private sector, such as low-dose naltrexone, coenzyme Q10, anticoagulation, hyperbaric oxygen, NADH, and we have started to do a systematic review on some of these to make sure that we're able to treat where we can. In terms of rehabilitation, the Yoga COVID Recovery website has some excellent resources that we co-created, and so patients are supported in terms of managing their daily activities, eating well, sleeping well, returning to education, managing emotions and feelings. And we've also contributed, along with Long COVID Kids, to the rehabilitation and self-management of COVID for adolescents, the WHO leaflet, which is really excellent, very user-friendly. Long COVID Kids charity has some great resources, as you can see here, especially the new education, the Long COVID Kids toolkit, and that's just an example of one of the videos. In terms of our outcomes, at initial assessment in orange, you can see that most patients were not managing to attend school. And at 6-month follow-up, we've managed to improve school attendance in 59% and those attending full-time increased from 9 to 39%, and those who are not at school at all reduced from 20 to just 6%. Functional impairment at presentation, 6 and 12 months. The blue is no impairment, orange mild, moderate is in grey, and severe is in yellow. And initially, you can see that a lot of patients have mild impairment, and at 6 months, about 30% now have no impairment, and an improvement in those who were moderately or severely affected. You can see that between 6 and 12 months, there wasn't a massive difference, and so that's something we're going to be looking at more, so that the initial improvement seems to happen in the first 6 months. Our wellness scores have also improved from 32 out of 100 at baseline to 63 at 6 months follow-up. And we're doing some pieces of research connecting breath and mind into dysfunctional breathing, full body MRIs, and characterising our cohort and outcomes, and looking more into the UK deprivation and ethnicity comparisons. So in summary, long COVID or post-COVID syndrome can cause a wide range of persistent and distressing symptoms for some young people, and has a significant impact on their function and quality of life. The etiology is not well understood, and specific treatments are still lacking for children and young people. Providing good quality MDT assessment and medications, rehabilitation, and support for young people and families is crucial. The time course of long COVID and proportion of patients who will recover or have long-term symptoms is not well known. And more research is desperately needed, and this does need to be funded. I'd like to thank the Pan London Post-COVID Service for all of their support, and I'd like to share some useful links and resources as well. I'm more than happy to answer any questions. Thank you very much for your attention.
Thank you. Thank you, Terry. I'm assuming Terry's on Zoom now with us.
Yeah.
Oh, wonderful. Hi, thank you for that terrific presentation. So we're going to have a slightly shortened on time for questions just because we're fairly behind on time. Maybe I'll start. Really excellent presentation. I wonder if you could speak to whether there's been research on congenitally exposed infants, and related to that, sort of the life course, if you have more information on sort of whether it's different across the different ages of the pediatric populations that you've seen, and particularly the symptoms that you described were very much similar to the ones that we've seen in adults and we've been hearing about in these conversations. And I'm curious if you're measuring other factors within these children, they're not popping up, or if there's specific things that you're seeing in children that are not seen in adults.
Thank you very much. I'm really sorry that I can't be with you all. I've actually got COVID, annoyingly, but it's really nice to, thank you for inviting me, and nice to see you all online, and I've been following with great interest such a fantastic conference. In terms of your questions, there are a few in there. The first one about congenital transmission, I'm afraid I can't answer that with enough knowledge. In terms of the pictures we're seeing very similar to adults. As I said, we're not seeing the secondary end organ damage, or we're not seeing evidence of that yet, which was reassuring at the beginning. We were worried we'd see the same kind of things as in the adults in terms of myocarditis, etc. We haven't been seeing that, so that's reassuring. And in terms of the phenotypes, we probably have maybe a slightly wider variety of phenotypes, as I showed on my slide. So have some functional neurological disorder patients, got some NG tube fed young people with gastro symptoms, but we're seeing very similar picture as the adults. And although we're not seeing some of the same end organ damage, we're not seeing many clots, for example, at all. They are very, very much affected.
and that's very severely affected some of these patients. And we're particularly worried about the severe group that don't appear to be making much progress. And we're happy that over 50% of our patients are making good progress, but there's still this 40% which is a bit stuck, similar to the adults. And then I think just the fact that they live within a family and they may have family who are affected as well can make the situation more complicated and more difficult for the young people and the family. I hope that answers your question.
Yeah, absolutely. That's great. Thank you. Okay, so I think we're going to continue and move forward with our next speaker. We're moving on now to the two abstracts. So our first speaker that's with us is listed here. Dr. Izquierdo Pujol from Spain, who will be speaking on PBMC immunophenotyping, plasma inflammatory profile, and antibody levels of children with long COVID. Welcome.
Yeah, okay, sir. Thank you first to the organizers for choosing my abstract to do another presentation. Well, I'm Joan Izquierdo Pujol. I'm a PhD student at Irsicacha AIDS Research Institute in Barcelona. And today I'll be presenting PBMC immunophenotyping, plasma inflammatory profile, and antibody levels in children with long COVID. So as you may know, we had more than 650 million COVID-19 cases worldwide, and there is an estimated number of 65 million people to suffer from long COVID. And we have listened a lot of talks about long COVID in adult population, but now I will try to answer what about long COVID in the pediatric population, right? So just to be specific, there are a lot of hypotheses behind the pathophysiology of long COVID, but today I will be focusing on the immune regulation hypothesis, as my group is now working on in this area. So our main hypothesis is that children and adolescents with long COVID have an immune dysregulation even after the acute infection is resolved, and we have three different objectives. The first one is to evaluate different PBMCs levels of children and adolescents with and without long COVID through spectral cytometry. Then to evaluate the inflammatory profile of children and adolescents with and without long COVID. And last, to evaluate the humoral response of these children and adolescents. To do that, we have the PediaCovid cohort at Hospital Germans Trias i Pujol in Barcelona. In the PediaCovid cohort, we have first the long COVID cohort with an N of 108 children, less than 18 years old. They have a SARS-CoV-2 infection diagnosed, either for antigen or PCR test, and they had at least 12 weeks of persistent symptoms, as the World Health Organization states for the definition of long COVID. Then we have a control cohort. The N is 23. In this case, we have divided the cohort in two groups. The first group, they got a SARS-CoV-2 infection, also diagnosed with antigen test or PCR test, but they were recovered, so they did not have any persistent symptoms after the acute infection, and the sample time point is 12 weeks from the acute infection to match with the long COVID cohort. And then we have another group where that they did not have any SARS-CoV-2 infection. So moreover, in the long COVID cohort, the median age was 13.8 years old, and 60% were female. There were no significant differences in both female sex and age between the long COVID cohort and the control cohort. Then the ones that they got symptoms had a median of 6 symptoms during acute infection, because the vast majority of the long COVID cohort was asymptomatic. Then the sample time point had a median of 20 weeks from the acute infection, and they had a median of 10 symptoms associated with long COVID. The symptoms with more prevalence were fatigue, neurocognitive neurodisorders, brain fog, headache, muscular weakness, dyspnea, myalgia, orthostatic hypotension, and insomnia. But we also had some cardiovascular symptoms as tachycardia, or gastrointestinal symptoms as diarrhea and epigastric pains, but they were less prevalent than the other ones. Moreover, the long COVID pediatric unit at the hospital, they did the PET-QL, that is a test that assesses for the quality of life of children and adolescents, and they saw that 37.5% of the children had their quality of life affected by this condition. Moreover, 45.8% were unable to attend school for full time, and more than 70% were unable to engage extracurricular activities, showing that long COVID is really affecting day-to-day life of children and adolescents that are diagnosed with this condition, and remarking the importance of studying this condition also in the pediatric population. So for the first objective, the characterization of PBMCs, we have preliminary results from the first 23 of the long COVID cohort and the first 19 of the control cohort. So we had PBMCs, and through a spectral cytometry with a 37-color panel, we were able to identify 53 different cell populations through manual gating. Of those 53 cell populations, 6 were significantly different between the long COVID cohort and the control cohort, where 3 were increased in long COVID, being double positive T cells, and 2 different subsets of memory B cells producing IgA, the CD21 negative and CD27 negative, and CD21 positive, CD27 negative. And then 3 were decreased in children with long COVID, being CD4 Temra cells and intermediate and classical monocytes. For the humoral response, we have data from the full cohort here, and we check in plasma through ELISA for anti-S2, anti-RBD, and anti-nuclear protein antibodies, both IgG and IgA levels. For the IgG, what we saw is that children and adolescents with long COVID had significantly lower levels of RBD, IgG, and we did not saw that in anti-S2 nor in anti-nuclear protein. So it was very specific of RBD. And then for IgA, we saw the same trend, where children and adolescents with long COVID had lower levels of anti-RBD IgA, and we did not saw that in S2. And in nuclear protein, as you can see, we only had 1 responder in the long COVID cohort and 0 responder in the control cohort. For the inflammatory profile in plasma, that it was the third objective, we also have data from all the cohort, and we check in plasma for 42 different inflammatory markers through Luminex and ELISA. Of those 42 inflammatory markers, we saw that 4 were significantly different between the long COVID cohort and the control cohort. 3 were increased in the long COVID cohort, being eotaxin, interleukin-15, and PDGF-AB. And 1 was decreased, that is, it was RANTES, or CCL5. So a little bit of conclusion and outlook about all the data that I shared now. For the PBMC immunophenotyping, we saw different immune cell populations that were dysregulated in children with long COVID. However, these results are from the first 23 of the long COVID cohort and the first 19 controls, so they are very preliminary, and now we are analyzing all the data from the cohort, and we are expecting the results in order to confirm if the preliminary results stay or not. Then for the humoral response, we saw that children and adolescents with long COVID had lower anti-RBD levels in both IgG and IgA compartment, and it was very specific of RBD. We did not saw that in S2. There was a paper in July that they saw that adults within the first 10 days of the infection with lower anti-RBD IgG levels were more prevalent to have past or long COVID. So maybe this is happening in children, but they are not able to recover those levels. Then for the plasma inflammatory profile, eotaxin is increased in our cohort, and it also have been shown to be increased in adults with long COVID, having brain fog as a symptom. And brain fog in our cohort was one of the most prevalent symptoms that we have. So the results in adults are pretty similar with what we got. Then the increased PDGF-AB. Increased PDGF-AB is known to be increasing conditions that they have vascular damage associated. So maybe the increased levels of this cytokine, it's showing us that children and adolescents might have vascular damage. We did not assess that yet, but maybe in the future we will look into it and just corroborate what we got. And finally, interleukin-15 and RANTES are not described in long COVID, but just you to know, interleukin-15 is involved in the maintenance of cytotoxic cells. So the increased level of this cytokine is showing us that the body wants the cytotoxic cells to be maintained. And then RANTES CCL5 is important in T-cell chemotaxin, so maybe the decreased levels of RANTES together with increased level of interleukin-15 is saying that maybe there is some antigen or viral persistence in the body, but as RANTES is decreased, maybe the T-cells are not going to the site of the viral persistence. This is an hypothesis. And well, I would like to thank all the people that is involved in this project. Sara Moron Lopez, that is my mentor and the principal investigator in this project. Also Marta Massanella, that she developed the 37-color panel that we are using in spectral cytometry. The pediatric unit at Hospital Germain Trias i Pujol, that they are with the children trying to solve, and There are problems through rehabilitation, the cytometry core facility at IGTP, where we ran the spectral cytometry samples, and for sure the most important ones, the participant and the families, that without them it would not have been possible, and our funding sources. And thank you.
Do we have any questions for our speaker?
Hello, thank you. Very interesting findings, especially the low RBD antibody levels that appear quite distinct. So do you think, and it's intriguing that you do not see that for other antibodies, do you think it could still reflect a lower antiviral response overall? And if so, do you have signs of viral persistence? For instance, in the panel of markers that you followed, did you look at interferon? What about interferons?
Yeah, thank you. Yeah, it was quite surprising for us to see it was only against RBD. We did not check for, well, we have the data for interference, but they did not got any significant difference. And what was the second thing that you said? Sorry,
viral persistence.
Yeah, we want to check viral persistence through digital PCR. We will do it next year, and let's see if we can find something. But we think that it's more of the, there are two B-cell clones that are dominant for the response against RBD. So we hypothesize that maybe in these children, those clones are not working correctly, and that's why we have lower levels of anti-RBD. But also it's an hypothesis that we have to check in order to see what's happening there.
I might just ask one more question myself. Thank you for that excellent talk. Some really rich data that you have available. And I'm wondering, I know you showed that there was some differences among the children who had brain fog. I'm wondering for your analysis that it combines everyone, if you've thought about maybe looking at some tails of the distributions to see if they're different, because if we think that perhaps that group is heterogeneous in some ways, that it looks like you're looking at an overall shift in the distribution, but if you might, rather than rule out those that don't have that, maybe look at some of the tails of the distribution, if you've thought of that.
No, we are currently, these are all, with the cytokines also, are preliminary results. We are just trying to analyze per symptomatology. But as I said, for example, for iotaxin, our core was very enriched with brain fog. So we were not able to see if the ones that, when we ran the statistical test without the brain fog, there were no differences.
Great, well, let's thank our speaker again.
Thank you.
Okay, our final speaker of this session is Chiara Di Gravio from the United Kingdom, and Chiara will be speaking about the relationship between self-reported persistent symptoms post-COVID and employment among adults in England. Thank you and welcome.
All right, can you hear it? Yes. Thank you for organizing this. Given there's a really high chance I might run out of time, I put the acknowledgement first. And so I just want to acknowledge the funding and the people that make this possible. This whole work is actually part of a dissertation done by Xuan Hu. She could not be here, so I'm just presenting on her behalf. But a little bit of background. I mean, we heard about this for the past 24 hours. We heard about having about 10% of people that report persistent symptoms have been classified as long COVID worldwide. We've been talking about risk factors of long COVID, things like female, BMI, having comorbidities. We also find that having a lower household income and a higher deprivation index is related to long COVID. Well, I think what we didn't really talk about is the effect of long COVID. And so we see that in many countries, there is a reduced workforce participation following the pandemic, and it's still not clear how much of this is actually due to COVID. So what we want to do here is to looking at the relationship between long COVID and employment in two different ways, which are both important if we want to go on with like new policies or targeted intervention. So the first of our aim is to see whether employment is an actual risk factor for long COVID or not. And so it's a certain group of people are more at risk of getting long COVID depending on their job. The second thing we want to look at is, well, now that you have long COVID, will that impact your future employment? And so you can think of that impact your future employment, most likely will it impact all your future life. To answer both aims, we did use data from the REACT study. You heard about that yesterday, but it's pretty much was launched in England in 2020 to track the prevalence of SARS-CoV-2. It's made up of two main studies, REACT-1, that looks at the prevalence of SARS-CoV-2, and REACT-2, that track the prevalence of antibodies. The study ran from April 2020, and some of it is still running. And so part of the people that we have in REACT-1 and 2 have been followed up in the REACT-LC or REACT Long COVID studies. And we are now assessing the impacts of infection on health and well-being. There's quite a lot going on because there's quite a really big cohort that we have. But to answer our aim one, and so to determine whether the type and nature of employment are risk factor of long COVID, we used a subset of REACT 1 and 2. So we had about 275,000 participants for which we had information on employment. To answer aim 2, and so to determine whether long COVID has an impact on employment, we used data from REACT-LC. And so we use data here, we have like about 107,000 people that were within REACT-LC. So they're also a subset of the data that we use for aim 1, for which, again, we have information on symptoms and employment. Two things to notice is that for aim 1, data goes from 2021 to 2022, while for aim 2, that's subsequent data after collection in REACT 1 and 2. All the analyses are logistic regression model adjusted for known variables, so adjusted for known risk factors, things like COVID variant, COVID vaccination, whether or not you have previous comorbidities. And I'm just going to show you here odds ratios and confidence intervals, and then you'll just go through the results that we have. Starting from the first questions, I told you to answer the first question, we used data on about 275,000 people. I just thought it would be interesting to see what the main characteristics were. And so the majority were women, white, without previous comorbidities. And our outcome was long COVID, which we define as whether or not you report symptoms for longer than 12 weeks. And there's about 15% of people reported long COVID. We have 3 different exposures. So the nature of employment, which is like whether you work full-time, part-time, you're self-employed or not working. The type of employment, I've listed them all there. And employment rights, and here we may just, do you get sick pay if you're off work? Or the last one that's really interesting is that, well, if you are off work for 2 weeks, does that impact your finances? And this is all self-reported measure. And so those are the main results and the few things I want to highlight. The first one is the healthcare worker that's at the end of the forest plot, and we find that healthcare workers had a 47% higher odds of developing long COVID after adjusting for all known factors. Also, people who work in logistics and security had higher odds of long COVID. Those are police officers, firefighters, delivery drivers, people who work in public transportation. We also found that nature of employment and whether you have access to sick pay was not associated with odds of long COVID, and that people who reported serious financial impact of time off work had a 29% higher odds of developing long COVID. So in the interest of time, I'm just going to move into the second of our analysis that looks at how long COVID impacted employment. And this is a subset of the population that we've seen before. And so even here, then we have the majority female, white, and without previous comorbidities. The outcome here is a yes or no question, a yes or no variable. And so participants were asked whether they had to reduce their work hours due to their health. And health, we mean both mental and physical health. And about 8% of them say, yes, we had to. We had a bit more information on persistent symptoms, and so we could actually define long COVID slightly different, and that's the exposure for this analysis. And so we define a variable of like 4 different levels. So there's people who have either no symptoms at all or symptoms up to 4 weeks, between 4 and 11 weeks. And then the last 2 are what is called long COVID. So 12 weeks or more of symptoms, but we add information that allow us to divide this into 2 groups. And so those are people who resolve long COVID, and so the symptoms lasted long, but now they're over. And then people who still have symptoms at time of the study. And again, this is some of the main results. People with ongoing long COVID were 4 times more likely to reduce their work hours compared to those who recover within 4 weeks. We did find a dose-response relationship because it's not on the slides, but people who resolve long COVID, so they had symptoms but they don't have it anymore, they were actually 2 times more likely to reduce their work hours. Both part-time and self-employed workers were more likely to reduce their work hours compared to people working full-time. And I think for self-employed workers, it was like 3 times more likely. And I think you can see from the plot there that individual in any public-facing roles, so whether that's healthcare workers or like police officer, they were more likely to reduce their work hours compared to people in non-public facing roles, with people who had the opportunity to actually work from home. And so just what they will learn from this, well, healthcare workers and people who feared loss of income from time off work were more likely to develop long COVID. Participants with long COVID and those working part-time and self-employed were more likely to reduce their hours of work. I think what this finding demonstrates is that COVID impacted work in different ways. And depending on what is your employment, that impacts your risk of COVID. And so when we think about long-term support, when we think about intervention, when we think about policy, we need to think about which sectors have been disproportionately impacted. And this ends my talk. If you have any questions, I'm happy to take them.
Do we have questions from the audience?
The most people that has been long COVID is the professional, sanitary professional. But the ills isn't recognized. And it's a problem for the personal health continuing to work exactly at the first. And it's a problem because any Any person neither recognizes the long COVID. You only can say the symptoms. I am tachycardia, I am neurological symptoms, but neither said what do you have.
So the way we define long COVID, we did ask symptoms, and we did ask, like, when did you start your symptoms? I think we also, it's not in here, but we did also ask, how do you think you have long COVID first, and then did your doctor actually diagnose you with long COVID? And we did find that there's differences in between, yes, I think I have long COVID, but my doctor doesn't think that.
I might follow up with that question. I think you were talking at the end about policy and the need for policy, and perhaps what somebody's alluding to is the importance of defining long COVID in order to shape that policy. Maybe you could speak to that.
Yes, that's a really hard question. I think I don't have the background to be able to say, like, oh, that's how you should define long COVID. I think that's this kind of meetings that's helpful, and patients, that really helps. What I think, though, it's that once you have a definition of it, you really need to pay attention on the fact that there are some groups that have been disproportionately affected by long COVID compared to others. And so, like, policies on intervention that work for some group might not work for others, but, like, the definition is out of my ability to actually come up with one.
Great. Thank you so much. Excellent talk. So that concludes this session, and now we'll move to a coffee break and return at 4:15. So thank you.
Okay, so we start again. So, we are very glad to welcome you both in person and virtually for this second part of the clinical management. And I would like to welcome Dr. Neme, Messam Neme, from Switzerland, from Geneva. Dr. Neme is an internal medicine doctor. She works as the head of the epidemiology unit and coordinator of the post-COVID consultation. And she's going to share with us a presentation on neurocognitive and neurological symptoms. Thank you.
Thank you very much. Thank you also, Professor Salmon, for the invitation. Dear colleagues, so I'll be talking about neurocognitive and neurological symptoms in post-COVID, and about one of the randomized clinical trials that we're doing in Geneva, Switzerland. So you've heard about this a lot in the past few days. It is important, however, to say that post-COVID is still something that patients who suffer from it are still suffering 3 years on, with a gradient of fatigue, which could be reported fatigue, but also could be post-exertional malaise or criteria for chronic fatigue syndrome. And so it is very important to keep talking about post-COVID and to try to find solutions and even to try to understand what are the underlying mechanisms. And so fatigue for us is a neurocognitive symptom. It is a neurological symptom. Fatigue is very vague. It can be neurologic. It can be due to other causes as well. But post-COVID fatigue is most likely due to neurological symptoms. And why is this important? Again, because there is, as some of my colleagues mentioned it in previous lectures, there is a real impact on functional capacity. And so in this study that we had conducted in Geneva, we had shown that patients who had what we call the chronification of symptoms, so patients who had long COVID, but that lasted at least 15 months, had really significant functional impairment and more visits to the primary care doctor, more utilization of healthcare, more visits to also specialists in the emergency room. So what this means is that there's a cost to the individual, to their health, to their functional capacity, but also a cost to the society as a whole. So it's not only a person's problem or disease, it's also a public health issue that needs to be explored further. And so, as you know, and as has been discussed, the symptoms can range widely from fatigue, headache, difficulty concentrating, sleep disorders, dyspnea, cough, dizziness, tinnitus, and pain. So a lot of these symptoms are actually neurological symptoms or neurocognitive symptoms. Fatigue, as we mentioned, headache, difficulty concentrating. Sleep is also related to neurological symptoms. Pain is mostly neuropathic pain that we see, we have a study going on at the Geneva University Hospital, also biopsying areas where there is this neuropathic pain, and we are finding that there is some small fiber pathology. So there could be some underlying mechanisms for these neuropathic pains. And so what we know today, we have tried to disseminate or to diffuse to the general population. So in Geneva, Switzerland, where I work currently at the Geneva University Hospital, with 17 different partners all over Europe, but also in Canada and mostly in the Francophone world, we tried to put a system or a platform online for bidirectional exchange. It started early on, and it's called Raphael. It's a platform where we have information on post-COVID management, social impact. And we also did this platform for adults and for children, adolescents, and because it was important for us to see what were the questions or what were the things that were preoccupying patients, their parents, their families, but also healthcare professionals. So Raphael started as this platform for bidirectional exchange. There's also a chatbot where people can ask questions and get answers, and also a community moderator if the chatbot doesn't know how to answer. And we hope that Raphael, we initially started doing literature review where we would put all the ongoing clinical trials on there, and we would hope with coordination and collaboration with other sites, partners, and also other investigators to actually transform it even into a platform where we can announce what are the ongoing clinical trials and have patients participate if they fill the profile, if they live close by, or if they have the inclusion criteria. It's important to have such platforms. There's Après J20 also in France. There are other platforms because it's important for patients to communicate together with healthcare professionals, and also because we are still learning about this disease. The idea was also that maybe some part of post-COVID or symptoms can be handled with self-management options on the long run. Not all of them, but some of them, including pacing, other resources that we've put online on the platform, like breathing exercises, hypnosis, meditation, and Tai Chi. All these resources help with whether vagal nerve stimulation, but also neurocognitive symptoms in general. And so the idea was really to give the opportunity for patients and for healthcare professionals to have this information online and to manage their symptoms at home if possible. And so I do invite you to look at these resources. They're in French, but they are quite helpful because they really look at symptoms in a broad sense. And these exercises or therapies can help not only long COVID patients, but also the general state of health. And so my main talk will be about this RCT that we're doing in Geneva. It's not only in Geneva, it's a multi-site, it's probably one of the first European multi-site studies that is still ongoing with sites in Spain, Italy, and in Switzerland. So in Switzerland, we have the 5 sites, Geneva being the primary investigator site, but also Bern, Basel, Sion, and Chur. This RCT is for patients who have fatigue or neurocognitive symptoms, and I'll be talking about the hypothesis behind it and what kind of treatment we are trying to study or evaluate, completing also what Professor Salmon had said earlier about the study. So why this study and what is the hypothesis behind it? Maybe some of you know, we do have retroviruses in our DNA. About 8% of our DNA is actually composed of retroviruses. Retroviruses are usually, so they're endogenous, and usually they're not activated. And sometimes there's a virus that can come, and that could be COVID, SARS-CoV-2, it can be EBV, CMV, or other viruses, or some kind of pathogen, actually, that may activate these retroviruses. And so knowing that these retroviruses should not be activated, once they're activated, this becomes pathologic. And so the idea is to try to stop this activation loop. So like I said, when you have any virus, it can activate in certain individuals, not all of them, this activation loop. And the idea would be to actually try to stop this activation loop. And so this is the hypothesis behind the randomized control trial that we're conducting in Geneva and in other sites in Europe as well. So SARS-CoV-2 has been shown actually to be associated with an increased expression of WONV or HERV protein. This HERV protein or WONV is actually expressed by retroviruses. So again, retroviruses should not be activated. If they are activated, they are pathologic and they can produce products or molecules. And one of these molecules is WONV or HERV. It's from the HERV family. And so we now know that SARS-CoV-2 in some studies was associated with an increased expression of HERV or WONV. We also know that WONV or HERV is associated with, has some pro-inflammatory actually properties, and is associated with symptoms such as fatigue and neurocognitive symptoms. This was shown in other diseases as well, such as multiple sclerosis or amyotrophic lateral sclerosis. And so if we follow this chain, we have a virus that can activate a retrovirus that will express a WONV or pathologic protein, and this protein is associated with neurocognitive symptoms. And so the idea is to stop this WONV production or try to reduce it as much as possible. And this is where there is a monoclonal antibody that is in a phase 2 trial currently, which is Demystifying, and this monoclonal antibody has been studied in multiple sclerosis and in ALS. It has not been studied yet in post-COVID. This is what we're doing actually, and the idea is to target the WONV or the HERV protein to reduce its activity or even its existence, so that we have less, hopefully less, pro-inflammatory properties and less neurocognitive symptoms. So this is a traditional PICO that kind of describes our study. We have in the population, it's adults who are 18 years of age or more who have a SARS-CoV-2 infection. Unfortunately or fortunately, we have to have some kind of documentation of SARS-CoV-2 infection, meaning that an antigen test, antibodies, anti-N antibodies with a medical certificate saying that this patient has post-COVID symptoms are also accepted, and obviously the PCR tests as well. And so in accordance with the NICE criteria from the UK, one of the inclusion criteria is to have symptoms that have been ongoing for more than 12 weeks. And the symptoms that we're looking for are fatigue and neurocognitive symptoms. And so the intervention is to give Demystifying, and I'll show you how. And then the comparison is a placebo, double-blinded, obviously, over 24 weeks or 6 infusions. And the primary outcome is actually improvement in fatigue. And here, and this is the challenge, I think, in a lot of RCTs and a lot of studies that will be happening on post-COVID, is that how do you get hard outcomes, which what we call hard outcomes in science, is some kind of objective measure, which is still to be discovered or to be better defined in post-COVID. So here it's a decrease in fatigue. Fatigue is self-reported using the PROMIS 7A scale, but it is self-reported. So there could be also some variability depending on how the person feels that day, and or subjectively how the person would evaluate their fatigue. We do have several secondary endpoints, one of them being actually the reduction of WONV protein in the blood, but also the severity of symptoms, other symptoms, functional impairment, quality of life, and safety outcomes. So again, these are the inclusion criteria: adults with a history of SARS-CoV-2 infection, symptoms that are persisting for more than 12 weeks. We do a first screening visit where we have to identify WONV protein. So some of you might be wondering what is the prevalence of WONV protein in post-COVID in general, and what we find, and what we found from other cohorts, is that it's about 30% of post-COVID patients who might have the WONV protein, meaning that it's not the only explanation for post-COVID symptoms. It might be one of the explanations. The study still has to be analyzed and completed. But what's important is to continue doing these randomized controlled trials and these trials to try to get some kind of answer. But that being said, so the inclusion criteria is to have the WONV or HERV protein, and that's in 30% of patients who have post-COVID. Unfortunately, we can't include the other 70%, and other clinical trials have to be done and conducted to be able to find other potential mechanisms in this probably multifactorial disease. Fatigue with a score of more than 21 on the PROMIS scale is also important as an inclusion criteria. And then we had defined some secondary scales that look into quality of life, so the EuroQoL 5D5L, the PQD, which is the perceived questionnaire deficit, which has to be more than 27, and the token motor test, which is a neuropsychological test, actually, which has to be positive as well. And so this is what happens at the screening period. We have first the identification of the protein, and confirmation of all the inclusion criteria. We also do some blood tests to make sure that we don't have other diseases, just like in any other randomized control trial. It is important to make sure that we don't have immunosuppressed participants, for example, or any kind of disease where having a medication that has not yet been fully evaluated might put the participants at risk. And so this is part of the screening period that we do over the first 2 to 3 weeks. And then every 4 weeks, the participant will come to the clinical site, and they will receive either temelimab, or which is a monoclonal antibody, or a placebo. Once every 4 weeks for 6 months or 24 weeks. And so participants will receive a total of 6 infusions, and the objective was to recruit 200 participants, which has been possible thanks to all the sites actually that participated, and thanks to actually even funding from the Federal Office of Public Health for this study, which was also important. And right now what we're doing is trying to evaluate. So the study is still ongoing in the sense that we have recruited all patients, participants. The recruitment ended in the beginning of November, or November 7, actually. And so now, if the last participant was recruited on November 7, we have to count at least 6 months for them to finish their participation, and then we will have the results or the analysis. And so as fast as science and research is moving, or we would hope it moves, especially in long COVID, because again, there's the impact on the functional capacity on the individual and on public health in general, it might not be fast enough for patients who are suffering from long COVID, because if we look at the timeline, the symptoms might have started in March 2020. We started the RCT in August 2022. And then we won't have the results before August 2024. So that's 4 years of symptoms or long COVID, and knowing that it might not be the only solution and the only answer to post-COVID symptoms. And so one of the lessons that we've learned, and that we really encourage other researchers, but also stakeholders to do, is to contribute to research and to science. This is the only way where every year we can come back and have more information about this disease and how to help patients. We were discussing this with Professor Salmon just now, and I love your positive attitude, actually, which is great, because it's true that we started together back in 2020, and at a time when people were still probably suggesting, exercise-graded therapy or things that are contraindicated now. Since then, we've moved to make sure that patients are taken care of, and that we do pacing. And some molecules, like Professor Salmon was mentioning, like beta blockers, ivabradine, or antihistamines, were being given, but there was not enough evidence. And so now we have these randomized control trials that are looking into these molecules and these medications, and we have ongoing or new clinical trials like the temelimab one, and other clinical trials in the UK and everywhere in the world. I do invite you actually to look on the Raphael platform, because we have a document where we try to summarize all the ongoing clinical trials, where they're happening, and when we should expect results. And so hopefully that with time, we will continue having more and more results, and every year or every couple of months, we can come back with better answers. So this is it for me. Thank you very much. I'm happy to have you.
Thank you, Mesam, for your very nice talk. Do you have some question?
I have a few questions.
Okay.
Thank you. It's very interesting. So I have a few questions. The first one is, in which other pathology do you have a reactivation of F proteins?
Yeah.
And what were the results of telemedimab if it was prescribed in other contexts?
Yeah. So telemedimab is still a phase 2 trial, so it's not prescribed, but it is it was studied in other diseases, in multiple sclerosis and in amyotrophic lateral sclerosis, or ALS. The results were good. They were not great. So there was improvement of fatigue and neuropsychiatric symptoms in multiple sclerosis and in ALS, but in a subgroup analysis. But it wasn't so good that we put the medication on the market. So I think we still need further studies to make sure that it's the right molecule actually for these symptoms.
And the other question is that you have found ERF protein in 30% of your patients, but it is already a selected population.
Yes. Correct.
So maybe in the whole population of long COVID, it's lower?
It's lower, probably, yeah. So, I mean, we tried not to select in the sense that we didn't only take the participants that were in our clinic because we're a reference center and possibly that we have patients who have more severe symptoms. But we tried to really open up to the general population, knowing that they have long COVID symptoms. So yes, I think there is some kind of selection bias already, and the prevalence might be between 20 and 30% in the general population. And again, it doesn't explain everything because there is another 70% of patients who can be very disappointed actually after the screening visit because they're like, well, I have symptoms, and so they don't understand how they wouldn't have the protein. But this is also to say that it's not the only answer, and it's multifactorial.
Okay, thank you. But it is a real hope to see that clinical trial ongoing.
Yeah. Thank you.
There's some question. Yeah. Microphone is coming. Microphone is coming.
So it's quite interesting. Is the restimulation of the production of this protein associated to all your cohort or just a subgroup of long COVID patients?
It's only a subgroup, so the protein is only in 30% of patients. And when we find the protein, we go from the hypothesis that there was a re-stimulation, actually. That's how we find the protein. But it's only in a subgroup and not in all the participants, not in all the patients.
No, but maybe the question is this subgroup as specific clinical characteristics?
Oh, I see what you mean. Interestingly enough, I mean, but this still has to be studied and analyzed because it's part of the analysis. But I think, I mean, this is my subjective opinion from what we saw in the clinic and patients, they have more autonomic symptoms. It still has to be confirmed, but we did see, and this is also how we tried to guess, where can we have a high pretest probability, and patients who had a positive Shalong test or tachycardia or POTS actually seem to maybe have a higher prevalence, but it still has to be confirmed.
And do these people have coagulation problem?
Not on the lab results.
What does the treatment for the neurocognitive and neurological symptoms of long COVID actually?
Yeah, so neurologic and neurocognitive symptoms in long COVID are probably due to several factors, one of them being the dysregulation of the autonomic nervous system. And so the treatment goes back to pacing and to try to avoid as much as possible getting to the stage where people have this brain fog or have a crash. Because the crash, actually, so the neurocognitive and neurological symptoms are probably a manifestation of a crash. A person can have a crash with fatigue, they can have a crash with pain, they can have a crash with neurologic or neurocognitive symptoms. There are no medications. There's one study that that actually studied in Cell, which is a very good journal, that looked into SSRIs, which are antidepressants actually, but they have other properties as well, and showed that SSRIs actually can impact the autonomic nervous system and can decrease symptoms of post-COVID. This still has to be studied, and so today in the clinic, other than pacing and some trial of off-label medications, there is no other treatment of neurologic and neurocognitive symptoms. There was also, we tried in the beginning to say, oh, well, maybe neurorehabilitation would help. Not necessarily. So neurorehabilitation only in the sense that if we can give advice and some tips for patients, how to remember things, how to make sure that they have a good pacing schedule during their week, that could be helpful. But trying to force them to remember things or to jog their memory, that doesn't really work.
Thank you very much.
Thank you.
So we have now virtually Professor Nathalie Kubis. Professor Kubis is neurophysiologist at the University of Paris, and she has a long clinical experience with various situations of dysautonomia in other pathology, for example, Parkinson, diabetes, etc. And since about 2 years, she has her interest has moved also to long COVID. So thank you very much, Nathalie, to be here, and good presentation.
Long COVID patients present a wide range of several disabling symptoms that have been interpreted to be related to autonomic nervous system dysfunction, which I will call ANS for the rest of the talk. But these symptoms are non-specific, and ANS dysfunction is usually not tested in these patients. So to answer this question, we aimed to conduct with Professor Salmon in Otolde Hospital to investigate consecutive long COVID patients who presented severe and disabling symptoms, possibly related to ANS dysfunction, and that led to effort intolerance. And these patients were all referred to Lariboisière Hospital for ANS evaluation. So I would like to say a few words about what is ANS before we go on. So ANS consists of two different systems, which are called parasympathetic and sympathetic divisions of the ANS, and almost all organs are innervated by both systems, and these systems have opposite effects and are finely balanced. And as you may see on this slide, the anatomy is very different between the two systems, with the parasympathetic division in red and the sympathetic division in blue. And as you may see, the nuclei of the parasympathetic division are located in the brainstem and in the sacral spinal cord, whereas the nuclei of the sympathetic division are located in the thoracic lumbar spinal cord. And you can also pay attention to the origin of the vagus nerve, which is in the brainstem and located in the very lower part of the brainstem, which is called medulla oblongata. And this peripheral organization is under the control of the central nervous system, namely the limbic system, so that when you think there is a lesion or a dysfunction of ANS, it might be due to a peripheral lesion or dysfunction, or to a central lesion or dysfunction. So we classically oppose the sympathetic function to the parasympathetic function. And sympathetic function is called to be a fight or flight stress response, which means that it acts really quickly. It is also amplified, and it affects all organs at once. This is in opposition to the function of the parasympathetic system that functions at rest and for digestion, and which is said a peacemaker system, and whose aim is to restore energy. And it functions in response to sensory input to the central nervous system and is involved in complex reflex activities. I'll show you an example here, which is the baroreflex, which controls the regulation of the arterial pressure. You may see here that there are receptors in the aorta and carotid. And when you have an increase of arterial pressure, well, these receptors are stretched, and this induces an action potential, which is conveyed along afferent nerves up to the central nervous system, where it is integrated, modulated. And in this specific case, it will lead to activation of the parasympathetic vagus nerve to decrease arterial pressure, and it will inhibit the sympathetic nerves here in red, just to block the rise of the arterial pressure. So this is roughly what is shown here on the right side of the slide: stimulus, the receptors, information which is conducted through afferent nerves, modulated in the central nervous system, and the autonomic nervous response through the sympathetic and parasympathetic division. And just pay attention to the fact that the first synapse is mediated by acetylcholine and the last synapse by norepinephrine for the sympathetic division and acetylcholine for the parasympathetic division. When you suspect ANS dysfunction in a patient, you ask usually 9 questions. Do you have visual disturbances? And you will have to check for abnormalities of the pupillary motor function. Do you have dry mouth or eyes? Do you have sweating problems? Do you have vasomotor disorders such as warmth, redness, or coldness, pallor of the extremities? Do you feel dizziness at standing? And you will have to check for orthostatic hypotension. Do you have the sensation of bloated and full stomach? Do you have disorders of intestinal motility? Do you have urinary incontinence, retention? And do you have erectile dysfunction? The problem is that when you have asked this question, you don't know if there is a problem of the nerve or the organ. For instance, a Zika syndrome may be linked to the damage of the salivary glands, such as Sjogren's syndrome, for instance, or poor blinking habit, if you have dry eyes. Erectile dysfunction might be related to a vascular problem in diabetic patients. And above all, anxiety and medications might be responsible of a large part of the symptoms. So none of them is specific and needs to be evaluated. So this we finally included consecutive long COVID patients with persisting effort intolerance at the time of evaluation, which combined cardiological and neurological clinical expertise, and they all had ANS tested. We collected classical data. Just want to insist on the fact that we removed, whenever possible, all the drugs that could interfere with the ANS. And almost all patients had brain PET scan. I will comment later on. So this test investigated the parasympathetic system and the sympathetic system. So briefly, for the parasympathetic system, what we do is to see if there is a normal modification of heart rate in 3 conditions: on standing, to deep breathing, and during the Valsalva maneuver. I'll show you here how it looks like. So at the end of exhalation of air, the mouthpiece of the sphygmomanometer, you have an increase of the heart rate, which then decreases when the air is released. And this normal fluctuation might be completely abolished in case of ANS dysfunction, and you will obtain a flat curve. And this is the same for all the two other conditions. For the sympathetic system, we evaluated the pseudomotor evaluation with the sympathetic skin response, the electrochemical skin conductance with pseudoscan. We seeked for neurogenic hypotension up to 10 minutes after standing up, which is defined by a drop of systolic and diastolic blood pressure with no significant change in heart rate. And we also asked the patients for a 24-hour ambulatory blood pressure monitoring, seeking for reverse Doppler patients. That means that these patients have a higher SBP during night time than during daytime, and this may be a marker of ANS dysfunction. So usually, this is how we do routine examination. Dysautonomia requires at least 2 pathological tests in one domain or 1 pathological test in 2 domains, 2 different domains. And usually we have neurogenic hypotension. And this is really true for diabetic patients. And all these tests have been validated really in 2 main diseases, which are diabetes and neurodegenerative diseases. So we compared absolute values obtained at each test to the lab thresholds. And also we compared the mean global values we obtained in patients to the ones obtained in control subjects. So this population were young females and were evaluated more than 1 year after initial infection. Infection could be proven only in 9 patients because it was mostly at the first wave of the pandemic, and most of the tests were not available at that time. But we had other criteria such as anosmia, ageusia, ground glass opacities and chest CT scan. And the control subjects were age-matched healthy volunteers who all had presented SARS-CoV-2 infection more than 6 months before evaluation, and that was proven, and none had persistent symptoms after the acute infection. So we found that 5 patients had abnormal cardiovascular parasympathetic tests, and when looking at individual values, and at the Valsalva score, when we compare the mean values obtained in patients to the ones obtained in control patients, there was a significant difference. With the sympathetic system, 3 patients had abnormal pseudomotor response, but potentially due to the medications that we could not remove, but there was no other abnormalities. And interestingly, we found 1 POTS. I'll say a few words on the next slides on this syndrome. And we had isolated sinus tachycardia in 3 patients that were insufficient to retain the diagnosis of dysautonomia, but we usually do, however, in diabetic patients. So all patients had fluctuating symptoms, remissions and relapse, and 6 months after the evaluation of the ANS, 56% have improved, 31% were stable, and 12% displayed a worsening of their symptoms. So the first result is that cardiovagal function is more often impaired. So when we looked at another study that had exactly the same design than ours, they found almost the double of abnormal ANS tests than we found in our population, but their patients were seen much earlier, 4 months against 14 months for our population. What is more interesting is that we found similar proportion of parasympathetic and sympathetic cardiovascular function impairment in the 2 studies. And since we published this first report at the beginning of the year, we doubled our population, our 2 populations, and we found exactly the same proportion of impairment. How to explain this? Well, the first thing is that it's much easier to show parasympathetic impairment because tests that are available have a higher sensitivity and specificity, more than 80%, compared to what is used for the pseudomotor response, for example, 33 to 50. And also, we know that sensitivity varies according to the disease, and it's highly sensitive in diabetes. The second point is that there are two studies that aim to look specifically at the vagus nerves. The first one showed that there was decrease of the cross-sectional area of vagus nerves in long COVID patients. And another postmortem study showed that there was SARS-CoV-2 RNA in the vagus nerve and inflammation of the vagus nuclei in long COVID patients. But it's really difficult to correlate what they found with our study because all patients died, though they had not the same severity of the disease. And in this study, they did not look at the sympathetic nerves. So it might be that they could have found also inflammation of sympathetic nuclei. The second point is that we found POTS, which is defined by frequent symptoms that occur with standing, together, with lightheadedness, generalized weakness, blurred vision, together with an increase in heart rate more than 30 beats per minute when standing, and with the absence of orthostatic hypotension. So this syndrome has already been described in young females. The mechanisms are not clear. Autonomic denervation has been put forward, but we haven't much argument of this. What we know is that it is associated with fatigue, comorbid autoimmune disorders, and a higher prevalence of autoantibodies. We also describe in POTS patients some antibodies directed against one of the subunits of the acetylcholine receptor of the first unit, of the first synapse. But these antibodies may be found in control subjects, so we're not sure the specificity of these antibodies. The prevalence of POTS in non-COVID patients varies a lot, from 0 to 75. I have not many explanations for this discrepancy, but it might be that in that study by Blitzstein and Whitelaw, patients were specifically referred for that problem. So that might be a bias linked to the center. So we found that there is an underactivity of the parasympathetic system with decreased acetylcholine release, and this implies that there might be a relative increased norepinephrine release, and this might explain the sinus tachycardia we observed. We also observed postural tremor in some of the patients, but this remains speculative. But the limitations of our study are that there was an initial small number that we have doubled since, and we showed similar results. If we had performed this test earlier, maybe we could have increased sensitivity, but still all tested patients still reported severe symptoms at the time of evaluation. We cannot rule out the role of anxiety, and 6 patients out of the 16 had abnormal score at the HAD score indicating anxiety, but only half of them had abnormal ANS testing. We choose to use non-invasive and well-tolerated tools, and again, maybe sampling blood for orthostatic catecholamine determination have been more sensitive. Brain PET scan were performed in almost all patients, in 15 patients, and 12 of them displayed hypometabolism in the brainstem, but not in the medulla oblongata, where is located the nucleus of the vagus nerve. So it cannot be an explanation. But some of the regions that were considered to have hypometabolism are part of the limbic system. So the significance is still to discuss. And most of all, we could not control normalization of the abnormal tests in patients who recovered. In conclusion, to assess dysautonomia is not easy. New thresholds might be necessary for this population. Parasympathetic system is more often impaired than sympathetic system, given all the limitations I have described in the slide before. And also, we have to keep in mind that not all long COVID patients had dysautonomia, although they had these disabling persisting symptoms. So the causal relationship cannot be assessed. I thank you for your attention.
Yeah, thank you very much for this nice talk. I will have a question for you. Did you find some correlation between the clinical questionnaire you use with the 9 questions and the test you did to the patient? And do you think that this questionnaire could be used as a clinical tool for clinicians that have not cardiologists available nearby them? Thank you.
Not at all. So it's difficult to answer this question because, as you see, the series is quite small. We could not identify clear phenotypes and correlations between some of the tests and the symptoms that the patients referred.
Thank you. Are there some questions?
How do you think the test could be adapted to the population of long COVID? Do you aim to do that?
So when we doubled our population, what we observed is that all parasympathetic tests, well, all means were significantly different when compared to control patients. So maybe we could use an algorithm using, I don't know, ECG recording during, I don't know, 1 hour, and to see if there is a loss of heart rate variability. Well, this has been done actually by some of the some authors in long COVID patients. Mm-hmm. That might be the easiest way to show this parasympathetic dysfunction. But again, we were not able to demonstrate that there is a causal relationship between ANS dysfunction that exists and all the symptoms that were presented by the patients.
Maybe with more patients, it will be easier.
Maybe.
Thank you. Is there other questions? No. Yes. One question from Pauline Ostric from Association Après Givin. Pauline.
Bonjour Nathalie. Hello. I have a question about the test. I remember when we talked before, you said that these tests you're doing might not be the more appropriate for long COVID patients because they are less specific. But in your presentation, you showed that the parasympathetic tests were 80% specific. So that's my first question. Is this the same test that you were speaking about before at the health authorities when we were establishing the guidelines? That's my first question. And the second question is, some patients have diagnosis from dysautonomia with effort test when biking. And when you look at the results, they have dysautonomia when their blood pressure is flat while their heart rate is increasing. And this helped the physician saying, oh, you have dysautonomia because your blood pressure doesn't increase with your exercise. So I was thinking, my question was, what do you think about this test? And is this something you can rely to dysautonomia in your ideas? Thank you very much.
Okay, so thank you. So the tests we used were those we were talking about, but I don't remember if I said it, but all these tests were developed in very sensitive and patients, because diabetic patients have really quickly abnormalities of all these tests. And these normal values were determined by one or two teams 40 years ago, and only tested in diabetic patients and later on in neurodegenerative diseases. So again, I'm not sure to be able to answer to the first part of the question, because yes, these tests might not be sensitive enough, but there are other diseases when you have a sepsis in the intensive care unit, you may have dysautonomia, and intensivists know this very much. And they know that the absence of heart rate variability is of bad prognosis. So there are many conditions where you have ANS dysfunction, but it is never tested properly, again, because it's not the point. And to answer the second part of the question, maybe, although it's not specific, but this could be useful also to show ANS dysfunction.
Okay, thank you very much, Nathalie, for this discussion. Thank you for being with us.
So let's move on to the abstract session with Dr. Lindsay McAlpin, which is an assistant professor of neurology at Yale, and she's runs the NeuroCovid at Yale. So she's going to talk with us about vascular inflammation, neuropsychiatric PASC.
Great, thanks for having me. And I know it's been a long day, so thank you for staying. All right. So a little bit of background about our project. In acute COVID, like we've all talked about, platelet and endothelial dysfunction is elevated and actually predicts mortality in critically ill patients. Within 60 days after COVID, coagulopathy and endothelial dysfunction is still present and can correlate with the 6-minute walk test and function. There is evidence of microclotting, as we heard earlier, with unclear clinical implications at this point, and is unknown if vascular inflammation persists in individuals with neurologic PASC. So the most common symptoms that we see neurologically are cognitive impairment, mood changes, headache, and neuropathy, among others listed there. We investigated for vascular inflammation in individuals with neuropsychiatric PASC compared to individuals with post-COVID but no PASC. All right. So we recruited both from our NeuroCovid clinic and from the community, self-referrals. Again, our participants were COVID and PASC positive, and our controls were COVID positive and PASC negative. So here I'll be talking about the blood draw, and next talk I'll talk about the MRI. So we used a ELISA on plasma-based assays, and we tested 8 cardiovascular markers on the right. Our demographics, we had 2 very similar groups. We had 40 individuals with neuropsychiatric PASC. The age was similar to our controls, as well as gender, race, days since COVID illness, as well as numerous vascular risk factors that could also be affecting these markers. In terms of long COVID symptoms, as we know, each participant has numerous symptoms, and so these were the most prevalent. Fatigue, poor concentration, poor memory, difficulty with word finding, anxiety, depression, new or worsening was present in the majority of participants, as well as headaches and peripheral numbness, which a lot of the times, as we've talked about, may be related to small fiber neuropathy. But we included other individuals with other neurologic symptoms as well, including anosmia as well as dizziness. So the results, these are the 2 factors that were normal, that didn't show any significant difference between the 2 groups, platelet factor 4 and AGP. And then in terms of what we did find was that several markers, so 6 markers, were significantly different in the long COVID group compared to our controls. Alpha-2 macroglobulin, C-reactive protein, Phetuin A36, which the increased risk is a lower level, so that was in the appropriate direction. as well as haptoglobin, a systemic inflammatory marker, L-selectin, which I'll talk about, and serum amyloid protein. So to summarize, we demonstrated key differences in vascular inflammatory plasma biomarkers in individuals with neurologic PASC, including differences in plasma proteins that indicate ongoing systemic inflammation reflected by elevated CRP, haptoglobin, and SAP. Endothelial dysfunction is present with the presence of elevated alpha-2 macroglobulin. And then markers found to be present in atherosclerosis include L-selectin, fetuin E36, and SAP. So this was very interesting to us. And in terms of theory for long COVID, makes sense because the vessels are in every organ system in the body, and every organ system seems to be affected by long COVID. So we're very interested in this question of whether individuals with neurologic PASC may be at risk of persistent vascular inflammation, endothelial activation and inflammation and dysfunction, and or atherosclerosis. I think that would be, given the wide prevalence of the Omicron strain, important not only for individuals with long COVID, but also anyone who has had long or COVID period, if atherosclerosis is accelerated or worsened by COVID illness. So further studies that we'll be investigating will look at endothelial inflammation and atherosclerosis in individuals with neurologic PASC. So I'd like to acknowledge it takes a village. Serena Spudic, who's here, and my mentor, Shelley Farhadian, our wonderful funding support, and our great COVID Mind study team. Thank you.
Thank you for this interesting talk. I have a question. Did you see some difference in brain MRI between the two populations?
I'm sorry, say that again.
Did you see some differences in brain MRI?
Well, yeah, I'm about to talk about it.
Yeah.
Yeah, between the groups,
Yeah.
yes.
And did you use some functional or standard MRI?
Standard MRI. Functional B is on the docket.
Question here, please.
Hi, you mentioned that you want to look at endothelial dysfunction next. I was wondering, how do you plan on doing that? What's your method?
Right, so we are going to look at a number of different markers. So we're going to have a customized panel, I think of about 10 markers that we're going to look at to see if there's elevated endothelial factors and platelet activation. Stay tuned. We're hoping to publish in early 2024.
Those markers are elevated in atherosclerosis, yes? Mm-hmm. So do you know if statins are reversing something?
Oh, that's a great question. No, so we haven't looked at that yet, but that would be interesting, particularly in our follow-up. But we haven't used statins as an intervention in our clinic.
That's a question we ask themselves.
Yes. Yes.
Thank you. So do you want to continue for the second talk?
Sure.
So the second talk is also by Mrs. McAlpin, focal cerebral hypoperfusion in individuals with cognitive impairment after COVID-19.
All right. So a little bit of background. Anybody who has seen these patients in the clinic know that a routine clinical MRI has little value in diagnosing long COVID. Sometimes we find nonspecific findings like white matter lesions and large perivascular spaces and or microbleeds if somebody had a critical illness, but often we don't have pre-COVID MRIs to compare. But some research sequences have found gray matter volume alterations in the limbic, orbitofrontal, and secondary olfactory cortices that are present in long COVID patients and may change over time. And lastly, there is preliminary evidence that I show here on my slide of hypoperfusion in the frontal, parietal, and temporal cortices. Anybody who's seen these patients know that they're very symptomatic. So our question is why? What's going on? Why can't we see it on a normal standard clinical MRI? And how do we get at that? Because we can't biopsy the brain. So our study aims were focused not just on the individuals with neuropsychiatric PASC, but on the individuals with specifically cognitive impairment. And this is often, as we know, associated with fatigue, post-exertional malaise, and dysautonomia. So we investigated for vascular hypoperfusion in individuals with cognitive impairment compared to controls who had COVID but recovered fully and had no PASC. So first I'll go over our neuropsychological testing results. So like I said before, in this specific group, actually that our controls we compared to a bank of controls that were pre-pandemic, so they were all COVID negative controls, which was different than our MRI controls. So we use the WHO definition of PASC, and the procedures that we did were an RDoC criteria, which is an NIH well-rounded based protocol. So they completed questionnaires and tasks assessing cognitive domains, positive valence, mood domains, negative valence, mental health domains, motor, and social processing. So the demographics were very similar between the two groups, except in terms of race, ethnicity. And this, again, we're seeing people that are mostly non-hospitalized a year out from COVID who have cognitive impairment, fatigue, mood changes, and headache. So the NPASC group demonstrated deficits in language, memory, cognitive control, and perception significantly across the board, as well as significant differences worsen depression, anxiety, rumination, and apathy. And interestingly, we did not expect this. The NPASC group showed motor slowing in the non-dominant hand, so that'll become relevant a little later. Social processing was normal. So connecting that with our MRI perfusion imaging, we enrolled participants with just cognitive impairment and then prospectively enrolled controls who had had COVID and no PASC. We performed arterial spin labeling to measure parenchymal blood flows, cerebral blood flow, CBF. And we used the Harvard-Oxford Atlas regions to compare in this preliminary analysis. So our groups were comparable by age, female sex, and race. And starting with the preliminary results, this is a comparison of the NPASC group to the mean of the control. So the cerebral blood flow is the 0 line, little pointer, and then the red dots are our NPASC group. So here showed relatively decreased cerebral blood flow in the superior frontal gyrus, which is involved in working memory, spatial processing, and the non-dominant hemisphere, the right side, is involved in impulse control and modulates motor urgency. The post-central gyrus was affected as well, showing involvement of the primary somatosensory cortex and proprioception. The middle frontal gyrus was involved in the left hemisphere. The dominant is involved in literacy. And I know I can link these to every story I've heard from a patient. I can't sit down and read a book. I just can't do it. Superior parietal lobule is well involved. Attention and visual spatial perception. People get easily overwhelmed by stimuli, and they have poor ability to multitask and pay attention. In terms of the precentral gyrus, that's involved in the motor cortex. So in the left side, the precentral gyrus was involved, and that corresponds with the right hand non-dominant motor slowing. And then the angular gyrus. So these are all high-level cortical involvement in the parietal and frontal lobes. And a wide range of tasks are involved in the angular gyrus, including language, reading and comprehension, number processing, memory retrieval, complex systems. And lastly, the precuneus, which overlaps with the superior parietal lobe a little bit, and also has a wide range of tasks and networks that are involved in its function, and can also be involved in memory. And I know a lot of people have heard that as well. Patient comes in and says, I can't remember the conversation I had with my wife yesterday. And interestingly, there is, in migraine, a gender disease effect, specific effect between females and males, with females being more affected, which I found very interesting, given the female predominance of long COVID. And so for the right hemisphere, there's a lot of overlap. So bilateral hemisphere involvement, so the precentral gyrus, again, so the primary motor cortex, and then also the supramarginal gyrus, which was not involved on the left side. So that's involved in phonological processing, spoken and written language. A lot of times you'll hear patients, I lose track of my speaking in the middle of a sentence, I have word finding difficulty, the thought comes and then it's just gone. Again, the postcentral gyrus, so the primary somatosensory cortex, and also the lateral occipital cortex, which is involved in object recognition. And the superior parietal lobule, again, which overlaps with the precuneus, involved in attention and object manipulation. And the supplementary motor area as well, so it involves complex sequence task planning for movements and coordinating bilateral movements. So in conclusion, when comparing all of the regions, so the trends that I just showed you, this is the significant findings. So in the left hemisphere, the superior parietal lobule had significantly lower cerebral blood flow compared to our control group. So there's a clear trend of hypoperfusion in the left parietal cortex, which may lead to visual spatial deficits and episodic and semantic memory impairment. And the question I've thought about a lot is, why here? Why in this area, the frontal and parietal lobes? Are these hypermetabolic areas? Yes, it's the cortex, but there are more hypermetabolic areas, the hippocampi, the cerebellum as well. This is a vascular watershed region, so is the cerebral blood flow affected by the small vessel function in these areas? Is this anatomic damage? Not that we can tell, because the clinical MRIs are normal. We would expect to see scarring or neuronal death. Or is this a functional impairment that's reversible when you stop overusing your brain? We've obviously heard that from a lot of patients as they get cognitive crashing, cognitive fatigue, and they're just done after a certain point. And why the gender difference as well, which I haven't looked at in our subgroup, but I'm excited to, as we continue to enroll in this study and gather more participants. So the limitations are that it's preliminary. We have a small sample size currently. Ideally, we'd like to enroll 100 individuals to get sufficient power. And then there's no pre-pandemic imaging, which we hear a lot from other research outside of long COVID, but it's an inherent issue that we deal with in long COVID. So I'd like to acknowledge everyone again in our wonderful MRI Center at Yale for the support. Thank you.
Thank you very much. Really impressive image. Huh? Thank you. Is there any question? You have one question?
Is any treatment for this?
Any treatment for this? We're not there yet. No, we're preclinical, and so it's hard to say what treatment we could do right now, because we don't know why there's hypoperfusion. What is the vascular dysfunction going on that is leading to this mismatch of demand and, yeah.
It is an appeal too early to answer your question.
Yeah.
There will be clinical trial, but it's too early.
A question? Yes, please.
If you did have access to a biopsy brain, what would you look at?
That's an excellent question. I would look at the vessels. So I do really think that, we saw it early on in acute COVID, that the endotheliopathy is affecting the function and the permeability of the vessels. And so I think that this is also happening in the brain, that, the brain is an extremely fine-tuned organ, and any even slight dysfunction in the vessel diameter or reaction to metabolic demand is going to cause symptoms. And so I think that is really where we'll get some answers.
And based on your MRI, which region would be most interesting?
The parietal lobe. Yeah, definitely.
Question one? Yes.
A really quick question. Why is there gender differences? Why is there gender difference? In your last slide, you say it will be different.
Oh, just not in terms of, I haven't looked at the MRI data in gender differences, but I want to. I think that's an important part because there are gender differences in long COVID.
And do you have an idea why there will be? Immunity or?
I think so, possibly. We know this comes on right in that autoimmune window and persists and is associated with other autoimmune diseases. And a lot of my patients and participants have a positive ANA, suggesting possible underlying autoimmunity. So I suspect there may be a role in there.
Microphone 2.
There have been reports of phantom vessels in the brain, meaning missing capillaries. So I was wondering whether the type of MRI, functional MRI you did, would be sensitive to that, and could you attribute the hypoperfusion to a functional defect or a missing vessels?
That's an interesting question. The really tiny vessels in the brain are really difficult to see on MRI. Most of the best studies have been done on postmortem because you're able to do 7T, 11T for long times and get a really high definition. But you can't do that in a human. Even 7T is not tolerable for a long period of time. So missing vessels, I'm not sure how to interpret that, because missing could mean a stroke. You cut off the vessel and then it's not functioning anymore, or missing could be congenital. So I think some of the research sequences aim to get at that, and we are looking at the very small vessels. We're looking at the arterial, the venous, and even the lymphatic to get a sense of where in this pathway is the issue.
Do you think there is a link with the suspected portal of entry of the virus in the brain via the olfactory cliff? And it is suspected that then the virus spread in the base of the central nervous system and not in the cortex.
Such a good question. I get that question a lot from my patients too. And, as a neurologist who's seen patients with active viral infections in their brain, there's alterations in the cerebral spinal fluid, there's obvious inflammation. So I don't think there is active viral replication in the brain, except in very, like Dr. Sputic showed, rare cases in the acute infection when people are so ill that they have a leaking of the blood-brain barrier and there's active virus. But in terms of the orbital frontal cortex, I think Guillermo mentioned it earlier, but that there's dysfunction and death of the epithelium, and then the nerves become less healthy, and then the input to the orbital frontal cortex is interrupted. So I think that's mostly what's related, I think.
It's your hypothesis.
But we'll see.
Okay. So 2 very quick questions and quick answers.
Yes, can we say hypoperfusion is similar to hypometabolism or not?
I'm sorry, say that again?
Can we say hypoperfusion is similar to hypometabolism or not?
To hypometabolism.
Hypometabolism.
I'm sorry. Hypometabolism is similar to hypoperfusion.
No, yes.
Is
No,
that the
because
question?
you have
Okay.
seen the
So
work of Gage who see.
I think it's a mismatch of metabolism and perfusion. So you're having maybe an increase in that part of the brain. If in function and demand, you need more blood flow, and then there's a deficit there. So there's a mismatch of metabolism and perfusion. Yeah.
Thank you.
Yeah.
Yeah, hi, Lindsay, great talk. You don't have pre-COVID MRIs on people, but you may have people who get better over time. So do you see a change in the hypoperfusion in specific areas or overall improvement?
That is a great question and part of our planned study. So we want to do a volume and perfusion analysis, and our time point is going to be 1 and 2 years. So we haven't made it to the 2-year point yet, but it's actually coming up in the spring, and we look forward to looking at that analysis and seeing, because we do have the patients that get better, and we have the patients that don't. And so I think it's really important to study the participants and the patients who get better and understand why and how we can move our other patients into that group.
Okay. One last, the last one very quickly, and after.
Sure. I am an ophthalmologist, and we can see the retinal capillaries on OCT, and we see very, very clearly that there is a decrease in the capillary density of the retina, and there is no recruitment of capillary when there is an increase of the metabolism demand. So, and we can see that 43% of our patients have some area of ischemia. We don't know if it's closed, but it's not perfused, normally to be seen on OCT angiography. And
that's great.
I have a poster on
yeah, window into the brain, the eye.
Yes, it's a window of the
That's
brain.
really wonderful.
Maybe it's the same pathology.
Right, and
I don't know.
we could look at angiogenesis, what's going on with the growth of the vessels. That's interesting.
Okay. So we stop here. Thank you very much for your question, all of you. So I am very happy now to introduce for the last talk of the day, but before the poster, Professor Lyod Mulenga, who is coming from Lusaka, Zambia. The Professor Mulenga is Professor of Infectious Disease and Director of the Infectious Disease for the Ministry of Health in Zambia. He will present to us the presentation and factors associated with long COVID among individuals with post-acute COVID symptoms in Zambia. Thank you very much.
Thank you, and good evening. I came from Zambia to come and learn and possibly give hope to many people who are suffering, and especially that Africa is underrepresented in the burden of long COVID. My presentation is largely on the clinical presentation and epidemiology as well. We have done a number of studies in Africa around the seroprevalence. In Zambia, we did one of the surveys or the extent of COVID around the country. Then also early during the pandemic, we also saw that this was just 8 months into the pandemic, that people who suffered from COVID, they still had persistent symptoms as well. And we also had a high number of inflammatory markers as well associated with those persistent symptoms, and these were published. However, there are few countries that set up dedicated services for long COVID, and also we think that that is a gap. So because of those persistent symptoms which we saw among the patients that had COVID, we set up the first COVID-19 clinic. Then also we set up with support from the U.S. Center for Disease Control. We started having dedicated clinics for individuals with long COVID. And these clinics, we call them the post-acute COVID-19 or PAC-19 clinics. And because, again, of the nature of where we are, infectious diseases have a high burden, so we had to include bi-directional screening for TB, but also comorbidities as well, management in these PAC clinics. And we have 13 PAC-19 clinics in the country. We have the data recorded in REDCap for all the patients that we have seen in the PAC-19 clinics. We set up the guidelines, developed guidelines for management of those individuals who are presenting to these PAC-19 clinics. And WHO did recognize Zambia as a country focus where there was a manual dedicated to guiding healthcare workers on how to proceed with those individuals that may have long COVID. For the individuals who are presenting to our clinics, they needed to have at least 4 weeks of symptoms after acute care from COVID-19. And because of our low human resource capacity, most of our guidelines are protocolized, so we have to use protocols for a lot of nurses that we depend on, and also physician assistants in how to manage these individuals. And unfortunately, again, there are not many answers even up to now which we are giving to the people that are suffering from long COVID. So I will present what we analyzed from the data of the individuals that presented to these PAC-19 clinics from August 2020 to January 2023, which was in the REDCap. And we looked at, we did the logistic regression models for cross-section and also longitudinal assessments for those that had more than 2 visits. We also had to look at factors which are associated for what we defined as long COVID. This is our patient flow, a small number, 1,359, and the individuals that did present to our clinics. And of those, we had a huge number of them falling off care. And over time, you can see that from visit 1, where we had 548, we had 50 up to visit 50. A lot of people were not coming back for care, largely as well because we are not offering them much. Most of what we are offering them is counseling, and of course some were referred to specialized clinics as well. But we've continued giving service to those that are still in care. This is just the characteristics of the population. So those that were coming in the COVID-19, the clinics, the post-COVID clinics, we asked them with symptoms, largely fatigue, those that had cough, those that had brain fog, and those also that had difficulty in routine normal functions as well. And we classified those as having long COVID symptoms or no long COVID symptoms. And interesting as what has been presented here and many publications as well, we saw that there were more females who presented with symptoms suggestive of long COVID, a median age of 53, and we also had the elderly compared to the younger presenting with symptoms suggestive of long COVID. A lot of our patients were from the urban center in Lusaka, where we come from. And because of the Delta had a high number, this is where we had a high number of admissions as well. So overall, the whole population which we have among those with long COVID, still we have a number of individuals who had SARS-CoV-2 Delta variant compared to the Omicron, even though we had widespread number of new infections from Omicron more than Delta, in fact 3 times more than Delta. And the median time in terms of diagnosis when they presented to the facilities was 6 weeks for those that did present with long COVID symptoms. Again, we saw that those that had pre-existing comorbidities, hypertension, diabetes, obesity, cardiovascular disease as well, were the majority of those that had symptoms suggestive of long COVID. Then the vaccination. At least most of our individuals at this time, we are not vaccinated. That's why you see that even vaccination did not have a factor in how many people presented with long COVID. But we had those that had inpatients, those who were inpatients who had been admitted during acute COVID, presenting as the majority, and also hospitalization from 8 days length of stay was a factor as well. Severity of disease, which we defined for those that were on oxygen, those that received steroids, remdesivir, as a factor as well, where we saw majority of those individuals who had severe form of disease did present with long COVID. This is again showing the attendance by date of diagnosis. We see that again, that lighter blue one, that is the Delta variant. A number of individuals still presented with long COVID. They were infected with the Delta variant of SARS-CoV-2. In terms of time, we see that over time, the number of individuals that have been presenting with long COVID has reduced. This is by the symptoms. We have cough, and you can see over time again that decreasing, but fatigue is still a common feature among the patients that we have been seeing over time. Shortness of breath, brain fog as well is also another feature which has been persistent over time. So we see that you have symptoms for those that have had more than 4 visits. A number of them still have those symptoms which have persisted over time. So when we look at the hospitalized individuals who presented with long COVID, from the 919 individuals in the database, again, we see that the female were more. Then also when we look at the age group as well, the elderly, but interestingly as well was the pre-existing comorbidities. These were a risk factor among those who are hospitalized. Also, the length of stay as well was a major factor. Those that stayed for more than 8 days in hospital, and even those that had severe illness. Vaccination was not a major factor for long COVID development. But those that were referred to the specialist services, and again, these were the sicker people, so they were likely to have long COVID as well. For when we combined those hospitalized and also non-hospitalized, still it's the same factors of comorbidities, hospitalization, which were dominant as risk factors in this population. So in summary here, really we demonstrated that even in a resource limited setting, it's feasible to set up a clinic dedicated to long COVID, and that there are symptoms which were varied and also over there happening over time. And there are features which are suggestive of severe disease, longer hospital stay, use of steroids, and IV antivirals as well, including the comorbidities which appeared to be risk factors for both hospitalized and also non-hospitalized patients as well. And we believe that moving forward, integrating these services into routine care would improve access. And we have even set up now virtual clinics for some of the individuals that we are receiving. Now, we have limitations to this because only the patients who attended the PAC-19 clinics, and these represented just less than 1% of the entire confirmed cases of COVID-19. Then also, there was a self-report, and so you cannot rule out any self-saving bias as well. And we utilized the routinely collected data, so we had some missing information, and the patients were not retested for SARS-CoV-2, so we could not rule out if there was any reinfection. But those that did present over time with persistent symptoms, which were suggestive of acute COVID, we did retest them as well. We, in the next steps, are combining efforts with other groups from South America, from the UK, and also from the US and Canada on trying to categorize any subphenotypes, because we see that especially South America and also Africa is underrepresented in many of the studies. We want to see if there are any differences looking at the plasma proteins and also the metabolites as well. Thank you so much.
Thanks a lot for your very nice talk, and thanks to remind us that long COVID is a global issue, and not only in US or Europe. I will have one very short question. How did you get to catch the long COVID patient very quickly? Because in our studies, it's often very long to catch the patient, and your time of long COVID since COVID diagnosis, it's a few weeks. In our experience in France, it's almost 1 year, for example. So how did you set up this, your information? Yeah.
So really from the first case that we saw in March of 2020, we immediately set up clinics for us for patients who were recovering from acute COVID. Mm-hmm. And immediately after that, we realized that there were individuals who had persistent symptoms. And together, with the changes in the definition, no unified definition, we came up with all those that had persistent symptoms beyond 4 to 6 weeks. We were taking care of them and following them up longitudinally.
Okay, thank you. So, Roger.
To ask you two questions, so congratulations for your presentation. One is, as a responsible from the Ministry of Health, you have to decide to engage in long COVID care in a setting where you have also a lot of other priorities. And where do you rank, let's say, long COVID within the many other problems that you might have, like TB or others? Is it the prime, second, third? And I'm not thinking about Zambia, actually. I'm thinking about our own governments that tend to underrank long COVID. And then the second question is more about also it has been described post-Ebola syndrome. How, in your experience, how different it is from what patients surviving Ebola are having based on your experience? Thank you.
Thank you. Really, it's up to the program managers. I am the director for infectious diseases, and I also practice. And I have a number of diseases I'm responsible for in the country, of which long COVID, in fact, is not considered by many as a high priority. But because I see the burden when I do clinical rounds in the hospital, I've been able to bring it up, and we have even a dedicated budget towards long COVID. We've been allowed by the authorities, by the policymakers, meanwhile politicians, that as long as we can leave certain people behind without proper health care, then we are not achieving universal health care. Many governments would not consider this as high priority, but it should be really voices coming up and recognizing that a lot of diseases in Africa, they are not a priority because we have so many competing demands. But as long as we have people that are suffering, we need to have voices towards that. Unfortunately, fortunately for Zambia, we do not have Ebola. We've never recorded any case of Ebola, but our neighboring country, DRC, they report the case of Ebola, so we have not had any experience, and also identifying the differences with the two. Thank you.
Plenty of questions.
Thank you very much, and congratulations. It's really impressive data. It's always exciting to see data coming from Africa because there's really paucity of data on long COVID from Africa. So the question I have relates to the interaction between long COVID and other co-infections such as HIV, hepatitis B, hepatitis C, TB. I'm wondering whether you see any interaction, and I mean, in advanced countries, you see comorbidities such as hypertension, diabetes, obesity. I'm wondering if there's any interaction or relationship between long COVID and co-infections.
Thank you so much. Again, like many countries, we have a high number of infectious diseases in our region. TB is the number one disease that we are really scared of and which we saw. In fact, when you look at those comorbidities, diabetes, hypertension, they were lower, but TB, we have about 17% of those that have long COVID. In the bidirectional screening, you find that they also have TB. So some of the symptoms like persistent cough may be attributed to tuberculosis, and you need to rule out tuberculosis. So in our area, we screen every patient who comes in with symptoms of those who have long COVID, we screen for TB. And also those that have TB, we also screen for COVID as well. That is, TB is a major factor. Influenza, we've also started screening for influenza and also part of the post-viral syndrome from influenza as well, which can be another area. But we do not see as much influenza as COVID. The diabetes, hypertension are the other high comorbidities besides the TB. So in our area, it's tuberculosis, which is of a high burden.
The last question? Yes?
That was a fantastic talk. Thank you so much for sharing your data. I was struck when you showed the types of symptoms, the frequency of symptoms that your participants are reporting, that there's a very low percentage of those reporting forgetfulness or memory problems. And I'm wondering, one possibility is that it's a different genetic background and there's other reasons why there's less of that particular symptom in the population that you're reporting on, or do you think it has something to do with the symptoms that are reported by people, or something about the surveys or the way you were getting the symptoms? Because it's a striking difference from a lot of the other data that we've seen.
I think it's the way that we are getting the symptoms. When you, especially that this is routine data. So when we have followed up these patients and in the virtual clinics, we have now started calling from our database all the individuals that had COVID, find out if they have symptoms suggestive of long COVID. And we are seeing that forgetfulness is a big problem. So it's one thing which many of our people think, oh, maybe it's something minor, and they don't bring it up. But when you probe, you find that it's a major problem.
Right. Thank you.
Thank you, Dr. Mulenga.
Thank you.
So, see you next year, I hope. So thank you very much for all the speakers and the audience for your participation. So we can move to the quietly to the poster session. We have 1 hour to look at poster and discuss. Want to add?
Thank you, Bob. Thank you very much.